Welcome to the 2025 International LGMD Conference. I'm so glad we're here today in Orlando, Florida to be together, and this conference is going to be a wonderful time. I want to address a few things this morning. Earlier we did have a technical difficulty with the presentation from Sarepta. It is available right now that you can download it on our streaming site, but we are actually going to stream it again and right before lunch. So it will be available. We apologize, there was streaming difficulties because this was added yesterday. So apologies. So you will be able to see that for our streaming audience. At this time, I also want to just talk to you just for a moment about the difficult process of drug development. We're all reeling from the last 2 days of it just seems like daily bad news for our community. And it's been difficult, and we've all struggled to try to make sense of those things. I want to just share that drug development is a challenge. It's difficult, and all rare diseases do struggle with this. We, as a community, are going to go through some things, and I want to just emphasize that we have lots of hope still. We have lots of companies that are entering into this space. We have companies that are as well staying in this space, and there are researchers working on things right now. Even right now, there are people communicating, and there are many things that are going behind the scenes so that these drug development programs continue. So I want to give everybody encouragement and a lot of hope. This is not the end. This is a turning point for our community, and it's going to be positive. And I just wanted to say that before we start off this conference today. I just think it's important that we all unite together, and we're all part of this big family of Limb-Girdle Muscular Dystrophy, and I'm so thankful that you're here. I want to kind of go through some housekeeping before we start our first session. And number one, we have some clinical study opportunities that are going on right now at the conference. And you can actually participate as a volunteer. They're occurring down in Segura 1 through 4, right where we had our reception last night. The first one I want to talk to you about that is available to you is with Lindsay Alfano and her team, and they're doing some PT assessments, and this is important information where they're going to be assessing different limb girdles and to learn more about the natural history and the course of the disease. So that's going to happen downstairs. If you would like to participate, go right on downstairs at the breaks, and during some of the sessions, if you want to break and go down there, and that team will assess you down in Segura 1 through 4. We also have Dr. Peter King and his team as well, and they're going to be looking for unknown LGMDs, new subtypes, and they're going to be doing sequencing downstairs, and it's a saliva cheek swab, so it's not any blood work. You don't have to worry about that. If you would like to participate in that, if you have an unknown limb girdle and you would like to participate in that research, again, that's voluntary, but we would love for you to be a part of that as well. I also want to share about Ask the Experts. You have an opportunity during the conference to ask our experts. We have 2 cards that were put into your bags at registration. We also have additional cards out at the speak table. Please fill those cards out and then put them back in this green box on the Speak Foundation vendor table. Those are going to be answered today. So if you would like to participate and ask our experts, we have 1 session with all of our clinicians. We have another one with our genetic counselors. So these are 2 important things that I think you have a great opportunity today to get your questions in front of our best experts. So take advantage of that. I also want to explain about Limb-Girdle Muscular Dystrophy Day on the Hill. We're talking about advocacy. Our community is really good at advocacy. You can participate in Hill Day just by going out to the speak table. There's a QR code and you can immediately sign up. It's September 9th. The deadline to sign up to become a delegate is July 22nd. We all participated in Hill Day last year. It was wonderful, and we were all advocates on the Hill. And so many things that we're doing matter for our community. And I want you to be able to hear on Hill Day what we can do to make a big difference. And then special thanks. I want to just take a second and express our deep gratitude to our 2025 LGMD Conference leadership team of organizations. These organizations and our Limb-Girdle community were vital throughout the planning process for our conference. As I recognize your organization, if you're able to, please stand. I want to recognize the 2D Foundation. If y'all would give them a round of applause. I want to recognize Cure LGMD 2I. I want to recognize the Jane Foundation. I want to recognize Coalition to Cure Campaign 3. And last, we want to recognize our LGMD Awareness Foundation. We're also specially recognizing Dr. J.P. Laurent. Dr. Laura Rufibach. Dr. Jen Levy. And Dr. Brad Williams. We will have our scientific poster session this afternoon at 5:30, and that'll be a cocktail reception in this room that you're all invited to. This is the first time we've had poster session, and we're excited about that. So thank you all who have presented posters. We're excited to see you tonight, and we will be giving out our awards this evening at the poster session. Now, I'd like to turn to our session presenters, and we've got our first session with Dr. Matt Wickland. He'll be presenting, and then Dr. Volker Straub and Meredith James will also be presenting in session one. Dr. Matt Wickland is our neurologist and professor at the University of Texas Health Science Center and director of the UT Health MDA Care Center. He'll be presenting first, what should patients know to get productive clinical care? Please welcome Dr. Matt Wickland.
Well, hello. It's a pleasure to be here. This is the fourth of these. And I want to pause before we get started. And what I want to pause is for 10 seconds, and I just want you to look around the room. And I'll tell you what I see. I see patients. I see family members. I see advocacy groups. I see researchers. I see providers, and I see industry groups, and they're all working together for one thing, and that's to try to help make the lives of patients with LGMD better. So, all right, my job is to tell you about 10 topics associated with LGMDs that ultimately will help you know your disorder and get better care. So, one, many of these limb-girdle muscular dystrophies look alike, but they're not the same. So, this is 5 young adults, and they all have limb-girdle muscular dystrophies. They all look roughly the same, but they're not. These are 5 different genetic subtypes. So, it's also important to know, even in your particular genetic subtype, not everybody is the same. And so this is an example where we have a young lady that has a limb-girdle pattern of weakness with FKRP, and yet there also is an infant that also was affected at a very young age. Additionally, even within family members, there can be marked difference. So I've talked to a couple of you earlier, and you talked about, oh, well, my brother is more or less affected. And the answer is, that's true. And this was a fun article from 2013. It's in a slightly different genetic muscle disease, Pompe disease, late onset Pompe disease. That usually has onset about 5 to 50 years of age, so it's a broad range like some of the LGMDs have. But what they looked at is 22 sibling pairs, so brothers, sisters, brother, brother, sister, sister. And so they have 50% the same genes, and then the question was really, what is the difference in the age of onset? And you would go, if it's 20 and 22, you'd go, yeah, okay, I get that. But the average difference was 9 years, and it was as much as 31 years difference. So that's like you got disease at 20, and your older brother didn't get it till 51. So that's huge. That's the variability that we see. There are a variety of different proteins and pathogenic mechanisms involved in the limb-girdle muscular dystrophies. So this figure I've had for a number of years, and the reason I like it is because it says that if you have a gene that produces a protein that is anywhere in or near a muscle fiber, it can cause a limb-girdle pattern of weakness, a limb-girdle muscular dystrophy. So if we go from the top on down, you can see there are disorders of the extracellular matrix. Those are the collagenopathies. There are disorders in that extracellular space, and so those are disorders of alpha-dystroglycan. In the middle there, you have the sarcolemma, or the muscle membrane, and so there are disorders that are structural or for repair that are involved. There are disorders on the bottom left there of the contractile proteins, and there are disorders that are affecting either the sarcoplasm, which is in the intracellular space, or even in the nuclear envelope proteins. So anywhere in and around a muscle fiber can cause a limb-girdle muscular dystrophy. The other thing is that if you look at the limb-girdle muscular dystrophies, they overlap with a lot of other disorders. So that can be distal muscular dystrophies, congenital muscular dystrophies, congenital myopathies. So these Venn diagrams overlap. So how do we define a limb-girdle muscular dystrophy? And as some of you may know, the way we call them has changed a little bit. So let's talk through that. So in 2017, we had a meeting. Actually, our European colleagues had a meeting, and they helped solve a problem that we had. And so first, they defined the limb-girdle muscular dystrophies. And there were key components here, which are that they're genetically inherited conditions that primarily affect skeletal muscle. They lead to progressive, predominantly proximal weakness. That means the hip girdle and the shoulders. And they cause loss of muscle fibers. And then to be classified as a limb-girdle muscular dystrophy, it had to be described in more than one family, because at the time of the writing of this, there were certain cases that in a single family had been reported, but it has to be in more than one. Individuals have to be able to walk independently at some time in their life. They have elevated muscle enzyme levels. They have degenerative changes on muscle imaging. And then at some point in their disease course, they'll have a dystrophic pattern on muscle biopsy if a muscle biopsy is done. So how do we talk about the limb-girdle muscular dystrophies? Because you've heard all these different names, LGMD, and then letters and numbers. So in the old nomenclature, we had LGMD for limb-girdle muscular dystrophy, 1 for dominant, 2 for recessive. And then there was a letter that was added on to that that denoted the order in which the chromosomal locus was delineated. The problem is that we ran out of letters. So we got to Z. And then the question is, what do we do? And so the logical thing to do is just switch it around. And so now we name them as LGMD for limb-girdle muscular dystrophy, R for recessive, D for dominant, and then a number for the order in which the gene was discovered. And we can't run out of numbers. They're infinite numbers, so we can have as many of these. Well, there are only 20-some thousand genes, so we'll not run out of numbers. And so now, what used to be LGMD2A, which is for calpainopathy, now becomes LGMD-R1 calpain-3 related. This is just the dominantly inherited LGMDs. This is the recessively inherited. This is what I show my residents and say they get 10 seconds, and then we'll have a quiz. All right. Okay, let's talk about how common are the limb-girdle muscular dystrophies, and especially in relation to one another. So, what is the relative prevalence? So, from 2015 to 2017, there was a sponsored genetic testing program that had 35 genes. And in the United States, there were 4,656 patients who had this testing. And this is where we learned that as you go from the left to the right on this bar graph, that calpainopathies, so LGMD-R1, is the most common, followed by dysferlinopathies, then the collagen 6 disorders, the sarcoglycanopathies, and Octamin 5 FKRP. So our colleagues over in Europe did the very same thing, and they found very similar results. So they had 1,001 patients, and of those, calpain-3 was the most prevalent, followed by dysferlin, and Octamin 5, titin, and then if you look at the collagen genes and you look at the sarcoglycans and add those together, they also are in that same prevalence. And our South American colleagues have also chimed in. And so if you're in Brazil, calpainopathies are more prevalent than dysferlinopathies. If you're just over the mountains and you're in Chile, then dysferlinopathies are slightly more common than calpainopathies. And then finally, I know he's here because I saw him last night, from Monkel Leck's group. He did a very elegant study where he looked at the BROAD database, that's a genetic database, and what he did is he said, of the known pathogenic variants for the limb-girdle muscular dystrophies, how often do we see them in this database? And then you can calculate what is the likelihood that they'll meet up in a human, and then you'll get somebody with that disease. And so when he did this, what he found is that going from top to bottom, FKRP, dysferlin, and calpainopathy were the most prevalent. But interestingly, what he found is that an Octamin 5 genetically may be the most common, but the reason that we don't see as many LGMD 2L, R12, and octaminopathy patients is because they tend to have onset of disease usually in the 20s, 30s, 40s, and so many of them may be genetically an LGMD, but they have not manifested yet. And then finally, those were all relative prevalences. The question is, what is the real prevalence? And the answer is, again, out of Newcastle, back in the late 2000s, they actually looked at their catchment area, and they figured that there were 2.3 patients with LGMD per 100,000. And the same thing was done in the Netherlands, 1.4. But if you go, I don't know if I have a back arrow, but if you go back and look at that and add up the numbers in Monkel's data, the answer is it should be more than that. And so probably there are patients that are not yet ascertained. So here in the US, we kind of figure there are about 3 to 10 per 100,000 in the United States. All right, how do you make a diagnosis of LGMD? Nowadays, this is so different than it was a decade ago. So I'm going to walk you through what I teach all of our trainees. If a patient walks into you and you think that they have a genetic muscle disease, the next thing you do is you do genetic testing. You do panel, exome, or genome sequencing, and that's what you can do here in the United States. And we have an advantage because we have 2 genetic testing programs, one with 66 genes and one with 211 genes, that cover the limb-girdle muscular dystrophies, and they're sponsored by a company, so there's no cost to the patient. If you get the answer, you're done. But if you don't, then we circle back, and we do all the stuff we used to do, which is do labs, EMGs, imaging, biopsies, and other testing. And sometimes that'll help answer the question. If that doesn't give us the answer, we can go on to more complicated testing. But eventually, in the next 5 to 10 years, I think we're going to be at this next stage, which is genome sequencing. So we'll do that at birth. And that way, you'll know your whole genetic makeup at the time that your infant is born. And the reason that's relevant is the FDA and the NIH are on board with this concept because there's no good way to do precision medicine unless you know what patients have. And if we know what they have before they manifest disease, theoretically you can mitigate disease before it ever occurs. So, what if your genetic testing, despite all that you've tried to do, didn't give you an answer? This is actually very relevant. You should maybe make sure that it is a genetic disorder. And this has been reported over the last decade. There are patients with acquired disorders that are autoimmune, that over 4, 7, 10 years slowly progress. But these are treatable. So if you have this, you should be diagnosed with this, and then you should get treated because you can get better. You should also make sure you don't have a different genetic muscle disease. So it's not inoften that someone will come in either with Becker muscular dystrophy or facioscapulohumeral muscular dystrophy, and those require different genetic testing for some of those. If you haven't had genome sequencing, you move towards genome sequencing. You can consider multigenic forms of inheritance. There are at least 2 disorders in muscle disease that require changes in both genes, 2 separate genes to develop disease. And then finally, you can just look at what else could be going on with the patient and do further testing. An example that I have of a young man about almost a decade ago, he had what we thought was a change in this gene called VCP, which leads to a muscle disease, but it also has a bone disease. And so we tested to see if he had evidence for the bone disease, and he did. And then we did an MRI, and his MRI is the one on the left, and the reference image is the one on the right. I put it in his chart. I showed him his chart, and I said, "What do you think?" And he goes, "Oh, they look almost exactly alike." And I go, "Yes, they do." And so we diagnosed him with this disorder 2 years before it was known to be a pathogenic variant. All right, number 6. There is sometimes other organ system involvement in LGMDs, and that's very relevant for you all. So some do, some don't. And so there is no or minimal cardiac and respiratory involvement in these disorders, and the asterisk is next to LGMD R1 calpain 3 because probably 10 to 15% of patients will eventually need non-invasive ventilation later in life. But these other disorders, they can have early and prominent involvement of the heart and the respiratory muscles. So keep that in mind. Number 7, what is optimal medical care? I put this together a week ago, but it's very timely. Oh, there are no FDA or EMA approved therapeutics for LGMDs. Yeah, that's really good this morning, isn't it? All right, but this is what we do have. We do know that multidisciplinary care is an improvement in the quality of life of patients that have LGMDs. So if you look at this diagram, patient is in the middle. You have therapy services that help out. You have providers that help out. And so if you can get to where you can be seen in a multidisciplinary clinic, I think that's very helpful. This is what our multidisciplinary care clinic looked like. And so on the left side, you'll see there are a number of different providers that are involved in the care. This is also relevant for if patients travel from a ways away. It's always frustrating to travel for 2 or 3 hours, be seen, and then they say, well, why don't you come back next week? Well, you go, that's a long way to travel each way. So if we can do it all in one fell swoop, that's better. On the right side, we couldn't get everybody into the same general clinic space, and so we made arrangements with other groups, and specifically I'll talk about pulmonary, sleep medicine, and cardiology, so that they had temporally associated appointments so our patients could come, be seen, and then they simply go to a different floor in the hospital and they can be seen there. I also want to emphasize on this that it says neuromuscular pulmonologist, neuromuscular sleep specialist, and cardiomyologist. And that's because most pulmonologists and cardiologists, they don't understand genetic muscle disease. So if you can find somebody that does, or if your clinic knows somebody that does, that's who you should be seeing. All right, number 8, where should you get your care? And at the top it says, if you can do so, get it at a center of excellence or a center that has expertise in LGMDs. And then right below that it says, or go to somewhere where at least they've heard of LGMDs. So that's better than probably most of your experience. All right. I'm going to talk about Newcastle from my colleague over here because 25 years ago in England, the government did a very useful thing. For 4 disorders, one of which was the LGMDs, they sponsored centers of excellence. And so if you do go to the John Walton Muscular Dystrophy Research Center, you will get exceptional care because that's what they do. They do LGMDs there. Here in the United States, I will say, and also, as you can see here, Canada, Italy, England, other parts of Europe, there are Muscular Dystrophy Association or similar organizations that have care centers. And those care centers, they should at least have heard of LGMDs, or they should at least be able to look up how to take care of those. And then at the bottom, you can go to advocacy groups and organizations for whatever your genetic subtype is and say, hey, is there somebody in my area, my region, that is reasonable that knows what to do? And the answer is, they should be able to tell you who that is. Sorry, pressure's on. Okay, all right. I'm a little bit biased in that this is a research consortium that we put together, but this is a group of sites across the United States and in Europe and in New Zealand. They all do research on the limb-girdle muscular dystrophies, and they all should have someone there that has knowledge about and expertise in the limb-girdle muscular dystrophies. Number 9, neuromuscular specialists are starting to think like oncologists. All right. If there are sports fans out there, you know that earlier this week was the Major League All-Star Game. And this game ended in a 6-6 tie between the American and National Leagues. And they have a new way of deciding this. They do a home run derby. And so you also may know that this guy, Kyle Schwarber, he got to the plate, and each of the players got 3 pitches. He got 3 pitches, and he hit all 3 out of the ballpark, winning the game for the National League. So why is that relevant? Because in what we do for the limb-girdle muscular dystrophies, we have been trying to hit home runs. And in neuromuscular disease, we've done that once. So Zolgensma, which is gene therapy for SMA kids, this is not quite perfect, but it's really good. Really, really good. That's a home run. But we really don't have a lot of home runs. And again, maybe fitting, I wrote this before today. Other examples would be nowadays in like Duchenne muscular dystrophy. And in Duchenne, someone may have been on an ASO therapy and then gotten gene therapy, or gene therapy and then on an ASO therapy, but they've also been on corticosteroids. They're also maybe on an antifibrotic, and maybe they're also on something else. So the whole point is, just as when somebody gets cancer and they get 3-drug chemotherapy plus radiation therapy plus surgery plus post-care, we need to be taking care of multiple different aspects of how to take care of your limb-girdle muscular dystrophy. So for dysferlinopathy, it looks something like this. There are multiple different avenues at which there are drugs in development for different pathways. All right, number 10, again, I'm biased in this. Research, I'm going to talk a little bit about it, but I think research does help move you towards better clinical care. If you talk about how do drugs come to market, there is preclinical research, that's work in animals and in cells. There is clinical research, that's natural history studies, physical assessments, biomarkers. There are clinical trials where there is a drug that is run through the trial. And then our hope is that you have a launch of a new drug. There are phases of clinical trials. So once you get to that drug phase, so in that phase 1 to 6 months, usually it doesn't take long. And this is where it's all about safety in this, and it's usually done in either norms or minimally affected people. And I tell my patients that's where they want to find out, do you grow a foot out of your head when you take this drug? And the answer is, hopefully no. Phase 2 is slightly bigger, but phase 2 generally is all about safety, but they also start looking at efficacy somewhat. And then phase 3 or phase 2/3 are these registrational studies where it looks at, will the drug be effective and safe and can go to market? So I'm going to end by saying participation in research is one of the best means to obtain ongoing, productive, state-of-the-art clinical care, and usually you'll be doing that at a center that knows something about LGMDs. All right, thank you for attention, and have a great rest of the conference.
I'm going to introduce you now. Next, we welcome Dr. Volker Straub and Dr. Meredith James to present on developing formal standards of care for LGMD. Dr. Straub is director of the John Walton Muscular Dystrophy Research Center and deputy dean at Newcastle University in the UK. Dr. James is a neuromuscular physiotherapist and honorary clinical senior lecturer at Newcastle University. Please welcome Dr. Straub, followed by Dr. James.
Thank you very much, Kat, for the kind introduction. I would actually like to thank the Speak Foundation for kindly inviting us across the Atlantic to participate in this international conference, and it's great to see that there are so many patients, families, caregivers here, because it's all about a community, as Kat already mentioned. Now, I think throughout the day you will probably hear some repetitive messages, and I think that's good, because this way you remember them. First of all, I would like to make a disclosure statement. I do work with a lot of colleagues in industry together as well and get funded by them, and I think that's good because we need to work together. I don't think that for my talk there's any clear conflict of interest. I would also like to disclose that all the slides have been made by myself and not by AI in this case. Now, Matt Wickland very kindly mentioned Newcastle and the John Walton Muscular Dystrophy Research Center, and that we have a highly specialized service. So Newcastle upon Tyne is in the northeast of England, and the National Health System in the UK felt that for rare diseases it is really important to build expertise, and they assigned services to certain centers. And in Newcastle, we are assigned the National Service for Diagnostics and for Advice for patients with Limb-Girdle Muscular Dystrophy. And this is basically based on the long-standing tradition in Limb-Girdle Muscular Dystrophy research and care in Newcastle. It was actually a famous neurologist, John Walton, who first defined the Limb-Girdle Muscular Dystrophy as a separate entity when he compared this to other muscle diseases. Now, in this service where patients come from all over the UK with limb-girdle weakness, the questions that they would like to get answered is, if this is a genetic disease, what does it mean for my family? And many adults with genetic muscle diseases are more worried about their kids and their grandchildren than themselves. But of course, everyone who gets this diagnosis also wants to know, well, what will this mean for my future? what is the prognosis of the disease, and then what can you do about it? So these are the three questions that ideally, as a clinician, I would like to give answers to. But first of all, it is important that you have a diagnosis. And Dr. Wiklund already showed you how complex it is and how many diseases there are with different modes of inheritance, the recessive and the dominant ones. There are currently 31 different forms of limb-girdle muscular dystrophies, and there might be more than this, very rare. But the vast majority of patients, over 90%, should get a diagnosis if it's a genetic muscle disease. We have just actually across expert centers published a paper on the genetic diagnosis and how to interpret results as well. So it was great to hear that Dr. Kang offers genetic testing for those of you here who don't have a diagnosis yet, because if you want a clinician to provide answers to those three questions that I mentioned, you need to have a diagnosis. With the diagnosis, we can offer genetic counseling. With the diagnosis, we should be in a position to at least make statements about the prognosis. And with treatments, Dr. Wiklund already said, well, unfortunately, there is currently nothing available. So for the genetic counseling, I think we can do this. With the prognosis, it depends a bit. For an individual case, an individual patient to learn, well, how will my disease be in 10 years? It might be difficult depending on the diagnosis. None of us has a crystal ball to address this specifically, and for the treatments, it looks currently a bit dire that there's nothing that we can prescribe. But even though this looks a bit depressing, actually there's also good news. And that's an important message for all of you. So what is the good news? Now, I already mentioned having a diagnosis will allow us, and we have done this over the past decades, describe the clinical features, share this with colleagues. We have now established assessment methods for patients with limb-girdle muscular dystrophy so we can monitor their progression, which allows us also to then make prognostic predictions and provide advice to the three questions that I pointed out. Now, ideally, we actually have a good understanding about the natural history of these diseases. And if we do have natural history data, we can often also use it as an incentive for pharmaceutical companies, for example, to invest into clinical trials. Now, the natural history studies, these are basically studies that inform clinicians about the long-term cause of these diseases. And the graphic shows you where it says function over time, that the disease course for an individual patient might look different. For some of them, it might be more progressive. Not everyone with a limb-girdle muscular dystrophy may use a wheelchair, others will. These are important questions, of course, that patients want to know at their diagnosis. There have been natural history studies in those diseases that are more common, and Dr. Wiklund mentioned that for LGMD R1, calpain, and LGMD R2 for dysferlin, also for LGMD R9 with FKRP. Now, there have been studies, and there are more and more studies, which is fantastic. Sometimes they are very long. I mean, if you look at this slide, you see that there's a study that's called COS, a clinical outcome study in dysferlinopathy that's generously funded by the Jane Foundation, where we have collected data for 10 years now. But we are continuing this because there are also new ways to assess patients that weren't available 10 years ago. As you know, there are now many of the watches that we wear that can collect data as well. So these are activity monitors. So natural history studies often continue beyond just a certain period of time because also assessment methods change. Now, I just want to briefly show this fairly complex slide because it summarizes the challenges of clinical trials. And Kat Bryan, in her introductory remarks, did mention that it is very difficult to do clinical trials. And it's a long journey. And Dr. Wickland mentioned the 3 clinical phases, phase 1, 2, and 3. But before you get there, you also have a few years often of a discovery phase where you identify a compound and then you have to test it. Often you use animal models as well. So you test it in the laboratory. And then you want to make sure that what you think may work in the laboratory is actually translated into benefit for patients. So you need to start your clinical trials. And it's an uphill journey, which is also getting more and more expensive. And what this graph shows you is that it can take up to 15 years before you may have what Matt called a home run. But often, these trials also show that maybe there isn't as much efficacy. You still have to, go through this entire journey as well. It also is costing a lot of money, and so you have to be fairly committed to say, well, we bite the bullet and we'll still do it the whole way. Why is this also important? Well, it's also important you can actually only do clinical trials if there is an understanding about what is the standard of care for all those that participate in trials, because there needs to be an equal playing field. You need to have a group that can be compared, and then you test the drug. So, but most importantly for all of you who are affected by limb-girdle muscular dystrophies, individuals with limb-girdle muscular dystrophy should be offered the best informed treatment. And treatment doesn't always mean it needs to be a drug. We heard that the heart can be affected. There are very good drugs for cardio or heart protection. That breathing can be affected. Well, it's not a drug, it's a ventilator that you may need then. So there are treatment options. Physiotherapy is something else, and Meredith will cover some of this. Now, it's also important that we want to make sure that care standards, of course, are accessible, ideally, for all patients and not just in certain countries or areas. So we need to have international agreement on those. There is now actually a guide for families as well, and there will be a symposium at lunchtime organized by TreatMD, and I will actually introduce this guide for families. This will be a worldwide launch for a family guide for limb-girdle muscular dystrophies. Now, when it comes to care standards and guidelines, there are quite a number of different aspects, from the diagnosis and genetic testing to then looking at your motor function, respiratory function, so breathing, cardiac function. Many patients want to know, what about nutrition? It was pointed out by Dr. Wickland as well that there are even some diseases where bone health can be a big issue, but this could also be relevant for many of the limb-girdle muscular dystrophies. What about pregnancies? What about mental well-being? What if you need a surgery? Are there special things that doctors need to know about? What about vaccinations? These are just some of the areas around care that you need to know about. Now, Kat Bryan already mentioned there will be a double act. So this was a bit of an introduction from my side to you about the concept, why we need standards of care. And my colleague Meredith James will now go into some of these aspects in more detail. So thank you very much for your attention.
Good morning, everyone, and thank you again to Kat and the meeting organisers for extending the invitation across the pond for us to come and see everybody at the conference today. That's my disclosure statement. I also work with a number of pharmaceutical companies advising on how we can best measure and represent the lived experience of individuals with limb-girdle, and those monies are paid to Newcastle University. Louder? I'm normally told to be a little bit quieter as the Australian in the room, so I will be quite happy to speak much louder. Can everyone up the back hear me now? Oh, good. Thank you for the thumbs up. Super helpful. So as Volker said, my part of this presentation is a little bit more about the practicalities of managing and living with limb-girdle muscular dystrophy, and how standards of care and the family guide can help empower you as you are the experts in your condition. I know a lot of you will come to specialist centres, and then others of you will be just seen perhaps by a general neurologist who may have never ever treated another patient with limb-girdle muscular dystrophy. And so when we look at standards of care and care guidelines, this is to help you be able to go to your local care providers to say, actually, I've got this, and these are some of the things that the experts recommend, so that you can advocate for your own care. When we look at advice on surgery and emergency care, emergencies rarely happen at your local hospital when you're at home. It might be when you're away. It might be when you're some distance from your muscle team. Your muscle team and an emergency department might not actually be in the same institution. So what sort of things do you need to know? If there's an emergency, it's really helpful if you are able to contact your neuromuscular team so that they can be involved with the emergency physicians to understand what might be the best plan of management. If there's planned surgery, whether it's orthopaedic surgery or just general surgery, it's really also important that you make your neuromuscular team, your physio, your OT, your neuromuscular physician, aware of this surgery so that we can work together with your surgical team and your anaesthetic team to make sure that all the right things are in place. It may be that the hospital doesn't have the specialist moving equipment you need if you need assistance within your bed mobility or your transfers. I think there's a really important thing that if you do use a ventilator overnight, that you travel with that and have that available, or that you understand what your recent lung function tests might look like, so that if there is any risk of being laid out flat on an operating table for a number of hours, that the anaesthetist or the anesthesiologist is aware of those risk factors. As Volker said, I'm a physical therapist or a physiotherapist, depending on where you are in the world. And we have, in the absence of disease-modifying treatments, there is a lot of things that we can do working with you to try and maximise your independence and maximise your function. And so on that list, there is exercise, and this does not mean going to the gym necessarily. Whilst that might be suitable for some people, just your daily activity and looking at your activity levels and how you can be best supported to move and do something that you enjoy, because exercise and activity, if it's not something you love, no one's going to keep it doing it. And finding the right thing for you with your level of ability is important. Range of motion. We know in some limb-girdle muscular dystrophies that losing the ability to actively move your joint yourself means that we need to make sure that we've got other methods to keep your joints moving and supple. Sometimes ankle contractures, so where you need to go up on your tiptoes, can make walking and balance really difficult. So it's important that your care team is keeping an eye on those muscles that are prone to getting tight. And then further to that, we can look at different splints that can assist walking. And I know there's a number of you in the room today that are utilising ankle-foot orthosis to help your mobility and help your balance and make walking a little bit easier. Mobility aids. This is a difficult discussion. At no stage ever in a consultation with a patient is anybody wanting to necessarily accept that we may say that now might be a good time to consider using a walking pole, hiking sticks, maybe thinking about a wheelchair and a mobility scooter. And I'm sorry that those are very difficult decisions to have to make as a community if you need to use a mobility aid. The idea of introducing a mobility aid is to try and maximise your function and your independence so that you can enjoy those longer days out and not use all your energy and mental fatigue trying to do a walk to somewhere when walking's really difficult. But it does take time, and we certainly know with insurers and other providers that getting the right wheelchair prescription or the right scooter prescription can be quite challenging. And again, your care team's there to advise you, and as we write these care guidelines, we as the clinicians can be putting certain features into those to say, actually, it's really important that if you're using a wheelchair, that you're able to tilt the back, or you're able to tilt the whole seat, or that you have a seat elevation on it. So those little things that sadly at the moment aren't routinely available to everybody in every area, by writing these care guidelines with you as the community, we can try and encourage the payers to provide you with the most appropriate equipment. Fall management is really important. This is a condition that can lead to falls very easily, and you knowing what your plan is of how you're going to get back up off the floor again and for your family, because rarely do falls happen somewhere convenient like next to the sofa so you can get yourself back up. They happen when you're crossing the road. They happen in the department store or the mall. So having those discussions with your care teams about, well, how will I manage my falls is really important. Pain and fatigue. We know this occurs in a number of limb girdles, particularly fatigue, and understanding how you have a cup of energy and how much you can take out for that cup for what you need to do in that day and how you refill it again is a really personal thing, but it's something that's really important for your care team to talk about with you, to look at how you manage and structure your daily activities to make sure you've got enough energy to do the things you want to do. And home aids and adaptations, it may be that if you do that walking becomes difficult and you are becoming a wheelchair user, that there are quite significant home aids and adaptations that need to be made. There's lots of advice online, there's lots of advice within the patient forums and your own clinical team, and having an occupational therapist is critical to making those appropriate decisions about how do you organise your bathroom, what might be a suitable Hoyer. As Matt and Volker alluded to, some limb-girdle subtypes are more likely to have respiratory involvement. We do recommend that testing of your breathing should be done as a baseline when you're having your diagnosis. And for some subtypes, we will monitor this more frequently. And then some people may progress to using non-invasive ventilation or a breathing machine overnight. The other thing that's really important to talk about with your care team is that if you're having trouble clearing secretions or coughing, there's lots of different options for helping with that as well. This is a phenomenal community who are incredibly resourceful and who are wonderful at sharing experiences. And so from some of the previous Limb-Girdle conferences, some of the top tips that have been raised by people to live with limb-girdle is things like getting higher. We've got a range of aids and adaptations that can get people up a little bit higher, and if we get you a little bit higher, then you're able to stand up independently. And that makes, obviously, when you're out and about, if you're in a cafe, when you're going to toilets outside of the home, that can make that difference between being independent and not. So getting high is good. If your limb-girdle type means that the muscles on the inside of your legs are a little bit weak and your legs tend to fall apart, then something as simple as a luggage belt, I know it's not fancy, but it's really effective, can help keep your thighs aligned, and that means your feet are flat. And if we can keep your feet flat on your wheelchair or your scooter foot plates and your thighs straight, that means it's better for your back and your entire spine and more comfortable, especially if you're sitting for up to 16 hours a day. Back to the fall management, having smart speakers in the home, because it may not be that you walk around with your phone in your pocket at the time that you happen to have a fall. So having smart speakers around the house or voice activation on your phone is a good way to be able to alert someone. We also obviously have smart technology and watches that might be able to alert and call someone if you have a fall. As you know, every day is different with this condition and you're not quite sure what you're going to wake up to. Our role as clinicians is to try and, while we don't have the crystal ball just yet, the world expert physios that most of whom are sitting at this table in the front here, we are trying to create the crystal ball to be able to give you time to make the changes, to understand what's coming next for you in your journey by using, well, making things hard in clinic by asking you to do certain things in clinic and getting our stopwatches out to see how long things take. The reason we do that is not because we are physioterrorists, because we are, but it's to try and be able to help predict and to look into that crystal ball, see what's coming and give people time to make changes. None of these changes are easy. The more time we can give you to make adaptations, the better. And of course, anyone that's been at the District Glycanopathy Conference in Iowa, led by Kathy Matthews and Kevin Campbell, will know that there's an amazing Tops Tips session, and they very kindly post online their top tips. And there's a number of useful pieces of equipment and ideas in those sessions from all the community. So this is a phenomenal community. As you can see, you have patients, families, you have advocacy groups, you have clinicians and researchers and industry all in the room together trying to make managing and living with this condition better. And what we've been able to do as a community is have these amazing conferences that we are so delighted to attend, but also as professionals, knowing there's not that many experts on limb-girdle, we've been able to run a number of masterclasses so that we can upskill other clinicians around the globe. We have educational websites, so other clinicians that might not be in a specialist neuromuscular centre can learn about limb-girdle, can learn about management. And of course, these community events like us here coming together this weekend is a really, really critical opportunity for the limb-girdle community to share experience and for us as clinicians to be chatting with you and learning what we can do better. This also creates, as Kat kindly mentioned, the opportunity to participate in research. Not all limb-girdle subtypes necessarily have a natural history study. And so what we've been so lucky to do over the last few conferences is actually meet many of you, ask you to do some tricky things, and then publish that research, because we've actually been able to create assessments that are limb-girdle specific that have then been used in clinic and in clinical trials. So as Kat alluded to, we'll be downstairs for the rest of the conference, and we're having a particular look at digital outcomes or wearable technology this conference to see, is there an easy way that we could measure you at home perhaps, that you would have less clinic visits, or is there something about your walking that we could measure with a gait analysis? The patient voice is critical. You are a powerful community. We have a number of individuals with limb-girdle who are able to be amazing on social media, sharing their experiences in their lives. I've just put 3 of them on there for today. We have a website run by Anna Mayhew called PodNMD, and it was initially developed for clinicians to learn about limb-girdle, but we also have patient experiences. So one of our COS patients who has been in the natural history study for many, many years shared her experience of why she kept coming to see us in Newcastle, even though it was really inconvenient for a number of years, and why that was motivating for her. Louise Halling also lives with limb-girdle, and she has a lovely podcast about walks like a duck, and it's titled that because when she was being assessed in Australia, a medical student said to the attending, "Oh," and she asked her what she thought about her gait. "Oh, she walks like a duck." The student was spoken to afterwards. Thankfully, Louise found that highly amusing and has then utilised this to call her podcast by that. So that's a really good listen. And Keris, who's in the room as well, as one of our young women living with limb-girdle, also is sharing her Unbalanced podcast and her experiences. So this is a great community. And I know there's people in the room who are here for the first time, and I encourage you, if you can, maybe put your hand up. So everyone that's here for the first time, hopefully we can all go and find you and people can introduce themselves to you so that you know you've got a great community. I know the timing's not great given the last 48 hours, but we are recruiting for our natural history study this weekend. Every patient visit matters. Every piece of data that we create helps bring us forward as a community. We cannot progress care and research without you. This is a global engaged community. You will see that whilst this is a North American meeting, we've got participants from all over the world. Do we know how many countries are represented?
27.
Oh my goodness, so 27 countries are here this weekend. So this is a community that works together internationally and sharing experiences. So as Volker has mentioned, we've got standards of care. We have a family guide, which is diagnosis agnostic. It doesn't matter what your diagnosis is. The family care guide is for everyone. And we're also, as clinicians and patient representatives, developing some specific ones. So we have a dysferlin one in place. We've also been developing an FKRP or Limb-Girdle R9 or 2I, whichever version of the nomenclature you'd like to use. And we've recently had a workshop to look at standards of care for the sarcoglycanopathies. Additionally, just in the 2 days prior to the conference, we've been looking at this for calpainopathy or Limb-Girdle R1 as well. So I'd like to thank everybody for listening this morning, and please know that we are working very, very hard with you to try and improve your lived experience with Limb-Girdle and to keep working together for the best care and management. Thank you very much.
Thank you so much to all of our panelists. Thank you for your presentations. We can't do this without you. I want to follow up on what you mentioned, that every patient matters, and the loss of one of our patients in our community has been quite heartbreaking for me, and I know for many of us in this room. I want to take a moment to honor this person who is supposed to have been confidential. No one should have known his name. And unfortunately, this family ended up exposed. Something private for them should have been private. I'm sure reporters have now been bothering this family who were grieving and mourning. This individual had 2D. He was 51 years old. From what I hear, he was also a father. This is somebody that really understood the risks of being in a trial, from what I understand as well. For our community, I want us to honor this individual, and I want us to honor all of the people who have participated in clinical trials. Every time any of us in this room participate in a trial where we're receiving a medication, we are taking a risk, and that risk is not just so that we can get better, that risk is so that we can help others in our community as well. And I know for myself, I take it that seriously too. And I want to honor him today with a moment of silence in the room, if you will, if we could give him a moment of silence. As someone who has limb-girdle muscular dystrophy myself, we are frequently getting emails, communication from patients where they've told us that a loved one has died. And unfortunately, a lot of times it has to do with the Limb-Girdle News Magazine. And the families said, please take us off the subscription. Our loved one is no longer here. This disease is very serious, and I just wish everyone understood who hears about limb-girdle that this is not just a mild disease, this is a serious disease that touches every single one of our lives in a very serious way. And I just wanted to say we're all a family in this room. We all share the same difficulties. And one thing we can do is be very united and very focused and come together and say, we're going to make sure that we receive treatments and that every single subtypes receive treatments as well. And we can do it together. So I just want to say thank you to all of the presenters this weekend who have taken their time, who have come here, for all of our patients, for you to be here. You're doing a wonderful thing being here, and thank you. We want to make sure this is a wonderful weekend for you. So we're going to take a short break, and then we're going to come back for session 2. Also want to remind, if you are receiving a travel stipend, those will be given at the Speak table. If you start at 11:30 a.m., the stipends will start to become available at the table, the Speak Foundation table right outside. All right, thank you so much, and we'll take a break.
Good morning, everybody, and welcome to the session, Understanding Diagnosis and Genetic Test Results. My name is Laura Rufabach, and I'm the co-president of the Jane Foundation, who's a nonprofit foundation whose mission is to find treatments for LGMD 2B or R2, which we call dysferlinopathy because it's caused by mutations in dysferlin. So I just want to reiterate a few announcements. Kat mentioned this morning that there are cards in your bag or out at the speak table if you want something for Ask the Experts or Ask the Genetic Counselors. The sessions are happening at 1 and 3 p.m. today, so if you have a question, please get them on the card as soon as possible, and there's a green bin at the speak table. Please drop them in there. Also, as Meredith talked about, there are 2 clinical studies going on downstairs. One is more of a genetic testing, and the other is more physical assessments and outcomes. They're taking all comers, both those with LGMD and individuals without, to be used as controls. They're taking kids and adults. So please, if you want to be part of a clinical study of any kind, and are interested or finding out more information, please go downstairs and talk to them about that. All right, so let's move on to our first speaker, is Lee Kugelman. She's a genetic counselor at the Fixel Institute of Neurological Disease at the University of Florida. She's been a member of that team for the last 5 years and works in the neuromuscular and ataxia clinics. And she's going to be talking about how to read and interpret genetic reports.
All right. Good morning, everybody. Let me just make sure I have my clicker that I know what to do with here. There we go. Okay. So yeah, I'm going to be talking about looking at a genetic test report. This can be a little tricky because every lab has a little bit of different ways that they want to format their test reports and can have different types of information on there. But I'm going to try to break down some key pieces of information that are important for you when you're trying to piece apart exactly what that test report is saying. To start, just so we're all using a shared vocabulary, because genetics has a lot of overlapping, sometimes redundant terms in all of the kind of different pieces of the system here. So a gene is just one individual section of DNA that has a particular job. Each gene, and we've got tens of thousands of them in our body, each gene is the instructions for our bodies to make a particular protein that our bodies need to grow and function and do everything that we need to do every day. Our DNA are these long strands of genes, and the way we store our DNA in our bodies, it's wound up and scrunched up in these structures that we call chromosomes. And here on this slide, I've got a picture. We can visualize our chromosomes under a microscope in this picture that we call a karyotype. And so the important thing there to keep in mind is the way that we've got those arranged. Our chromosomes come in pairs. We get one from each of our parent. And so what that means is for all of our genes, we have 2 copies. We get one from each of our parents. When we're talking about genetic disease, very often what we're talking about is zooming in on the individual gene level into that individual set of instructions that we call the DNA sequence. The smallest unit there is, if we zoom all the way in, is something that we call a nucleotides. We have 4 different types of nucleotides, and what code that they say when the body reads through that sequence of nucleotides is how the body interprets what our DNA instructions are saying. Our bodies interpret these, they read them in sets of 3. So every set of 3 nucleotides is the code for our bodies to put a particular amino acid as our bodies are starting to build up a protein. So our bodies go through and read these 3 at a time and add an amino acid along a strand to build up a protein. When we're talking about how DNA can end up leading to symptoms of a disease, what we're talking about is some sort of change in that genetic code. And we use a lot of different terms to refer to that change. We use the term mutation. I really like to use the term variant. But basically what that means is something in one particular person's genetic code that is different from what we would expect. What we would expect is something that we call the reference sequence, and this has been built up over years of research of saying what is normally going to be present in this DNA strand, these amino acids here, that would produce a functioning gene product. But if someone has a variant or some sort of change in that sequence in their genetic code, this can result in a change in what amino acid is put in as the body is building that protein. And if there's a different amino acid or a change in the amino acid order or function, that can result in a difference in the protein function. And that can, down the line, result in symptoms of a disease. And so the goal of a genetic test report is to communicate these variants to the clinician. I work in a clinic, to work with whoever it is that ordered that genetic testing lab and give them information about what was found on those particular changes. And together with all of that information, the clinician can interpret and try to make a diagnosis in a patient. So I'm going to kind of start out small and go piece by piece about all of these different things. So starting out about how do we describe the types of differences in the DNA sequence itself? Well, we know we have our reference sequence of what we expect the order of these particular nucleotides to. We've got each nucleotide at each position is numbered. And so we can have different types of changes of how those nucleotides can be different. Maybe at a certain position, one nucleotide is a different nucleotide in that position. That's something that we call a substitution. Maybe there are some nucleotides that are missing, so a deletion. Maybe there are some nucleotides that are extra that weren't supposed to be there, but a couple extra are added in, something like an insertion, a duplication, or a repeat expansion. And so the way this is communicated on a test report is something that we call a C-dot language. And so this is, I've zoomed in here on this sample test report that I've created. This was a fake test report in a fake lab. These are real variants, but not a real person that I pulled this test report from. And so in this individual has 3 variants that were identified in 2 different genes, 2 variants identified in dysferlin, the DYSF gene, and a variant identified in the GAA gene, which is associated with something called Pompe disease. And so what this first line here is, this first variant that was found, what this C-dot language says for the nucleotide change, as long as nothing's broken. What that means is that the first line there, that nucleotide position 2,997, in the reference there's a G. We expect that there is a G nucleotide in that position, but in our patient here there is a T instead, so it was a letter substitution. The second line here refers to a deletion, and so what that says is the 298 to 300, those 3 nucleotides right there are missing in this patient's sequence. If we scale up to the next level, we say, okay, well, these are the individual nucleotide changes. What can that mean for the amino acid sequence? How can that mean that the amino acid is different? Now, sometimes we can have a nucleotide change that has no function on the amino acid whatsoever. So in this first line here, we've got a variant. It's a different nucleotide position, but the code still ends up putting the same kind of amino acid in that same position. We call that a silent change or a silent mutation. If the change in the DNA sequence, the change in the nucleotide results in a different amino acid at that particular position, we call that a missense change. Sometimes the change results in an amino acid missing entirely. It tells the body, instead of to add another amino acid as it building up the protein, it tells the body to just stop, end of sentence right here. We call that a nonsense change. And other times we can have insertions or deletions that can shift the order of that group of 3 that the body reads them in, and that's something that we call a frame shift change. And so we represent these amino acid changes in what we call the P-dot language here under that variant column there. And so again, in that first line right there, that first DYSF variant, this is talking about that amino acid sequence. Now, the way that reports represent these amino acids, there's some different types of abbreviations, either using 3 letters or 1 letters. I don't know why. I didn't make the system. I don't know why the labs don't all use the same things. But we got to kind of sometimes look up and see exactly what amino acid that is referring to. And so that first line there that says the 999th amino acid in that sequence of building that protein, What we expect to see in that place is a tryptophan, a TRP, but instead in our patient, she has a cysteine in that particular location. The second DYSF variant that this patient carries, at the 100 position in that DYSF gene, we expect that that patient is going to have an alanine. But instead, because of this deletion in those nucleotide positions, what that results in is a deletion. So one amino acid is missing from that strand that she's got there. So that is how we report out the nomenclature specifically for the variants that were found in a patient. But then we say, well, how does this actually impact how the protein, whatever particular protein is the gene is encoding for that we found this variant in, how does this impact how that protein functions? And that's where we get into the terms that you might have seen on your test reports like pathogenic, benign, and variants of uncertain significance. This is a process that we call variant classification, trying to see what is this variant going to do on the actual function of the protein. And the process of figuring this out involves looking at a whole lot of different lines of evidence. We look at things like, has this ever been seen before? How common is it? Has it been reported in the literature? Do we have lab tests, lab models of how we expect this could function? There's lots of different criteria that can go into trying to determine if something is pathogenic, meaning it can cause disease, or if something is benign, meaning it's not going to have any impact and not going to cause disease, not going to have any impact on someone's health. And so there is kind of a standardized process that testing labs use to do this. It was created by ACMG, the American College of Medical Genetics. There's a rough formula where labs review these different types of evidence for each individual variant they find. They look at what information is available for that variant and see what can we check off on the list, and if we pull that evidence together, how does that fit on one end or the other of the spectrum of a pathogenic or benign change? Now, each lab is going to have their own kind of individual criteria that they might use internally. They might not all stick strictly to these particular guidelines, but it's all based off kind of the same concept created by the ACMG. So the labs, as I said, they go through and try to tick off these different lines of evidence, but sometimes we just don't have a whole lot of information about a particular change, a particular variant, and we can't say for sure what end of the spectrum it falls on. That's when they come back with a variant of uncertain significance. It's a change, there's a variant in the DNA, but we just don't know how that's going to impact the protein function and therefore how that could potentially cause symptoms down the line. So when we get these variants of uncertain significance, or we call them VUSs or VUSs, what do we do with them in the clinic? Well, sometimes there's a little bit more testing we can do to try to figure them out. Sometimes it involves testing other family members that can help us try to figure out a little bit more about what a VUS is doing. Sometimes other types of lab tests, sometimes a muscle biopsy can be really helpful in interpreting exactly what a VUS could be doing in someone. Sometimes we can do a whole lot of tests and we're still not going to move the needle. It's still going to be stuck in the middle of a VUS, but I'm looking at the patient and I'm looking at the evidence and I say, I'm pretty confident this is the answer. I think most likely this is the answer. Other times I'm looking at the evidence and I say, I really don't think this is it. I think we can cross this off and worry about it. And that's where kind of speaking with a genetic counselor can be really helpful to get that interpretation of what these test results can potentially mean. That whole process of us looking at a patient and looking at the results and trying to make that match there is the clinical interpretation process made by genetic counselors, neurologists, any member of your clinical team that's looking at your test results and trying to get you a diagnosis. Because the variant classification alone isn't enough for us to make a diagnosis. Just because we get a test result back with something that says pathogenic, that doesn't automatically mean that finding is someone's diagnosis. There's a little bit more that we got to look at in context of a patient to really make sure that we're looking at the right thing for making a diagnosis. One of those is the inheritance pattern. And this is where we zoom back out again and we remember that these genes come in two copies, one from mom, one from dad. We have two copies of each gene, and how a particular gene, a particular disease gets passed down in a family is important to keep in mind when we're trying to interpret if these findings could be a diagnosis for someone. So in a dominant genetic disease, if a person has a change on just one copy of the gene, and we call these two different copies alleles, so if they have a change on just one allele, in a dominant disease, that can cause symptoms. That could be a diagnosis. But in a recessive disease, we need to see a change on each allele, on both copies of the gene, in order to say that that finding on the genetic test report is consistent with someone's diagnosis. So if I go back to my example test report here, we did find 2 different changes in this DYSF gene. We know DYSF can cause an autosomal recessive limb-girdle, but we got to be careful, because just because we see 2 changes on a test report doesn't mean we can automatically say, yes, this is Jane's diagnosis, because what we need to make sure is, are these 2 changes on opposite copies of the chromosome, on opposite alleles on both copies of the gene? So that's where we get into terminology you might have seen on a test report of something that we call zygosity. So what zygosity refers to is each individual variant, is this present on one copy, one allele, or on both copies? So you can see these first 2 DYSF changes found in gene, these are heterozygous changes. What that means is each of those variants, they're only on one allele, on one copy. Jane only has one version of each of those changes in her. Versus this bottom variant here in GAA, Jane is homozygous for this variant. What that means is this same variant is present on both copies of Jane's GAA gene. What I'm looking for to make a diagnosis of dysferlin in Jane is that she is compound heterozygous for both of these 2 variants. We know they're heterozygous, which means she only has one of each of these changes, but I need to make sure those 2 changes are on opposite copies of the gene. Because sometimes a patient can have one of each of these 2 changes, but they are what we say they are in cis, meaning these 2 changes are both on the same copy of the DYSF gene, the same allele. And then in that case, Jane's other allele of the DYSF gene doesn't have any changes, is working, making the protein like it's supposed to. Jane would be a carrier of this condition. That would not be a diagnosis for her. She would be a carrier of this recessive disease, and we would need to keep looking to try to get a diagnosis from her. But if I'm able to determine that each of these changes are on opposite copies, opposite alleles of the gene, we would say these variants are in trans, and that would be consistent. We would be able to make a diagnosis of limb-girdle 2B in Jane. So how do we do this? This is a process that we call phasing, and this is where testing family members can be really, really helpful. So for example, if I'm able to test both of Jane's parents, in a recessive disease, what I'm looking for one change on each copy, I'm looking for one change came from Jane's mom and one change came from Jane's dad. And we're able to test that and show that, because we can't quite, these things are just too tiny for us to actually be able to visualize, so testing family members is a way to do that. If we're able to show that she got one from mom and one from dad, that confirms that these variants are in trans and confirms this diagnosis. But if both of them came from the same parent, so for example, if both are found in Jane's mom, that means that these variants are in cis. This is not her diagnosis. Even though we saw something pathogenic on this genetic test, it's not a diagnostic genetic test for Jane, and we gotta keep digging. So what happens when we get a test result that has some findings, but they're still not enough for a diagnosis? Sometimes that's because in this example, Jane can be a carrier of this condition, but it's not making a diagnosis. Sometimes it's because there was a finding in a gene that doesn't entirely correlate with the symptoms a patient is currently experiencing. So for example, the Titin gene is a gene that can cause a whole spectrum of different things. It can cause some muscle weakness. It can cause some people to have some limb-girdle symptoms. It can also cause just cardiac disease. And which kind of flavor of symptoms someone might have can depend on the individual variant and what part of the gene that's located in. So sometimes I get a positive genetic test result back that says we found a pathogenic change, but I gotta look a little closer at that particular change and say, well, what is that change associated with? Is it only associated with one set of symptoms and not the symptoms that my patient is currently experiencing that we're trying to diagnose? Some other examples that might come up on a limb-girdle panel are something that is called a pseudodeficiency allele, and that was what was found in Jane here in this GAA gene. That can be something that doesn't actually cause symptoms, but might cause lab tests to be a little abnormal. So that can be kind of a red herring. I've had some patients come to our clinic with this GAA result thinking that it's a diagnosis, but because it's a pseudodeficiency allele, it's not quite it. So again, having these test results interpreted by someone who is in genetics or works a lot with genetic disease can be a really helpful step to dig in and make sure we're talking about the right diagnosis. So if we do all this, we do a test, we may or may not have some findings, but it doesn't give us a diagnosis. What does that mean? What do we do next? Well, sometimes it's because the test that we ordered, you have a genetic disease and the test that we ordered didn't take a look at that gene. Maybe if you had testing many years ago, looking at genetic testing that was done 15 years ago, maybe the genes that we knew about back then didn't include your particular disease and we need to do some updated testing. Maybe the particular type of testing that was ordered is a particular type of genetic testing methodology that can't find the type of genetic change that's actually causing your disease, and we need to do some updated testing again, looking at a different type of methodology. Maybe it's because you have a change in a gene that we haven't linked to limb-girdle muscular dystrophy yet. We haven't discovered it yet, in which case might be important to talk about some research options or head downstairs, since that's something that we're doing today here at this conference. And then this is not likely to be applicable to the people who made their way in this conference, but happens sometimes in my clinic, that sometimes symptoms can be caused by things other than genetics. We have patients who have muscle weakness for things that aren't a genetic disease, but are other things. And so we need to do some more digging to try to figure out a good answer for folks. And again, that's where working with a good team to try to help figure this out and explain things with you and make a plan for next steps can be really important. So if you are trying to figure some things out and you don't have, as part of your care team, a genetic counselor, findageneticcounselor.org is a website you can go to look for a genetic counselor in your area. You can put in a zip code. So if you've got some family members who live far away, they're not able to see your team, or your team doesn't have a genetic counselor and you're looking for someone that they can speak with, that's a good website to go to. And my last parting thought that I always like to make for everybody is keep copies of all of your genetic test reports. For whatever reason, when patients come to our clinic, new referrals come to our clinic, the results that get sent over almost never include the test reports. And when someone comes in and tells me I've had some genetic testing, we're not really sure what it meant, it's really important for me to see that report itself so I can get all that information that I've been talking about today and see exactly what it was said so I can make that evaluation. If you guys can bring those, make sure you have those copies, bring those copies, and make sure that they come with you to new evaluation, that goes a long way, because I almost never get them and have to spend a whole lot of time digging them down. So I always encourage people to keep a copy of those with you. And that's all I got today. There's a Q&A later, so if anyone has any specific questions, I'll be part of the Q&A this afternoon.
Thank you, Lee. So our next speaker is Dr. Conrad Chris Weil. Dr. Weil is the professor of neurology and the head of neuromuscular section at Washington University School of Medicine in St. Louis, and he will be talking about challenges and barriers to establishing a genetic diagnosis.
Great, thank you for letting me talk, and thanks for the introduction on genetics. So I'm going to get started here and make sure I understand how to do this. So I'm going to talk about challenges and barriers to genetic testing, and I want to just bring up one quick point, which is that we talked about the reference genome and what everything's based on, and I always think it's an opportunity to really talk about the importance of diversity in understanding genetic test results, because I'm going to talk about genetic variation. And genetic variation is the variation that happens not just within individuals, but within different ethnic groups, within different areas and regions of countries. And so by broadening the sources of genetic testing that we do, and by using that research-wise, we can actually include everybody, and you'll be able to see why that's important whenever we want to interpret genetic variation. So we already heard some introduction to this, so some of this may be a bit duplicative, but the goals of what I want to talk about are the types of genetic testing. I want to talk about some barriers to genetic testing, and so why patients might not get genetic testing. The bulk of what I want to talk about is the understanding of genetic variation, and then how to interpret genetic test results. And so genetic testing that can be performed in clinical practice, so if you come and see me in clinic and I'm suspecting that you have a hereditary disorder or hereditary muscle disease, one thing you could do is if I knew what your family had, for example, I had a genetic test from your sibling or from your father or from your mother who had similar symptoms, I might be appropriate for me to actually just do individual genetic testing. Typically, I would say that's not what we do, but there could be a situation where that would be appropriate. What we typically do is panel-based gene testing, and so these are genetic testing to look for all known or likely LGMD genes or myopathies. What's important, and what we just heard about, is different panels and different genetic test results. Just because you had genetic testing doesn't mean that you had all of the same genes done, and we keep adding genes and removing genes from gene panels. And so just because you had genetic testing might not mean that you had everything done. And so knowing who did your genetic test result or who did your genetic testing, which company is really helpful, because different panels exist for different genetic test companies. Another thing that's important, and patients will come to me and say, oh, I've already had genetic testing, and I'll find out that they had genetic testing maybe 15 years ago. And they may not have a diagnosis, but they had old genetic testing, and we've updated genetic test results, and we've added new genes. And so making sure that you've had updated. Now, if you already have a diagnosis, I'm not talking about that. I'm talking about if you don't have a diagnosis. And finally, we can do things where we can actually interpret all of the coding genes. And so this is something called whole exome sequencing. Again, knowing the genetic test that you had, so just saying you had genetic testing might not mean that you had everything done. And again, this is if you don't have a diagnosis, because even whole exome sequencing can miss certain things, deletions, non-coding regions. And so someone may say, well, I've had every gene tested. Well, that may be true, but I don't know what that actually looked like and what that genetic testing what it was. So that's just important to do. And then later we can do something called whole genome sequencing. I want to talk quickly just about some of the barriers to genetic testing. And so currently, free genetic testing occurs quite easily, point of care in the clinic. But not everybody has access to that either. And whenever I say free genetic testing, it's not really free, it's sponsored genetic testing. And so a genetic test company is usually aligned with some pharmaceutical company that's interested in identifying their disease gene. And so they've helped kind of improve the diagnostics. But there are barriers, and one is sometimes it can be cost prohibitive, so payers, so even for genome sequencing, it can be a payer thing. Patient knowledge, community knowledge. I would say one of the biggest barriers we have is physician knowledge. And so not all of us understand genetic test results and genetic testing. We need to partner with a genetic counselor. But I would say not everybody has access to a genetic counselor as well. And so I think physician knowledge is really important. And I would say, and this needs to change, but the original patient care guidelines, this is from the American Academy of Neurology. This is from over a decade ago. But the care guidelines then actually said that you should actually sequence the gene that you think is the gene that is causative, meaning that I'm supposed to know whenever you come in that you have a dysferlin gene because I'm able to kind of figure it out. And that level C evidence, and level C evidence is just my opinion. It's Peter's opinion. It's our expert opinion. Suggests that we should do panel-based sequencing, which is what we do. And so this all changed, I would say, for limb-girdle muscular dystrophy in particular a decade ago. And this was free genetic testing that was allowed, point of care. And so point of care genetic testing is important because if I see you in clinic and you've come from far away, and if I'm able to do genetic testing that day in clinic, that's really valuable, because often what we would do 10 years ago is people would leave, I'd contact insurance company, we'd get lost to follow-up. And so by doing point-of-care genetic testing, we were really able to break down some of these testing barriers. And this was funded by the MDA as well as the Jane Foundation. And this here is the result. This kind of pie chart here kind of shows what they discovered. And they discovered that the prevalence of limb-girdle 2A was much more common than some of the others, and this was really, really helpful. They only sequenced 35 genes. But one thing that happened is although this was the result, what really was the result was that about 75% of people were left without a diagnosis. Half of them had what we call this variant of unknown significance that we just heard about, a VUS. And I would say that a variant of unknown significance leads to really a non-diagnosis in many situations. And so half of patients had variants of unknown significance in a limb-girdle muscular dystrophy gene. And so this leads then to the interpretation of genetic test results. We heard a little bit about it. This is a patient's genetic test result right here. And what you can see is that this patient has several different variants of unknown significance. This patient had a panel of 100 genes, yet they have variants of unknown significance in several muscle disease genes. And this is quite common, and I'm going to explain why this patient would have so many variants of unknown significance. And it really has to do with understanding human genetic variation. And so it wasn't until we actually sequenced the entire human genome, and this was obviously done 2 decades ago now. And what we learned with this paper right here, this was the first attempt at sequencing 1,000 patients and looking at how variable we are from human to human to human, how different I am from my genetics from one individual. And what we identified is that there is a huge amount of rare variants. And in fact, if we look here, many of us have common variants, but everyone has about 30 to 40,000 rare variants. And these are variants, in some cases, that are unique to you. And so when I say unique to you, that means unique to you. You have your own personal mutation. You've got it from mom or dad, so it's not entirely unique to you, but in many cases, it's unique to you. And so of these rare variants, 250 to 300 cause actual would be damaging to that protein. And in many cases, it can be on both alleles, suggesting that we are all have mutations that could be considered disease-causing, yet we're not all walking around with different diseases. And so the other thing that's known is that in many cases, all of us have between 0 and 7 pathogenic variants. So all of us have variants of unknown significance. And so now whenever we look at this genetic test report, we can kind of understand there's so much genetic variability from patient to patient. I'm now sequencing 100 genes. Of course, I'm going to find variants of unknown significance that are unique to individuals and that are then hard to understand. And so how do we interpret these genetic test results? And so I'm going to go back to kind of elementary school. I think they're teaching genetics now in elementary school. Elementary school genetics, where we have a DNA that's transcribed to RNA that then makes a protein. And the way we can think about it is the DNA is the cookbook, the RNA are the different recipes, and then we can say that ultimately the protein is the cake, okay? So that's what the product is. So we translate our RNA into a protein, and that protein is then, we'll say, a cake. And what I can say is that cakes can come in many different flavors, okay? And so I think that's what genetic variation is. We need to be thinking about the cake coming in very different flavors. And so what I want to do is to kind of walk you through how we would do interpretation of a genetic variant. And I want you to think of this recipe here as the genetic code, all right? And so that's what the recipe is. It's different protein amino acids, and there's different steps to making that chocolate cake. And so what you can see here is the recipe is now right there, and whenever I make this recipe, I'm going to get a chocolate cake. But what I am very clear of is if I delete half of that recipe, I'm pretty confident I'm not going to get a chocolate cake, okay? I'm pretty confident I'm not going to get one. And so that's where I can do variant resolution and say if the protein is truncated, I'm not going to get that protein. That means that protein's not being made. But sometimes it's a little more complicated. And so one example is here. If I don't preheat the oven, okay? I've cooked a cake and I've not preheated the oven. I've actually gotten a cake. And so that we could say, I can take a pretty good guess and say that's probably a benign variation, okay? So I can look at that mutation and say, I think because of my experience, because of the way I've looked at other proteins, I can say that if I don't preheat the oven, I'm going to get a cake. But what about the example of where we leave out something like the baking soda, or we leave out this teaspoon of salt that we seem to need to add? I actually don't know if I'm going to get a cake. I might get a different cake. I might get a cake that doesn't taste good. And so those are variants of unknown significance. And what that means is I don't know what that change is going to do to the protein, and so I leave that as a variant of unknown significance. And so what are the challenges of variants of unknown significance? Well, they leave the patient with diagnostic uncertainty. They leave it an inability for our genetic counselors to do their job and to help with family planning because we just don't have a good sense. They leave the physician who's just as frustrated as the patient with diagnostic uncertainty. They can lead to inappropriate treatment and testing. They can lead to increasing healthcare costs and a whole variety of other things. And the other thing I would say that's really important is that because of all these variants of unknown significance, we start to not really know the true prevalence of many of these limb-girdle muscular dystrophy subtypes. And so I think that's an important aspect. And finally, the tragedy would be that you would miss out on some type of gene-specific therapy because we didn't actually have a diagnosis. And so again, the importance is clear. And I would say by resolving a variant, we help improve it for other patients' care. And so this, again, is an example of a genetic test result where this is a patient has progressive weakness, and they've got several variants. And are these pathogenic VUSs, or are these variants that are incidental? And so if we looked even through other genetic test results, everybody has variants of unknown significance, and everyone might have variants of unknown significance in multiple LGMD genes. And that's just because of our genetic variability. And so it leads us as clinicians to start thinking about how we're going to do this. We're going to do gene first, or are we going to examine the patient first? And just the ease and low-cost genetic testing, invariably patients are getting genetic testing done first. And I would say I've had patients that show up with a genetic test result that they got even though they don't have any clinical symptoms. And that's a really now challenging thing for me to understand, is does somebody actually have the disease whenever they're not manifesting it? And so we really need to work together. Geneticists and clinicians need to work together. And I bring this up, do we order the gene test first, or do we examine the patient first? And so this is an example of a genetic test result. This is an autosomal dominant disorder. And in this case, this patient had a mutation in DNA JB4. It causes a limb-girdle muscular dystrophy. It says pathogenic. That's a slam dunk. We've done that. That's a diagnosis of this patient. But here's another example. This is a patient that came to me, handed me their genetic test report, and said, I have limb-girdle muscular dystrophy. They didn't have limb-girdle muscular dystrophy, but they had a genetic test report that was very ambiguous and very confusing to them because it said a variant of unknown significance in that same gene. And so what I want to point out is that a geneticist can tell you if it's rare, they can offer predictions, but they don't know if it's actually pathogenic in the patient. And that's where we need to partner with clinicians as well. And so again, here's just another example of some genetic test reports that are ambiguous. This is a patient that has a pathogenic variant in one, but a VUS in another. Here's another. Everybody has variants of unknown significance. And so I want to give you an example of what we would do to help resolve a variant of unknown significance if I was a clinician, or as a clinician. And so this patient has a pathogenic variant in calpain-3. He has to have 2 mutations. We talked about that. They have to have 2 variants. And so the other variant has a VUS. And so this is a 34-year-old man with limb-girdle muscular dystrophy unknown etiology. He's got several variants of unknown significance. He's got one in dysferlin. He's got 2 of them in, he's got 1 variant in calpain-3, and he's got a pathogenic variant. And what we would do is we would kind of walk through this patient. We'd say, well, what is his history? He developed weakness at the age of 25 with climbing steps. That tells me perhaps this is limb-girdle. He doesn't have a family history. He's got proximal weakness. He's got some features that might be specific for calpain-3. He's got some scapular winging. We then do other tests. So we would look and check his muscle enzyme and do electrodiagnostics. We likely would need to do a muscle biopsy. Not everybody needs a muscle biopsy, but in a situation where we have a variant of unknown significance, it may be prudent to do a muscle biopsy in order to make sure that we can understand this. And so this patient has an elevated muscle enzyme. He's got, we didn't do an MRI of his muscle, but you could do something like that. He had a muscle biopsy that actually showed that he had a muscular dystrophy, and he actually had some other studies done. So then we go and we look in databases, and we can see that this calpain-3 variant is unreported in population databases, that it may change splicing. And we go further and we try to understand, do the variants segregate? This is where we would get DNA from mom or dad or from siblings. And so in this case, we were able to get DNA from his mother and get DNA from his 2 siblings, and we were able to see that this was on 2 different chromosomes. We did other testing on the muscle biopsy that needed to be sent to a specialty lab that showed that there's a reduction in certain proteins, and then we actually did a Western blot to actually look and show that calpain-3 is absent. So my point is that variant resolution is complicated. It takes a lot of work. And so it requires a specialist that understands hereditary muscle disease, and it's time consuming. And I guess the complicated becomes more complicated because some of these disease genes we're finding actually can be inherited in different fashions, in dominant and recessive ways. And so it just becomes more and more complicated. And so how can we kind of solve this? How can we kind of solve this, this process? And this is where we started a program working with a group called ClinGen. ClinGen is an NIH-supported group. They answer 3 important questions. One is this gene actually causative for a disease? Is a variant, so a VUS, is it actually associated with a disease? Is it pathogenic? And finally, if we do find these variants, is it clinically actionable? And so the way we do this, we just heard briefly, we aggregate all of this information together, we add it together, we kind of stack it together until we get levels of evidence. And so what I would say is that we need to do this and create these rules specifically for limb-girdle muscular dystrophy because there are specific things that we can do. And so one thing that we're working on, and am I running out of time?
Yeah, we're way over.
I'm way over. Okay, I'm going to go really.
Not just you, the whole stuff.
Oh, okay. It's not just me. So what I would say is at this point we have an incomplete library of genetic variants. And what we want to do is we want to create a complete library so that whenever someone comes in with their genetic test result, it says pathogenic, it says benign, so that whenever we do genetic testing on children before they get any disease, we can say whether they're going to have this disease. And so we've been working hard to kind of create these mutational libraries and do these types of scans. And there's other ways that people are doing it as well, using bioinformatics and deep learning approaches. And the goal will be to take this incomplete library and create a complete library. And so the question would be, well, where is this library being housed? And so this library is housed in something called ClinVar. And so ClinVar is a database that's open access that you can look at, and you can look at your variant and you can see if that variant is present. And so in working with Sarepta, with the Jane Foundation, who's helped fund some of this, we've been able to actually go in and actually have an expert panel look, and we can actually demonstrate that whenever you look in ClinVar, these things become likely pathogenic if we identify them as pathogenic, and they'll say FDA recognized. And this can only be done through an expert panel that we're working on. And I would say that we've had great luck in doing that. This is just an example. I have a poster over here to kind of talk about our success. And so at present, I would say genetic test interpretation and what I call armchair variant resolution requires knowledge of both clinical and genetic muscle disease. And so that needs to be done by specialists. Systematic disease variant resolution algorithms that allow us to do that and online deposition of these databases will help facilitate clinical care and and that we probably still need to be doing some enhanced clinical phenotyping where we examine the patient and just make sure everything fits together. And so, I'm going to leave you with that. We actually have people that we have help with curating. We actually have patients that come on and help with curating, and I encourage you to reach out to me if you're interested in kind of doing that. So thank you.
Thanks, Chris. Okay, so our last speaker, before we get to the interview section, is Dr. Peter Kang. He's a pediatric neuromuscular neurologist, and director of the Greg Marzoff Jr. Muscular Dystrophy Center and professor of neurology at the University of Minnesota. And he'll be talking about how do we discover new genes and advanced sequencing technologies.
Thank you. Many thanks to all the conference organizers for the invitation to speak. So let's go ahead and get started and talk about some new genes. These are my disclosures. And this is the outline of what we'll talk about. We'll go through some historical views, a recent example of a new gene discovery, and some new sequencing technologies, just to give you an idea of what happens when you participate in research studies for genetics. So going back in history, in the 1970s, DNA sequencing became more of a feasible thing for single genes or parts of genes. And this is now called Sanger sequencing because there are other technologies now available. And then PCR was discovered in the 1980s, and these were both Nobel Prize winning discoveries, so they were quite remarkable and helped us accelerate genetic discovery. And then the first muscular dystrophy gene discovered was the dystrophin gene in 1986, with the accompanying protein described in 1987. So what's happened since then is we've gotten a much better idea of what the genes and proteins are that are involved in muscular dystrophy. And there's an enormous list now of limb-girdle muscular dystrophy genes. This is a chronological list arranged by year of discovery, and you can see that alpha-sarcoglycan and calpain are the two first ones. And you'll see many of these. For those in the audience who have genetic diagnoses, the genes that are relevant are probably on this list. And the techniques we're using have become more and more sophisticated. I'll just illustrate with what happened with calpain and the discovery of calpain, because it was a lot harder back then. Not that it's easy now, but there are different challenges now. But there are 4 key publications that I could find. One was from the early 90s, where they found that the gene for calpain was on chromosome 15, and just finding the chromosome was a big deal back then, and this is before the human genome was sequenced, and so the human genome made a big difference. And then in a second paper, they narrowed it down to a specific section of chromosome 15, and then there was another paper where they narrowed it down even more. And then finally, in 1995, they hit on the calpain gene, and that has led to a lot of discoveries since then about calpain and its protein product. And so it was quite a laborious process, taking many years, and it's become quicker in large part thanks to the Human Genome Project. One thing that makes it difficult now is that the more recent genes are a little bit more rare on the whole, so that it's harder to figure out if a variation we find is truly disease-causing, and can we really convince ourselves and other people that it's a limb-girdle gene. And so I'll just mention a recent discovery. There have been a number of them, but this is one that we published a few years ago, a new LGMD gene called JAG2, and we collected a number of families from around the world. One of the things that's helped us with gene discovery, in addition to genetic sequencing technologies, is advances in muscle MRI, and these patients had a distinct pattern on their muscle MRI that helped us realize that there was a common pattern that's emerging. And so muscle MRI has become a very important tool for diagnosis and tracking progression, and also for research studies. So for new sequencing technologies, again, looking historically, the karyotype was discovered a long time ago, and that's still useful today in certain situations. And then you'll see a long list of different technologies that have come up since then, some in the 20th century, and then some of them developed in the 21st century. There's still no genetic test method that's perfect, and by perfect I mean by picking up every single genetic variation that's relevant to human disease and not missing anything. So one project that we've been working on for a number of years now is nanopore sequencing, and we are focusing on limb-girdle muscular dystrophy as a target disease category just because there are still so many genetic mysteries. And this just shows the flow chart of how we go about analyzing these patients. My lab and Christine Bruels and several other people are representing our team here, but Christine has a poster up that has more details of these findings, but we've now sequenced over 61 patients. Since this table was put together, we've sequenced even more, and we found variations that have explained what's been going on with a number of these patients. So among the 61, we've published the first 10. This is back up several years ago now, and so we're hoping that as we gather more cases, we can publish a larger group in the near future. So some of what nanopore sequencing is helping us doing is solving some mysteries that really persist in LGMD genetics, and missing variants being one of the key questions, but also phasing, which I think Lee Kugelman mentioned that during her presentation. When we're talking about a recessive disease and we find two variants, are we sure that they're on two different copies of the gene? Because that's an important thing for linking it to disease. So this is an illustration of how we were able to sort out a beta-sarcoglycan case. And this illustrates, and I won't go into too many details in the interest of time, but this illustrates how we found the two variants, one of which was found commercially, and then confirmed that this was truly what was happening based on some PCR analyses and Sanger sequencing. We've recently discovered more of the power of phasing, which is we can figure out whether the two changes are on different copies of the gene just based on the single sample. Traditionally, you're supposed to get parental samples or other relative samples to really prove that the two copies are on different, that the two changes are on different copies. But now we can do it just from a single DNA sample on the affected individual, and this is for AN05. And then we have other examples for calpain. And the other thing that we are still doing is we're looking for new genes, and this is a gene called myo18B. So this gene's been linked to human disease before, including some potential muscle diseases, but it, to our knowledge, has not been linked to LGMD before. So this is something where we hope that we can find additional cases and see if we can validate this a little bit further. So in conclusion, the discovery of new muscular dystrophy genes always starts with patients, regardless of the techniques used. It's been over 30 years since the first LGMD gene was discovered, and we now have identified 40 or more genes. The new sequencing technologies are helping us, but we have other challenges, including interpretation, as you saw from Chris's talk. And then now more than ever, if you have ongoing dialogue between patients and healthcare professionals, that'll really optimize genetic test interpretation and also help us figure out what's going on. And I appreciate the comments about our study going on downstairs. So Christine and Seth are downstairs. For anybody who has kind of an uncertain result on genetic testing, whether it's a totally unknown case or whether you have part of an answer but not a full answer, please come talk to us. Or if you just want to hear more about what we've been discovering, you're welcome to stop by anytime or talk to me. And so Seth and Christine are in the back row of this photo on the left. Seth is on the left in the back row, and Christine is right next to him. And several others in the lab have really been working hard on this project. So we're really grateful for that. And for all of our supporters. And the last comment I'll make is for anyone who likes writing medical articles, Neurology Genetics is a great destination. And so please come also speak to me if you're interested in learning more about that. So thank you very much.
Thank you, Peter. So to end this session, Brad Williams will be interviewing Sarah Witherell. Did I say it right? About her journey to a diagnosis. So Brad is one of the conference organizers, and he's the director of research at the Jane Foundation. He's also a person living with LGMD R2 or 2B caused by mutations in dysferlin. Sarah lives in central Illinois with her husband, Micah, and their golden doodle, Winnie. She was diagnosed with LGMD at the age of 13, but her diagnostic journey took a pivotal turn at the LGMD conference in 2019. And today she is sharing her story to bring awareness to others in the LGMD community who may be living with a misdiagnosis.
Okay, so is a little bit of lead into the story. So you've heard a couple of the speakers this morning say that, well, okay, what if you do all the genetic testing, that's available to you and, it doesn't find anything? Well, one possibility may actually be that you have something that is non-genetic, that looks like an LGMD, but isn't an LGMD, in fact, isn't any genetic neuromuscular disease. So several years ago, one of my other colleagues at the Jane Foundation, Sarah Emmons, had a conversation with Karsten Bonneman, who directs a diagnostic service at the National Institutes of Health, and he and his team had found that a significant number of people who have LGMD-type symptoms turn and, genetic diagnosis, isn't leading anywhere, actually turn out to have an autoimmune muscle disease caused by antibodies to a gene called, or protein called HMGCR. And
Yeah.
Yeah. Okay. Is this better now? Yeah. Oh, okay. Thank you. So, anyway, since I had to wait a long time for my genetic diagnosis, most of it waiting for the gene to actually be discovered. So I have a soft spot in my heart for other people who, are waiting in limbo for a diagnosis. So I sort of posted this information, and then, with a literature reference when it, came out on the work done at NIH, saying, well, if your genetic testing isn't finding anything, you might want to ask your clinician to look into this possibility of HMGCR. And that actually has resulted in a few people from the LGMD patient community who turned out to have this non-genetic and treatable autoimmune disease. So Sarah is one of these people, and so she's going to talk about her story a little bit.
Good morning. My name's Sarah Yam-Witherell, and I appreciate the opportunity to be with you this morning. My diagnostic journey began similarly to many with limb-girdle muscular dystrophy. Leading up to the age of 12, I was very able-bodied and full of energy, but in my 6th grade year, I began noticing increased muscle weakness. And after a few years filled with doctor's visits and testing, I was diagnosed with muscular dystrophy. And over the years, my doctors felt confident that I had limb-girdle muscular dystrophy. However, we were never able to determine my genetic subtype and assumed that it just hadn't been discovered yet. So I was first diagnosed at Mayo Clinic a few years after the initial onset of muscle weakness. And then after college, I became involved with MDA and participated in the genetic testing through Emory with MDA. Did I lose you? Okay. Which remained inconclusive. I attended a few limb-girdle muscular dystrophy 2I conferences in Iowa City, pictured here, and we continued to work to discover my genetic subtype. It was at the Limb-Girdle Muscular Dystrophy Conference in Chicago in 2019 that I made an incredible discovery. During the Friday night reception, I was chatting with a group of friends, a woman named Jenna, see her in the bottom left-hand corner picture there, And we were speaking about how she was diagnosed with muscular dystrophy over 20 years ago, but she had just read an article being shared in a Facebook group about a condition that closely mimics limb-girdle muscular dystrophy. Shout out to Brad for sharing that article. Jenna had had a simple blood test done weeks prior, and to her and her doctor's surprise, she tested positive for this autoimmune condition, anti-HMGCR myopathy, which is a form of myositis. She did not have muscular dystrophy. And the exciting thing about her new diagnosis was that there were medications available to treat it. As I listened to her story and noticed many parallels to my own diagnostic journey without a genetic subtype, I wondered if I should look into it for myself. So after a few months, I decided to pursue the anti-HMGCR titer test just to be sure and rule it out. The results came back, and to my surprise and my doctor's, I had anti-HMGCR myopathy, and I also never had muscular dystrophy. The reason that we, and likely some others, were misdiagnosed over 20 years ago is because anti-HMGCR myopathy was somewhat recently discovered. Anti-HMGCR myopathy was first diagnosed and characterized in patients with a history of statin exposure. After the discovery of anti-HMGCR myopathy, several international groups identified and characterized more patients, expanding the phenotype spectrum of this disease to include pediatric patients and young adults without statin exposure, and those with chronic myopathy resembling limb-girdle muscular dystrophy. So moving on to how we're managing my disease, I began receiving IVIG infusion treatments for my newly discovered condition in 2020. And though I do have some severe muscle damage, the disease progression has stopped, and I began to see some slight improvements in strength and mobility. The diagnosis of patients with a limb-girdle-like presentation of anti-HMGCR myopathy is critical because these patients may respond favorably to immunotherapy, especially those with shorter disease duration. In addition to the IVIG infusions, the treatment plan for anti-HMGCR patients often include immunosuppressants, corticosteroids, and physical therapy. Since 2020, I've made an annual visit to the NIH in Bethesda and Johns Hopkins Myositis Center in Baltimore to see Dr. Andrew Mammon and his team, who contributed to discovering anti-HMGCR myopathy. I've included his information on a handout that I have here for those who are interested. After I shared my new diagnosis with Jenna, we searched for other patients and information online. We found no Facebook groups for anti-HMGCR myopathy, so Jenna created one. Today, there are 85 individuals from all over the world who have found our page to seek insight and community and share their experiences. I'm truly thankful for the conference organizers here today and the donors and participants that make this conference possible. By spreading information about anti-HMGCR myopathy, it's my hope that others who may be misdiagnosed may find answers and therapies.
Thank you, Sarah. So I think that one thing that this story shows is the value in both the work done by people at the NIH, as well as the power of the patient community that, we could sort of spread it around, among ourselves. And, wow, 85 people in this group. That's a large number of people to get treatments for.
Yeah, I would say it seems like there's a mixture in that group of newly diagnosed and quickly found the correct diagnosis of anti-HMGCR, and then many that were diagnosed with limb-girdle years ago and are just finding their correct diagnosis.
So the diagnostic process for this is improving?
I believe so. I know there's a few young patients who found the diagnosis quickly and got IVIG infusions in a short manner, and they're managing fairly well.
So what was your reaction on, learning that you didn't, in fact, have LGMD.
Yeah, after about 17 years of believing, you have a certain condition, and it was, I think, a level of shock on my part and my family's, and I think it really took about a year or two to sink in that that I had this other condition, and it did take about a year to get insurance to work with insurance to get access to the treatment. So after diagnosis, it was about a year of fighting with insurance to get the correct medications and treatment.
Thank you very much.
Thank you.
So I just want to thank all the speakers, and now we'll be moving into lunch, and I believe there's going to be a presentation during lunch, but in this room.
Hello, everyone. My name is Wendy Erler, and I'm the Senior Vice President of Patient Affairs at Sarepta. I want to begin by saying how incredibly sorry I am to be speaking to you today under these circumstances, which are heartbreaking. At the same time, we are deeply grateful to be among this community, to be surrounded by your strength, your unwavering support for one another, and for all of you who have been along this journey with us from the very beginning. At Sarepta, everything we do is guided by our commitment to patients and families. We hold ourselves to the highest standards, both in scientific rigor and in transparency, and we remain committed to walking this path together with you. Today, we share difficult news about our Limb-Girdle Muscular Dystrophy programs, news that weighs heavily on all of us. Many of you know Dr. Louise Rodino-Klapac, Chief Scientific Officer at Sarepta and friend to the Limb-Girdle community, someone who has worked so closely with all of you. She's unable to be here today and shared this message, which we'll share now.
Hello, I'm Dr. Louise Rodino-Klapac. First, I want to say how truly sorry I am that I cannot be there in person. Sarepta announced earlier this week a restructuring of our business, a restructuring that includes a narrowing of our portfolio and a 500-person reduction of our workforce. These changes were necessary to help ensure the future, and in fact, the very viability of Sarepta as a company. These are incredibly difficult decisions. The impact is far-reaching and prevented me from joining you in person. I know what's most important to all of you is what it means for our limb-girdle development programs. First, we plan to advance SRP 9003 for LGMD2E and submit our applications to the FDA this year. Second, we are not currently moving forward the remainder of our investigational programs for LGMD. We'll be working with investigators to close down current studies. Importantly, while we have paused these programs, we are actively exploring alternative paths forward, such as identifying a strategic partner to continue the important work of developing therapies for LGMD. To every patient, family member, and advocate who has participated in clinical trials, natural history studies, or awareness efforts, thank you. Your courage, advocacy, and partnership have been the foundation of everything we've accomplished. I've had the privilege of getting to know many of you personally. I've heard your stories, your challenges in getting a diagnosis, and your hopes for the future. It's these stories that have driven my work for the past 20 years. Today may feel like a setback, and I understand that deeply. But it's important to recognize the progress we've made together because of the combined efforts of advocacy, awareness of LGMD and its subtypes has grown significantly. More people now have access to genetic testing and understand the importance of a precise diagnosis. Together, we hosted the FDA's first ever externally led patient-focused drug development meeting dedicated to LGMD and demonstrated to regulatory officials the complexity and challenges of developing therapies for ultra-rare populations. We've gathered critical natural history data that will inform future research and development, and we're committed to sharing these data to support the community. Your contributions in shaping clinical trial design and defining what is clinically meaningful to patients will have a lasting impact on rare disease drug development. This work has led to having a one-time gene therapy candidate for LGMD2E, approaching FDA submission later this year. These are not just milestones, they are shared achievements made possible by your strength, collaboration, and unwavering commitment. We will keep you updated on our efforts to identify a partner, updates on our progress around 2E, and data. Everyone at Sarepta is deeply grateful to be part of this community. Thank you again. Words cannot adequately express my gratitude to this community. I'll now turn it back to Wendy. Thank you.
As you heard from Louise, over the past few days, Sarepta has had to share some deeply sad and disappointing updates. Most tragically, we recently reported the loss of a participant in our Sarepta 9004 Phase 1 study for Limb-Girdle 2D R3 alpha sarcoglycanopathy. We reported this very serious adverse event to the FDA on June 20th and followed up with notification of the patient's death on July 3rd. Investigators were also informed because this was a clinical trial for an investigational therapy and the study had completed enrollment and no future dosing was planned across the limb-girdle programs. This was the only study that was actively dosing. We communicated in a very intentional and according to regulatory and research processes. It is important to remember that the family who chose to help all of us by being in a clinical trial was devastated. Patients and families participate in clinical research only after much thought, working with their physicians, and knowing that they are taking a really big step to help everyone else. So in addition to sharing with regulators and investigators, we communicated this to the Limb-Girdle Muscular Dystrophy organization leaders. What this means is that we worked closely with doctors, the FDA, and advocacy first. I've worked in rare disease patient advocacy for my entire career across many different rare disease communities, and I've heard over and over and over, please tell us first. We don't want to hear news via a press release or an investor call and be taken by surprise. We endeavored to do just that. After the meetings of the past week, media pretty quickly got ramped up. In part, we had just had an investor call about the Sarepta organization changes that were required for the company to continue to be viable in the future. Also, adding to the complexity of all this, because Sarepta has been able to have the first and only approved gene therapy for Duchenne muscular dystrophy, and we had shared fairly recently over the last months the 2 deaths of patients treated with ELEVIDYS who passed away from acute liver failure. There were a lot of questions that circulated in the media and added to misinformation and confusion. For those of you who have been aware over the last few days, we are deeply troubled that this is the way this has all happened. Why were the Duchenne cases handled differently? At the time of the first acute liver failure case with ELEVIDYS, the Duchenne gene therapy that is available commercially, it was the first death believed to be associated with the gene therapy. Through years and years of clinical trials for ELEVIDYS, and then crossing the mountaintop of commercial approval for a gene therapy. This had not happened before. It was the first safety signal of acute liver failure. We are not saying that gene therapy isn't a difficult administration and a lot of surveillance and things monitoring that has to happen, and that patients have had clinical things that have to be managed. But this was the first case believed to be attributed to gene therapy earlier this year. In all of the years of study, we learned a lot about gene therapy. And in clinical trials, the patient focus is really narrow. The population is often small. We continue to learn more as a community once a medicine becomes available. When a medicine moves from the research to the commercial setting or the real world, we all continue to need to understand what's happening. A couple of months after the first case, a second person with Duchenne passed from acute liver failure. That was when we made the decision as a company to stop shipping ELEVIDYS for non-ambulatory patients. 2 serious adverse events warranted a safety signal that required this action of us. The second case was actually an older teen who had been dosed in a clinical trial. So there were 2. The 2 themes in the media that have come up, one, there was confusion about the third death from acute liver failure. It was not a person with Duchenne. It was, as we shared, a person with Limb-Girdle Muscular Dystrophy who participated in a phase 1 Limb-Girdle clinical trial. And 2, that it should be disclosed more broadly. We attempted to address, through an investor call yesterday and a media statement. Let me be clear, we would never, ever hide or not disclose important safety information. In fact, we did disclose. We did so following the process that all innovative drug development companies are held to follow, the highest standards of ethical and rigorous reporting. We disclosed to the right people at the right time. When something like this happens in a clinical trial, it's investigated and shared in a very intentional way based on the situation. This situation was a patient in a clinical trial that was at the phase 1 stage of research. A research drug that is not available outside of a clinical trial. No further dosing was planned for this study. It was small, and he was the last person enrolled. Above all, we are deeply sorry for the family who deserves privacy and time to grieve in this awful situation. We were very devastated that so many of the details were shared in media reports yesterday and probably hurt them a lot. Kat will share more about the family and honor them later. As it relates to the overall Sarepta Limb-Girdle programs, as you heard from Louise a few minutes ago, and many of you may have heard during the Sarepta investor call on Wednesday, we made a very significant company announcement, including the incredible, difficult, and not easy decision to not advance our other Limb-Girdle Muscular Dystrophy research programs in gene therapy. Since we are a public company, this type of announcement had to be first shared with investors and not with all of you first. We immediately did follow up and share with the advocacy community that this news had happened. And we shared a community letter as well. I want to assure you that our product portfolio updates were not a consequence of the death in the 2D trial. It does not reflect a lack of commitment and care and belief in this important work and this community and everything we have done together to advance research and drive disease understanding. On the contrary, it's because of the tremendous progress made, thanks to all of you, that we are committed to finding the right partners to carry these programs forward. Let me also clarify that given its stage of development and where we are with research for Sarepta 9003, the program for Limb-Girdle Muscular Dystrophy 2E-R3 beta, will continue through the regulatory process. That is expected to advance in the second half of this year as planned, including the strong efficacy data from Emergene that many of you are aware of. We expect this process to continue and will keep you updated. Throughout the years, your advocacy has driven true momentum. Regulatory process, genetic testing, variant resolution, and the unification of voices, led by the amazing Speak Foundation, has really changed the path forward for Limb-Girdle. Advocacy has made a real difference, and bringing awareness to this community, and all of our voices are critical. We all need to work together at this time of uncertainty. There are many external events happening around us and a lot of communication that's coming at us. We need to really elevate and make sure that what we're sharing is ethical, truthful, and helpful. We are committed to ensuring that our work together, including the Journey study, the large multinational natural history study in Limb-Girdle, can move the science forward. We are considering the best ways to share the data, including publication and communication with the patient community about the data. We do not yet have specifics or timelines, but this is an urgent priority. We will continue to support the sharing of science, and we will do everything we can to ensure the momentum you've built continues. Thank you for allowing us to be with you today. Thank you for all of your contributions, and we will work together going forward to get answers to all of your questions and share those as soon as we can. Thank you.
So we're going to go ahead and start this lunchtime symposium.
How long should I wait until the point
So thank you for attending. So I feel like I'm leaning here. So my name's Matt Garrow. I'm from Treat NMD. Lovely to be here with you all in Orlando, meeting members of the LGMD community. We are thrilled to be announcing the launch of the Limb-Girdle Muscular Dystrophy Guide for families, caregivers, and healthcare professionals. This is the culmination of 2 years' work between clinicians, patient advocacy organisations, the Treat NMD team, our design team, and many of the authors of the guide are in this room today. And this was in response to a critical need shared by the community. The community told us that they needed an updated, public-facing guide written in layman's terms. And we are excited to say today that this is available now on the Treat NMD website. We have QR codes at the Treat NMD booth. I'm also joined by my colleague Annie from Treat NMD. Annie, do you want to give us a wave? And we're here to answer any and all questions that you may have on the guide itself, and we can hand out QR codes for people who want to access the guide. So we're pleased to also have Professor Volker Straub and Rachel DeConte here to share more about why this guide is so important for the community and how patients and families can self-advocate using it. We really believe that patients should become experts in their own diseases, and we hope that this guide will help them achieve this. So please join me in welcoming our panel guests. First, Rachel DeConte. Rachel has been a part of the LGMD 2D Foundation since 2021, shortly after her son Jacob was diagnosed. And her commitment to raising awareness of LGMD is fueled daily by Jacob and her desire to assist other patients and families affected by LGMD 2D or R3. She's dedicated to the entire LGMD community and actively engages in partnerships with other LGMD advocacy organizations to help build global impact for LGMD patients. Professor Volker Straub is the Director of John Walton Muscular Dystrophy Research Centre in Newcastle and Deputy Dean for Newcastle's University's Translational and Clinical Research Institute. And with that, I will welcome Volker up to the stage to tell us more about the guide itself.
Impressive. So while you are enjoying your lunch, I don't want to introduce myself again, but just to mention also, TreatNMD is a global network that was initiated in 2007 to accelerate what we call clinical and translational research for neuromuscular diseases. So to make sure that there are trials and that the community is ready actually for clinical trials. So I was one of the co-founders of the TreatNMD network, and I'm on the board of directors for TreatNMD Services Limited, which is the business arm of the global network, and also a trustee on the TreatNMD Alliance Limited, which is a company that basically is a shareholder for TreatNMD Services Limited. I'm also the academic lead for the TreatNMD Therapeutic Advisory Board TACT for the Therapeutic Advisory Committee. Now, for those of you who have been diagnosed with limb-girdle muscular dystrophy, most likely at the time of diagnosis, you had never heard about this disease before. And when you asked relatives or friends, they will have never heard about this disease before. And with this diagnosis, there is this feeling of being lost a bit, you know. How can I learn something about this condition? This is why the family guide and the caregiver guide, or the guide for patients, is so important, because it will give guidance from the day of the diagnosis throughout the course of the disease. Limb-girdle muscular dystrophy doesn't go away, so it stays with you, and the guide is offering guidance throughout this journey of the condition. With improved care, we have heard this morning, we also improve the chances of clinical trials, because it's one of the prerequisites that patients are comparable, have the same care standards. So again, this is where the guide really provides enormous opportunities to also incentivize companies to invest into clinical trials. Now, you could ask, why did it take so long that we created this care guidelines? We heard that the first limb-girdle muscular dystrophy gene was discovered 30 years ago. Now, one of the reasons why it took so long is because we're dealing with ultra-rare diseases. And for many years, researchers and clinicians like myself, we were quite excited to be able to make a diagnosis. We had to understand these diseases. We didn't think at the time about care or treatment, because there were no treatment options. So for many, many years, the achievement was really having genetic diagnosis. And then once we were able to diagnose more patients, we also got a better understanding about the disease course. But it took a long time. And it's only when we had enough patients, we started to do natural history studies. And of course, first of all, we informed the clinical community, the healthcare professionals, about these diseases. So this is why it took so long. It's also that these care guidelines often are developed once there are treatments. And because we didn't have any treatments for limb-girdles, again, that delayed the process a bit. And then finally, there are 34 different forms of limb-girdle muscular dystrophy. So to have guidelines that are meaningful to everyone was also a challenge. But you're all here today to actually be part of a world premiere because this is the first time these guidelines are introduced to the public and the community. And as Matt said, this was a process that took more than 2 years. It was a collective effort between key opinion leaders from the scientific and clinical side, and then joining these efforts were people from the advocacy groups. And it was extremely important, of course, to hear the patient voice very loud and clearly during this process. So here we are at the launch of these guidelines. Matt already said we currently don't have printed versions, but you can download those. There will be QR codes that you can screen with your phone and get a link to the guidelines that are online now. Just to give you an idea about how they look, of course, the idea was to make this patient and user friendly. We mentioned this morning that in terms of standards of care, it starts with the diagnosis. You have to understand what the diagnosis means. And then there are different aspects of care depending also on your condition. There is advice that applies to limb-girdle muscular dystrophy more generally. There are user-friendly text boxes for learning and getting the main messages. There are many illustrations in there. And then for the most common forms of limb-girdle muscular dystrophy, there are also very disease-specific advices and guidelines about cardiac care or respiratory care. So hopefully you will find that the format of these guidelines is understandably, doesn't use jargon, and helps you. Now, in what way can the guidelines help you beside informing you about the condition? Well, you will all have regular care appointments as well, and the guidelines will also give you an idea, what should I be aware of when I go to the clinic? What should I actually ask my clinician in terms of care? And the guidelines and you will also help to educate healthcare professionals, because unless you see an expert and they are rare, we also need to make sure that the medical community is also educated about limb-girdle muscular dystrophy. We heard this morning from Meredith James how important it is to know how to deal in an emergency situation. And again, the guidelines can be shared with emergency teams. If you have to go into a hospital that you are unfamiliar with because you had a fall or a fracture, use the guidelines, take them with you, not necessarily the printed version, even if you have the QR code or the link to the online version. Point them out to the emergency team. So the guidelines have a strong educational aspect, educating the community, educating healthcare professionals, educating each other. And with the guidelines and the education, this allows us also to build partnerships. What's also important is that guidelines don't apply what we have published at a specific point necessarily, where when you're the diagnosis, you may not need additional information, but in an emergency or when you need a wheelchair or when you need cardiac care. So it's a journey, and again, the guidelines will cover this entire journey. So I'm very excited that we are now in a situation where we can support the community with these guidelines, and both Rachel and I would be very happy to answer any questions that you may have about these guidelines and how you can use them. So thank you very much for your attention. And this is the QR code if you get your phones out. Hopefully it's big enough to screen.
Thank you, Volker. And yeah, we've got QR codes to hand out for people to take away at the Treat and MD booth just outside, so you can get one of those. Just also wanted to take a minute to thank the author group who helped compile the family guide over the last 2 years. Listed on the screen there, obviously, as you can see, a real a team effort from a range of different people from the community. So thank you all for helping make this happen. So I think we're going to turn it over for Q&As. The original plan was to do a quick panel discussion, but we think it's more important and it's best to hear from the audience themselves. So I believe there are people with microphones who can assist with asking questions for Volker or Rachel. So who wants to go first?
I mean, this microphone, we don't need this. Sarah, here's a microphone.
Hello. Thank you very much for putting these guides together, because as we are working for a treatment for tomorrow, it's really important that people are getting the best care that they can today. I haven't, of course, seen the guidelines yet, but I want to thank you for putting this together, and I understand that it takes time and it's a labor of love. But one of the questions I had is, you mentioned that for certain subtypes there is cardiac information. Is there an outline of what kind of surveillance is appropriate for people with these diagnoses? Because I think if you go to a cardiologist and you say, oh, I have a muscle condition, they really don't understand what's needed or what's next. So anyway, I will take a look at what's in the guide, but I haven't got a chance to see it yet. So that was my question about cardiac surveillance.
Yeah, so this is an extremely important question that people often wonder, how often do I need to be seen by a cardiologist? So within the guideline, there are recommendations about cardiac surveillance, which limb-girdle muscular dystrophy should see a cardiologist and how often. So you find exactly this information in there. It is, of course, important that you coordinate this or discuss this also with your neuromuscular care coordinator, but yes, there's specific advice about cardiac care in the guidelines. If you want to make any additional comments, just feel free to.
Any other questions?
So if you have more questions, so please feel free to ask now. Otherwise, we will have a panel discussion with questions coming from Matt.
Any other questions? No? Okay.
When our daughter sees the dentist, what sedation method is best? Like a shot in the jaw or nitrous oxide, or what's the safest method for those type of procedures? Things.
So, if I understood your question correctly, this was about dental care and anesthesia.
Yes.
Yeah. So the risk factors for anesthesia are normally your respiratory function or your heart function.
Yes.
So it very much depends on, how good your respiratory or heart function is. If the respiratory or heart function is compromised, you should have anesthesia in a center with experience about neuromuscular patients. The risk is always also, even with dental procedures, if you are in a remote hospital where the anesthetist might have no experience with potential complications, and therefore we would recommend, and the care guidelines recommend as well, that you should get expert advice. For minor dental procedures, normally it's not an issue. But as soon as this might compromise your respiratory function, you need to be in an expert center.
Wonderful, thank you.
I mean, much feel free to just ask questions as well for Rachel in particular.
Yeah. Just wait to see if there's any more. Any other questions from the audience? All right. Rachel, I think I'll start with you. Obviously, everyone's heard from me and Volker a lot in this session, so I think we'll turn over to you. So, as you've been so heavily involved in helping create this guide, could you tell us why the guide is so important for the LGMD community?
Yeah, I first want to say that as a parent of a son who was diagnosed 4 years ago with LGMD 2D, and on behalf of the LGMD 2D Foundation, I was absolutely honored to be asked to be a part of this guide, as it is so important to our community. We, when we were diagnosed 4 years ago, as I mentioned, there were very limited resources, and what I had wished for was this one-stop shop for all of the best information from the best minds in clinic and in our patient advocacy groups to come together. And this is what that source of truth is. So for this community, it's so important, and as was already mentioned, it's not just a guide that's for newly diagnosed patients. This is a guide that is for anybody along their LGMD journey, because there are critical chapters against every step of the way, from diagnosis to, as we mentioned, cardiac, respiratory, neuromuscular management. This will be helpful for everybody, and not just as patients, caregivers, parents, but also as being able to share, as mentioned, with family members, the community, the schools, and even your pediatricians or PCPs that are less familiar with LGMD.
Thanks, Rachel. And Volker, how can the guide help those with lived experience of LGMD?
Sorry, can you just repeat this? Sorry, I didn't.
How can the guide help those with lived experience of LGMD?
Yeah, I think we already mentioned this. This guide is allowing patients to be empowered with ultra-rare diseases. Even though it's a strange concept often, the patient needs to become the expert. You will have all experienced this, that you meet a healthcare professional who feels completely overwhelmed by a diagnosis of limb-girdle muscular dystrophy and then a subtype. So the family guide really empowers patients to also let their healthcare professionals know what they need. And it's a lot easier to come with a document that has been endorsed by the global community, rather than with a personal view about, oh, I should get this. Now you can say, I should get this because this is what the international care guidelines for LGMD recommend, and this is based on consensus from experts around the world. So this really empowers you to also request care that you may not get otherwise.
And if I could just add to that with a specific example, there's been a couple of times my son has been hospitalized with rhabdomyolysis, and there's a lot of times in those hospitalizations that I'm providing our local hospitals with information on my son, what his CK levels are, what they should be. There's information that I, as a parent, am giving them that in a time where I'm also scared for my son, I don't necessarily fully want to be worrying about. So being able to provide hospitals, doctors with this guide to share this is the disease he has, and inform them, so I have to take a little bit of that off of my shoulders, is going to be critically helpful. And the fact that we wrote this, every chapter was written by a patient advocacy leader as well as a clinician. We ensured that there was critical clinical data, and information, but also it was written in a way that'll be understood and helpful to the patient community.
So, Rachel, what should be the motivation for individuals to read and utilize the document?
The motivation is understanding the disease in a better way, right? Being able to inform your peers, as I mentioned before, your community, your family, and understanding it yourself. You are, as a patient, as a parent, as a caregiver, your best advocate. We often say that nobody's going to fight harder than you are for your disease. So having this power of a resource behind you is going to be able to help you and armor you with that knowledge to be able to use it going forward. And again, the support now physically of being able to share a guide will also help you have more informed conversations and push harder for this community. So it's critically important, and everybody should be motivated to use it.
And question for you both, what are the opportunities for the future with this work into 2026 and beyond?
So I think we all understood that care changes over time as well. The natural history changes of disease. There are new ways how to assess, for example, the progression of the disease. So I think care guidelines therefore need to be adjusted. So the future will also mean that we need to critically review them. Hopefully, we will also come to a stage where there are drug treatments available. Again, the care guidelines would then need to be adjusted accordingly to make sure that we have an understanding how drug treatment gets integrated into care. So the work on standards of care never stops, but it's very important to now have information in one place rather than being very fragmented. And you know very well that you often want to make sure that you're not missing anything. And if you're on the internet and you Google for limb-girdle muscular dystrophy, you get, hundreds of sites. So now I think the information is in one place, but for the future it means we need to make sure that it's always updated as well.
I was going to add similar, the evolution. So now that we have a good source of truth, continuing to circle back and make sure that it stays up to date and evolves as new science comes, research, treatments is going to be critical for this community, and we're definitely committed in doing so. So, we have this step with the guide that we're all feeling very, very good about for this community, and continuing to evolve it and share it and raise awareness of LGMD is the next step in 2026 and beyond.
Okay, thank you. I just had a question from the audience, which I will answer. The question was very simply, where do we find this guide? So at the minute, the guide is on the Treat NMD website, so that's treatnmd.org. We have an education section on the website. You'll see there are, we have all of our family guides there, which are, the Duchenne, SMA. Happy to say that there's now an LGMD family guide there. You can download the guide, or we have a flip book option where you can just read it on the website. It's also been designed specifically that it can be printed as well. So if you want to print it off, that is possible. In terms of here today, if you just catch me or my colleague Annie at the Treat NMD booth, we've got a QR code with more information on there that you can take home with you. And that will also get you to the guide. So just see us at the booth, or if you happen to walk past the booth and you see a little square design card, just take one. They're for people to take away. So hopefully that answers that question.
And just quickly, Matt, too, one of the things that as the patient advocacy organizations, part of our job is obviously helping to inform you, right? So we will partner with Treat NMD to share the links to the guides. You'll be able to find it on the different advocacy organizations' websites. So all of the exhibits here today were a part of the advocacy organization exhibits were a part of the development of this guide, and you'll be able to gain access through our advocacy organizations as well.
Okay, so final question. Are there any other developments with this project that the community should be aware of, and what are the next steps?
You want to? Yeah, I didn't fully understand.
Do you want me to answer that, Volker? So I think the immediate plans is obviously to disseminate the guide as far and wide as possible, and raise awareness that this is a resource for the community. And we are looking at additional translations. Obviously, the guide at the minute is available in English, but we would love to be able to expand that. Again, if you go to the TreatMD website, you'll see with our other guides we have multiple languages. So that would be something we'd be looking to do. We may also look to expand to include all of the subtypes at a future point as well. And we may look to try and get the guide in printed format as well and disseminate that across centres globally. So those are the immediate plans. Okay, thank you for joining the lunchtime session. And thanks to Volker and Rachel for being our panel guests.
My name is Jennifer Levy, and I'm with Coalition to Cure Calpain 3. It's my pleasure to welcome you to How Does an Idea Become a Drug? Moving from Lab to Clinical Trials. So I'm really excited about this session because it's going to teach you a little bit about discovery research and the whole process of getting from the lab, bench, moving into animal models, and eventually getting to clinical trials. So our first speaker today is Dr. Kevin Campbell from the University of Iowa. He's professor of molecular physiology, as well as the director of the Paul Wellstone Muscular Dystrophy Center. So welcome, Kevin.
Can you hear me? Turn this mic on. Can you hear me now? Good. Well, thank you, Jen, for that introduction. I'd like to thank Kat and the Speak Foundation for inviting me to this exciting conference. And what Jen, the original title she gave me was How Does an Idea Become a Drug? And that's really an exciting topic for me. I love ideas. Ideas in research come from basic science research, from clinical research and translational research. And ideas eventually lead to therapeutic approaches. And we really need to start with new ideas to approach them. Some are very simple. One place I get ideas from is interacting with patients. So there's no questions at the end of my talk, but feel free to stop me and ask me questions. Lots of times patients present questions that lead to new ideas for research. So let me start. I switched the title of my talk to Basic Science, How Does Basic Science Research Lead to a Drug? And I'm going to try to explain how research at the University of Iowa led to the discovery of the sarcoglycans and the dystroglycanopathies. So when I arrived at Iowa in 1981, before some of you were born, basically I was a muscle membrane biochemist. I was interested in a simple process in muscle called excitation-contraction coupling, where depolarization of the membrane leads to calcium release, that leads to muscle contraction. I had no idea about muscular dystrophy. This project may be related to malignant hypothermia, but it really wasn't any type of disease-focused research. But really, it developed all the tools I needed to study muscular dystrophy 10 years later. So this process of EC coupling occurs inside the muscle cell, not like where you normally see where we're looking at the muscle membrane, but inside the muscle cell. And I worked for around 10 years characterizing the components of this process of EC coupling. And finally, at the end of 10 years, we did this experiment in the lab. We tried to isolate an EC coupling complex. And that's shown there on the left. And to our surprise, we were really isolating dystrophin and its associated proteins. And you can see on the right there, dystrophin staining. And so this was a project on basic science that led to a discovery of dystrophin being part of a membrane complex. We went on to purify that complex, and then you can see in fractions 10 and 11, you see the DGC complex. And it ends up, this complex can lead to various forms of muscular dystrophy. So initially, we just drew a cartoon model. And so when you see models like this, these are just made up in the lab. Ivan Kobayashi put this one together, showing the dystrophin, dystroglycan, its links into the extracellular matrix, the sarcoglycan, sarcospan. And this complex, this drawing, really gave us an idea of what dystrophin and these proteins were doing. They were linking the inside of the muscle cell to the outside of the muscle cell. And this protected the muscle cells and prevented muscle eventually damage and muscle cell death. And so this gave us a working hypothesis to work with and new ideas. But this is not really the structure. And for years, we thought of ways of trying to get the structure, but it wasn't possible. And then by chance, one of my postdocs went back to China to visit his family in China, and then COVID hit. And he was stuck in China for a year. And being stuck in China, we investigated other labs, and there was a lab at Westlake University in China, headed by Wu, and his lab was doing cryo-EM work. And we couldn't do that at the University of Iowa at the time. And so we started this collaboration. Tandy purified the DGC for them, and they went on to characterize using cryo-EM. And so this is a much more complex structure. This is the actual structure. It shows you that the sarcoglycans, dystrophin, dystroglycan are all really tightly associated. This complex really has one function. The sarcoglycans are not separate, the dystroglycan's not separate. It's really a tightly associated complex. And this really gives us clues and new ideas of how this might function and also for possible therapies. Now, one of the things we did before we had this structure was to look at muscle where dystrophin was missing. And to our surprise, when we did this experiment, the MDX mouse wasn't around. We had to use patient muscle, Duchenne muscular dystrophy patients that were missing dystrophin. And we found that all those other components in the DGC complex were dramatically reduced or missing. And this really suggested a new idea for other types of muscular dystrophy. And at the end of that paper, we wrote this sentence: finally, a deficiency or defect in a dystrophin-associated glycoprotein could perhaps explain DMD-like symptoms observed in suspected autosomal recessive patients that express normal levels of dystrophin. And that's the limb-girdle muscular dystrophies. So it's really by the discovery of this complex led to the discovery of these proteins that also can lead to muscular dystrophy. Because they're not on the X chromosome, they lead to autosomal recessive muscular dystrophy. And it's a good example of how initial basic science research can lead to discoveries that really are quite useful for clinical and translational research. Now, our lab and other labs went on to study the various components in this complex, and we found that it really is a hot spot for various muscular dystrophies. The sarcoglycans, all four of them can lead to limb-girdle muscular dystrophy. We have the dystroglycanopathies that can lead to both congenital and limb-girdle muscular dystrophy, and as is well noted, Duchenne or Becker with the absence or the abnormal dystrophin. So now thinking about potential therapies, okay, I'm going to talk about two possible therapies that are currently being tested or being planned. One is dealing with the sarcoglycanopathies, the AAV gene therapy or gene transfer, and the second is the dystroglycanopathies, ribitol or gene transfer work. Now first, the sarcoglycanopathies. When one sarcoglycan is missing, you can see in the panel there, minus, minus. This is a mouse model, but patients are the same. All the sarcoglycans tend to be lost or dramatically reduced. If you look at the DGC complex, in the wild type case on the left, you can see a nice complex is formed, but when one of the sarcoglycans is missing, the complex is disrupted. So you disrupt that function of that important complex. So this gave us an idea that could we put back one sarcoglycan in this mouse model and restore function? So there was a simple idea of gene transfer. Now there's several ways you can approach a therapy. The easiest, and one that we did first, was prevention. And this is where you restore the function or restore the gene before the onset of disease. So you really have normal muscle, and before you see disease progressing, and you restore the function, and then in that manner you can see restoration of function. The other way, which is more difficult, I'll present at the end, is restoration when you try to restore function after the disease has taken place. So for this study, we used a hamster model that was missing delta sarcoglycan. That's shown there, Bio 14.6. And if we used a gene transfer, at that time we were using adenovirus, you could see that if we injected adenovirus into the muscle, we restored delta sarcoglycan there at the bottom. So this was quite promising. The next step was to see, did we restore all the sarcoglycans? And that was the case. You can see here, after administering the delta sarcoglycan, all the sarcoglycans return to the plasma membrane. You actually can tell the delta sarcoglycan is being a little bit overexpressed. You see internal staining there, and that's something that you would need to kind of correct, for patient therapies. The next thing was to look at what happens to the DGC complex. And shown in the center is the hamster model, and that DGC complex is disrupted, is not present. However, after gene transfer, shown there on the right, you can restore the DGC complex. So this is another step saying that we're putting back the delta sarcoglycan gene, it's being expressed, it goes into the DGC complex and is now expressed at the membrane. And finally, to think about looking at function, we did an assay where we take the hamsters and we inject them with delta sarcoglycan, and then we inject a dye called Evans blue and exercise them. And when you do that, the cells that get damaged show up in red. Actually, Volker Straub, who's here before, developed this assay when he was a postdoc in my lab. And what can be seen is after gene transfer, the cells that are positive are the ones shown in green. They have delta sarcoglycan. They're protected. But the cells that you can't see but that show up in red are the cells missing delta sarcoglycan, and they get damaged. So this showed us evidence that we were restoring the protein and it was actually functional. Another way of looking at this when you're doing prevention is to count the number of nuclei that are in the center of the muscle cell, and that's dramatically reduced if you do gene transfer. And all these gene transfers were done in the first week of life for the hamsters. So again, it's prevention of disease, not treatment later on. So now if we go to the other aspects, one of the things we wanted to see is could we study restoration of disease? And for that, we actually started to study the dystroglycanopathies. So the dystroglycanopathies were originally described as being deficient in glycosylated alpha-dystroglycan, and that was an assay on congenital muscular dystrophy patients. And then an assay was developed with patient cells, with skin cells, to show that the glycosylated form of alpha-dystroglycan was missing. You can also see the laminin binding was dramatically reduced. And at this time, there were many genes being discovered for the dystroglycanopathies all over the world, and the functions of these genes were quite complicated. After a number of years, we finally figured out that these genes form one glycan that's put on dystroglycan, probably two sites. And this glycan, it has an extension that binds into the extracellular matrix, but it's quite complex. There are many steps to make this glycan. And you can look there, I'm not sure if you can see it, but FKRP is there in the middle, putting on ribitol phosphate. And so this was really a complex glycan that was being produced. Sorry, can you go back one? Let me see how I can do it. On alpha-dystroglycan. This suggested that there might be other ways of looking at therapies, and I'll show that in a moment. So the dystroglycanopathies are both congenital and limb-girdle muscular dystrophies. The most prevalent is the limb-girdle 2I. There's over 18 genes now involved in the dystroglycanopathies, and it's a growing list of genes. Kathy Matthews just figured out another gene at Iowa. And they have a spectrum from mild limb-girdle muscular dystrophy to very severe congenital muscular dystrophy. The hypothesis is that you're missing this link where that big X is here in this model. You're missing the link between the complex and the extracellular matrix, and that leads to the muscular dystrophy. So different than missing a protein, here we're missing a sugar glycan residue. Now, the exciting thing about the dystroglycanopathies is that they are caused by enzymes. So the enzymatic nature of the dystrophloglycanopathies really provides insights into therapies, because these are enzymes that could be modified and hopefully increase their activity, which would then restore function. So for the dystrophloglycanopathies, if you're missing any of these genes, it's lethal, and so you're not born. But basically, most of the cases are mild missense mutations that lead to reduced activity. And so one way of thinking about this is developed by two groups, Kilu and a group also in Japan, thinking that if you could increase ribitol, and you'll hear more about this tomorrow in the clinical trials on this, you could increase the activity of the mutant FKRP. So here you're adding more ribitol, which then would increase the amount of ribitol CTP, okay, and that would lead to an increased activity of the mutant FKRP. The enzyme that converts that there is ISPD. And increasing that FKRP activity would then lead to more matriglycan and rescue the phenotype. And this works quite well in mouse models. But a lot of therapies do work well in mouse models, and now it needs to be tested in patients. Also, this presents that there are other possible therapy approaches with mutant FKRP. If we could develop a non-ribitol compound that would increase its activity, we could also lead to a potential therapy. So this gives us really several different ways of approaching the dystrophloglycanopathies by using the nature of these enzymes. And the final thing I'd like to present is restoration. And this is a project actually, again, was started by patients coming to us at our conference in the summer. And they were realizing that a lot of therapies were being now targeted towards younger and younger patients. And they were asking, you know, what's going to be done for older patients? And that's restoration, when there's really are symptoms of the disease. And so a postdoc in the lab, Takahiro, really decided to take on this project. He's a pediatric neurologist who's back in Japan now. And he used the MYD mouse as a nice mouse model for this study. This mouse is missing the LARG, an enzyme in this process, so it's missing matriglycan. And previously we had shown if you took newborn MYD mice, you could restore matriglycan quite easily and protect the muscle. So prevention was working quite well. But what we really wanted to do was look at restoration after the disease took place. And this is a particularly nice model. The MDX model is quite mild. This model is quite severe. So you can see in this slide that around half the mice have died by the age of 35 weeks of age. At 60 weeks of age, all the mice have died. They have a severe pathology, and you can see that nicely here in the staining. Sirius red shows the collagen staining, the fibrosis. And so basically, it's a very severe mouse model, and we were going to treat at 35 weeks of age. And when we did that, and this was using AAV large, we saw restoration of matriglycan, not shown here, but restoration of laminin binding. This is nice because this is a quantitative measure. So it's really restoring the laminin binding, which was the key feature that was missing in the dystrophloglycanopathies. We've also been developing some non-invasive assays for the mice where we can test them and not have to sacrifice the mice. And this is one where we look at activity. This is looking, I think, at vertical activity. But basically, in orange there is the MYD mice, and they gradually lose their ability to move around the cage. But in green are the mice that have been treated at 35 weeks of age with AAV large. So this suggests that even treating mice at that age where there was a severe pathology, we could seem to restore function. And finally, the most exciting result was we looked if these mice could survive. And shown there in green, all except one mouse went out to over almost 90 weeks of age. So these mice were able to survive. Now, that's not perfect. These mice don't have total restoration of respiratory function or grip strength. So there's still things to work on. But this suggests that in at least this mouse model, restoration can be quite useful. So I'd like to end there and thank my group at Iowa, the Wellstone group, Kathy and Steve, who most of you know, and also thank the patients that come visit us every summer and for all those questions they ask me, which lead to new ideas. Thank you.
Thank you so much, Dr. Campbell. Can you hear me? Thank you so much, Dr. Campbell. Our next speaker is Dr. Sharon Hesterly. Dr. Hesterly has been in the muscular dystrophy field for quite a while. She's served in patient advocacy, and she's also been in biotech, and she's currently the interim president and CEO of the Muscular Dystrophy Association.
How about now? Is that better? I had to plug it in. Okay, we'll start learning about education these days. Thank you so much to the Speak Foundation for inviting me to talk, and this is the wrong talk. Okay, so I don't know if the group can switch it out, but this is actually the old talk. Is it possible to change the talk? If not, I can give this one. I like the other one better, but I'll give them just a second to see if we can do that. And I think you guys will like the second one better too, because it's slightly shorter. No one's ever complained about a talk being too long. Okay, so while they're looking into that, so I'll just say that, so perfect, thank you. So following Dr. Campbell's talk, you get some idea about all of the work that has to go into understanding, especially in limb-girdles, where we have so many different genetic causes of this disease, identifying the gene that's responsible for the symptoms, and then really trying to pick apart that pathway, what's going wrong in the cells specifically, because everything in that pathway that's a problem for the cells also becomes a target for drug development. So maybe, if there's an enzyme that's not functional enough, like in FKRP deficiency, there's a lot of things you could do. Maybe you could make that enzyme work better. Maybe you could add more of the enzyme substrate or material, which is what we've ended up doing. So there's a lot of work just to get to that point. But after you do and you have some ideas, the question is, how do you make those into drugs that you can feel confident you can put in humans? So just an idea, there's a lot of different approaches that are either feasible in limb-girdle or actually people have been looking into. Many of these are still in the preclinical stage. So by preclinical, I mean all of the work that goes up leading up to a clinical trial. So typically things that haven't been tested in humans, but here are a large variety of things. A lot of these are sort of genetic-based therapies because the limb-girdles are all genetic diseases. But just to give an idea of the different things that we could do. So how do you get from a good idea, like Dr. Campbell has described, to a drug that you can put in humans? You start with basic research and discovery, as we just talked about, but then the next stage is preclinical research. So that's, sometimes you have to do a drug screen. Say you have an idea that there's a molecule you want to change, and you can screen drugs. You can screen FDA-approved drugs, or you can screen totally new drugs to try to find something that will work. For gene therapy, a lot of times you might be trying to find the right delivery mechanism. You know what gene you want to replace, but how are you going to get it there? When you have something you think would work, you do what we call proof of concept testing. That usually takes a while. It's usually done in an animal model just to show, okay, if we test this, can it work? And they're usually quick experiments to say this is feasible. It's worth following up on. And then you get into what we call really translational research. So we said, okay, we've got a drug candidate. We have to do all this work before you put it in a human. You really need to understand if it's safe. You've got to figure out how to dose it. And then you get to clinical trials. So these timelines down below aren't hard and fast, and also where the work is done can sometimes be a little slippery. Sometimes academic laboratories do drug screens, for example. Sometimes those are done in companies. But this is the general way this happens, and it takes many, many years. Frequently, an example is I know MDA put a lot of funding into a drug for Duchenne that has now been approved. We started funding that drug, I think, in 2009, and it was approved in 2024. So there's an example, and that's a Gomri. It's a form of a steroid that doesn't have as many side effects. So that's not untypical, just to give you an idea. So let's see. Here we go. So just a little bit about why preclinical research matters. So the work that you do up front is really important. So we do know that many drugs fail in clinical testing. The more work that you can do ahead of time to try to optimize your chances, the better. And right now, I think the cost of a new drug is $2.28 billion. Now, I'm going to give a caveat there and say that doesn't mean that developing a drug for limb-girdle is going to cost $2.2 billion. But that's the average cost of a new drug. So that could be a GLP-1 inhibitor or, a cardiac drug that has a big market. That amount takes into account the cost of failure because a lot of these things, a lot of them do fail. So that's why that number is so inflated. The actual cost of developing a drug for limb-girdle probably are significantly lower than that. You just sometimes have to absorb the cost of all the ones that don't work. So just a little bit about discovery. So understanding the disease and what could be going wrong is important. Coming up with a target, a molecule that you think you're going to try. And then just below, there's an example of some of the different kinds of molecules that we could test. So small molecules, these are things like, say, an aspirin is a good example. This is usually a compound that you can eat. You can take it orally, it goes through your digestive system, it goes into your bloodstream, and it gets usually to many different organs. The others are a little more focused. These things that are based called biologics on either DNA or proteins or cells usually have to be injected or infused in some ways. If you eat them, they'll be digested just like a steak would be. So that's sort of the difference in these things. So these are some of the different types of therapies that we look at. So what do we need to learn in preclinical testing? The first question, can it work? So just basically, if we put this in a mouse or some animal model, can it prevent symptoms or delay symptoms or reverse them? And are there really obvious side effects, which is all you want to understand at this point? You're usually looking at whether the mouse loses weight. Of course, if they get worse or they are, pass away, maybe even without details that this drug has some toxicity. So basic things. And then you have a whole bunch of questions. So if you're going to dose this in humans, you need to understand a lot about it. Like at what point in the disease? Can you do it after symptom onset, or do you have to do it really early before people have symptoms? Is it effective if you keep doing it over a long period of time? What about different ages? Can you dose children in the same way you dose adults? Children have different types of metabolism, and sometimes they respond differently. And then, what dose are you going to start with? What's the most effective dose, and is that dose safe? Then you start trying to understand if the drug actually hits all of its target tissue. So say you have a drug that you test, and it doesn't work. Is it because your idea was wrong, or did the drug just not get to the right tissue? So you have to understand, did it get to the target tissue? If it got to the target tissue, where else did it go? Did it go to the liver? Did it go to the kidneys? Did it cause problems there? So all of these things are things that you really want to understand. How it's broken down in the body, what's the best way to formulate it. Sometimes, these drugs will just not go into solution very well. If you don't have the right formulation, they kind of clump up and stick together and don't do what they're supposed to do. All of this work has to be done in advance to kind of get something that you think is a good, what we call clinical candidate. So this is a drug that after you've done all of this work, you think, okay, maybe we have some idea how to take this into patients. The other big question is it safe? So then you get into real toxicology. We call this GLP tox, or good laboratory practice, meaning you do it in a way that's very, very rigorous with very specific requirements for how this works. And you really have to understand, what the impact of this drug or therapy is in all the different tissues in the body. Because, we don't know everything. And sometimes, a lot of times we'll find unexpected, impacts. A lot of times in the laboratory, they're just, animals are dosed for a very short period of time. What happens when you dose for a long time? A lot of these drugs we think people might be on for a lifetime. So we really want to understand long-term side effects. Young animals are different from old animals. If you have a drug that's going to be in pediatrics, you need to understand if there are safety or side effects in a growing animal that may be different from what you would see in an adult. So all of these things we have to do. Will it interact with other drugs? Is it a carcinogen? Does it impact your heart rhythm, for example? So these are all tests that have to be done in advance. And then finally, the safe dosing window is really important. So you have some idea what the dose range is that's effective. And then you also have an idea, what is the range of the drug that's not safe? And you want to make sure that that window for effectiveness doesn't overlap too much with the unsafe window. So when we say you have a narrow window, it means you're dosing at a dose that's pretty high and it's getting really close to the point where it's toxic. So what you prefer is a wider window so you have more room to dose. Another step, okay, so all of those, check, check. It's effective, it looks like it could be safe. Can you make it? And that's a stumbling block that some people don't get past. So maybe the answer to the first two things is yes, but it turns out this drug is tricky to make. Some small molecules have many, many different steps, chemical steps to get them where they need to be, and they can be really complicated. Gene therapy is complicated. Making an adeno-associated virus, because you remove the viral genes, you put in your payload, you have to grow them up. It's multiple steps, and so these things can be complicated. So how can you scale it up? And what is the detailed process, and how can you optimize that? And then how do you ensure that you're making the same thing every time over and over in a way that's safe? And then finally, you have to understand what is the shelf life. A lot of things start to break down over time. So these and other things, can you make it? Can you make it the same way every time? And when you do all that, if the answer looks like yes in every case, then maybe you're ready for clinical trials. And I think you're going to hear a presentation by Dr. Nick Johnson after me, who will talk a little bit about what all goes into a clinical trial. But this is just the steps to get you here up to a clinical trial. So at this point, you would, it's usually a company that would do this, would submit an investigational new drug application to the FDA. And it's a huge package, and it has data from all of these things I just described. It's this monstrously huge, thing that comes in, application that comes into the FDA. They review it all and they say, okay, they usually come back with questions, or maybe not, they let you go ahead. And that's what forms the basis of being able to go into the clinic. So it's not an straightforward, easy process. Just thinking about some of the hurdles for limb-girdle in particular, there's a couple of different categories. The main issue is there's a small patient population, which means that you can't do big studies. And it also means you don't understand always the variability, or if your small patient population has a lot of variability, it can be complicated to figure out how to test new drugs. It's what you see in clinical trial design that sort of complicates things. A real issue is the commercial market. So most drug development at this stage, translational research is done in companies. And companies are for-profit entities. Many of them really are invested in the patient community and rare disease and want to help. They have to make money, though. They're a for-profit entity. That's why they exist. And when you have a very small market, it gets complicated because the costs are not really scalable. They are to some extent, but the cost of developing a drug is still much higher, even in a small patient market. So the only thing they can do is charge a lot for those drugs to try to make up the difference, or in many cases, they just pass. A lot of companies won't work on a disease that affects under 1,000 people, for example. Some will, but not all, and it gets a lot harder to make that case. So that's a big challenge, I think, in the limb-girdles, is many of them are really, really rare. So we have to come up with a model that makes sense, because I'm not sure that there's a commercial drive to do it in a lot of cases. And finally, I think it's challenging to sometimes just because of, issues of access and equity, difficult benefit risk assessments in this population. You really have to understand, what people want. So that's one of the things we need to do is better maybe survey our limb-girdle community to understand what's important to you and what you're willing to risk for that. Because ultimately, you want that information to drive decision-making, not what the FDA thinks is important to you, or even sometimes what your clinician thinks is important to you. We really want to factor in what you think, so we need to have that data. I'm winding up a little bit. I'm not going to talk about ribitol because I think Dr. Campbell just did, and you're going to hear about it later. But just as an example, below are some of the things that, preclinical testing that MDA and other groups have funded here. NIH certainly plays a role, but also and the companies that come in put in a significant amount of time and money. But there's a lot of work that gets funded by all of us before it gets to that stage. I will say the same thing. Another example is AskBio's Limb-Girdle 2I gene therapy, which I know pretty well because I was at AskBio working on that program. Again, there was a lot of work that went into that ahead of time that was funded both by MDA and other groups in this room, as well as NIH, before it got to the corporate stage. Finally, just a quick glance at the limb-girdle clinical pipeline. Sadly, the first half of that pipeline just came off. We can talk about that maybe at another time. But, remaining, there's still some really good prospects for limb-girdles. And I think that just the fact that this meeting, is so well attended and vibrant is a good sign that we're going to start seeing more and more things move out of this preclinical space and into clinical testing. I think our key challenge is just solving this problem of ultra-rare diseases and how do we get companies interested in that space. That could be a whole nother talk. So I'll stop there. And I think that's it. Let's see. Oh, just saying how important it is to have you support these early stages of research. And that's it. So, thank you.
Thank you, Dr. Hesterly and Dr. Campbell for speaking about discovery and preclinical stage research. There is quite a lot going on for many subtypes. You'll learn more about them later in the conference, especially tomorrow during the emerging treatment session, as well as at the posters around the room, and we have a poster session later today. Our final speaker is Dr. Nicholas Johnson. Unfortunately, he couldn't be here in person today, so he's recorded his talk. He is a professor at Virginia Commonwealth University, and many of you might also know him because he is the leader of the GRASP Consortium, which is a network of clinics focused on studying limb-girdle muscular dystrophies. Thank you.
Well, welcome, and I'm sorry I could not be there in person, but I'm here to talk as the last talk in this session about therapeutic trials in the limb-girdle muscular dystrophies. My name is Nick Johnson, and I am at Virginia Commonwealth University in Richmond, Virginia. And these are my disclosures. So I think you've probably seen slides like this at other points of the talk, but it's just a reminder that when you think about drug development and the limb-girdle muscular dystrophies, many recessive forms of limb-girdle muscular dystrophy are caused by a loss of function of the sarcolemmal protein or having too little. And many dominant limb-girdle muscular dystrophies are caused by a toxic gain of function of a protein, which is to say that there's too much of that protein. So if you're thinking about this conceptually, the way I like to think about it is like a light switch. So if it's a recessive form of limb-girdle muscular dystrophy, you're typically talking about some sort of adeno-associated vector or an AAV virus based on gene replacement therapy to deliver the missing genetic material. But it's also to note that in this instance, for some of the alpha-dystroglycanopathies like LGMD2I or R9, you can also take substrate replacement approaches to replace the missing protein or protein function. Now, in the dominant forms of limb-girdle muscular dystrophy, here we're talking about having too much of a protein, and so antisense oligonucleotides or siRNA therapies may be appropriate to knock down the gene or block the protein interactions. And so this figure at the bottom shows an example of where you have this antisense oligonucleotide that binds to the RNA, and then you end up not making the protein the way you would like to. So these are, again, thinking about this conceptually in treating the limb-girdle muscular dystrophies, a good tool is to think about that light switch analogy. However, sometimes it's not such a simple light switch. So sometimes if you give too much of a gene replacement therapy in a recessive form of limb-girdle muscular dystrophy, you can cause new problems like heart toxicity from expressing too much of the protein. And sometimes if you have a dominant limb-girdle muscular dystrophy, sometimes too much knockdown can actually cause new problems because now you're missing a gene that was important. So, I think in the best case scenario, when we're thinking about designing drugs for the limb-girdle muscular dystrophies, it's the simplest way to do it is an on-off light switch. But sometimes for some of these limb-girdle muscular dystrophies, we may be talking about more like a dimmer switch, where you're trying to get just the right amount of protein production. Outside of this genetic modifying therapies, it's important to remember that there are other treatment approaches that people are considering, and I'm sure you're hearing about during the meeting here. So you can build muscle and strength using myostatin inhibitors and other approaches similar to that. And then a longstanding idea is to reduce muscle fiber damage using things like corticosteroids. So now that we've kind of talked about conceptually how that you might approach treating limb-girdle muscular dystrophies, both dominant and recessive forms, this graph shows the drug approval process, which is frankly quite daunting. So on average, it takes about 12 years for a drug to be approved. And out of 5,000 drugs that have been tested, only 5 will actually make it to clinical trials. And out of the 5 drugs that go into clinical trials, only 1 will make it into the market. So just as a reminder for all of us that when we're talking about clinical trials, these are experiments. It's not early access to a new therapy. With the clinical trial, there's still data that needs to be collected to show that the drug is safe and effective and is doing what it's supposed to be doing. A lot of times people will refer to clinical studies in phases. So phase 1, phase 2, and phase 3, and I'm going to break those down in the next few slides. But it's important to remember that you have this large area of preclinical research before those phases where the drug's being developed and tested, typically in animals and other tissues to see whether or not it's effective. And then once you get past phase 3, you have this new drug application, which typically takes some time, and then we have review, and then at that point, you end up with a drug approval. So down here, there's these other red arrows where you have this accelerated development review or a compassionate use treatment IND. And I'm going to talk a little bit about these again in the next few slides, but this is just an overview for how typically drug approvals work. So who participates in what study? So for phase 1, here, this is really all about safety. So typically, you're talking about either healthy volunteers or mildly affected individuals in a small number, and again, just really focused on whether or not that drug is safe at all. Phase 2, now you're talking about both safety again, but now you're talking about trying to figure out what the correct dose is. So here, again, a few more people, but also typically mildly affected to moderately affected. Phase 3, now this is a study where you're supposed to show whether or not the drug works and is doing what it's supposed to be doing. And typically this could be the same population as phase 2, but is also a little bit broader oftentimes. So this graph shows you that oftentimes phase 1 clinical trials traditionally take months, phase 2 take months to years, and then phase 3s may take years to decades. Phase 4 studies typically refer to when drugs are being tested after they're already on the market. Again, this is just a reminder, this is a traditional drug development approach. Now, in limb-girdle muscular dystrophies, the drug approval is likely different for rare diseases like the limb-girdle muscular dystrophies. There's a law that was passed by Congress in the late 1980s, the Orphan Drug Act, that provides several forms of regulatory relief. So you can have breakthrough designation that allows drug makers to meet with the FDA more frequently, as well as priority review, which means that they don't have to wait in line. And then there's a number of other provisions. So there may be only 1 or maybe only 2 phases. So now you're not talking about phase 1 through 3. You're talking about maybe a phase 1, 2, and then a phase 3, or phase 1 and a phase 3. And oftentimes those numbers and study designs get quite blurred because the patient numbers are quite small, and then it may rely on a protein-based biomarker, particularly for biological therapies like the gene therapy. So the bottom line is that if you were listening to the last few slides, you're like, gosh, I don't really have years to decades to wait for this drug to get approved and developed. Across the limb-girdle muscular dystrophies, it's typically faster, it's expected to be faster than standard drug development. So let's dig in a little bit about gene therapy. So because this is going to be applicable for most subtypes of limb-girdle muscular dystrophy. So the purpose of gene therapy is to use a modified viral vector to deliver human DNA. And we use viruses currently because they're good at penetrating the cells, and you can package really any DNA or RNA. And current gene therapies are non-integrating, which means that they don't go into your germline, or for example, if you had children, you wouldn't pass on the gene therapy. As best as we can tell, it would remain in your cells but not be passed on to children. But the downside is it only delivers about 4.7 kilobases of genetic material. And this is just a schematic here showing you of what a typical gene therapy looks like, with some of the important areas highlighted. So you can have this promoter area, which is what turns on the gene expression, and that can be designed in such a way that it only gets turned on in certain tissues, or only gets turned on in certain situations. The transgene is the gene of interest. That's typically, for most of you, would be the gene that you're missing if it's a recessive form of limb-girdle muscular dystrophy. Some gene therapies include microRNAs, which is another way of turning the gene on or off in certain tissues, and that all kind of packages into this virus. Traditionally, most viral vectors are naturally occurring, although newer ones are now synthetic. Since some challenges early on for almost any gene therapy program that we're going to talk about, they are now almost universally AAV. And some considerations for vectors include the native immunity. So in other words, have you been exposed to this virus in the past? Tropism, which refers to which cells the viral vector goes into. And then specifically for the gene therapies of interest that we're talking about, whether or not they go into the liver or not, because that's a primary source of toxicity for some gene therapy programs. And this is just showing naturally occurring AAVs. So many of you would have been exposed to some of these in the past. You probably would not have noticed that because they don't typically cause serious illness, maybe just a low-grade upper respiratory tract infection, if anything at all. And it gives you an idea that, for like an AAV8, for example, these typically go into the muscle, the liver, and the retina. An AAV9, the brain, the heart, the muscle, and liver. So these are some of the ones that are traditionally used for the gene therapy programs that we're interested in. Again, just kind of reminding people that the viral vector cargo tends to be capped at about 4.7 kilobases, which can be an issue for large sequences, like, for example, in LGMD2B or R2, dysferlinopathies, where you can't put the entire gene back in a viral vector. And so some approaches to doing this would be to trim the sequence to the minimally important length, which is what's been done in Duchenne muscular dystrophy with microdystrophin, trying to optimize the promoter and cassette to fit just a little bit more of genetic material in it, or a dual vector approach, which is what's being tested for LGMD R2 or 2B by Sarepta Therapeutics, where you put half the gene in one viral vector and half the gene in the other. So that might be another approach to dealing with that particular issue. As I mentioned, some of the current limitations of gene therapy that are important to remember, this liver tropism actually becomes a pretty significant issue. It's a major source of toxicity, and I think we all need to, as a community, to do more work to make these programs as safe as possible. There can be a transient immune reaction, and in fact, in some gene therapy programs, there have been deaths. It is a one-time therapy as it stands right now in 2025. So you cannot receive this twice. And so part and parcel with that is how durable these viral vectors are. Again, most of us think that they are durable for a fairly long amount of time, like in the order of years to potentially a decade. But the long-term durability, again, remains a question. Researchers have started to work to develop these new muscle tropic capsids, which I think holds a lot of hope and promise for those of us in this community. So basically what they've done is they've taken naturally occurring AAV vectors, and they've evolved them through animal species to select the ones that go best to the muscle and not as well to, for example, the liver. And this is a pictograph showing one example of this. There are multiple different scientists who've done this work. But this here you can see in this graph, it might be a little hard for you to see. So this is using microdystrophin, so it's in Duchenne muscular dystrophy, but you can see compared to the naturally occurring AAV9 that you get lower expression in the liver, which is where you want to, and higher expression in the skeletal muscle. So I do think that these next generation viral vectors hold a lot of hope and promise for us to be able to treat people in a safer way, because I do think gene therapy has a lot of opportunity for many subtypes in the limb-girdle muscular dystrophies. So there are a number of open gene therapy trials. There's an active LGMD2I clinical trial by AskBio that's enrolling, and I'll bet you're going to hear more about that during the conference. There are active LGMD clinical trials by Sarepta, and this was just at the time of this recording for 2B, 2D, 2C, and 2E. And the graph here shows an example from the clinical trial in 2E, where Sarepta Therapeutics was able to show that they restored the muscle protein on the outside, which is what you can see at the top in those graphs, and that the protein was restored as well. Again, this is for patients with beta-sarcoglycan. There are small molecule approaches in limb-girdle muscular dystrophy. So this graph here shows a program that's open and ongoing for LGMD2I, which is using BBP-418 or pharmaceutical-grade ribitol, which is essentially a substrate replacement therapy for those individuals missing FKRP, which is what happens in LGMD2I. And it basically overloads the enzyme pathway to encourage it to work. Across other limb-girdle muscular dystrophy, there's a program by Edgewise, and I can never say the name of this drug, Cevestamine, targeting fast myosin to prevent contraction injury, and continued trials of steroids using these newer steroids like vamorolone to deflazacort, which may have more off-target side effects. Now, really important is that in the United States, and again at the time of this recording, there are very different approval processes. So for small molecules like the BBP-418, these go through a drug development center called CDER. And CDER is a more traditional drug approval process. It follows a lot of the steps that I showed. So there's lower likelihood of accelerated approval and really a need for a more traditional phase 1, 2, and then a phase 3 clinical trial. And very important here is that these drugs need to demonstrate clinical benefit. So what do I mean by that? So that means that compared to a placebo traditionally, the patients taking a drug like BBP-418, for example, or vamorolone, or any of these other small molecules, needs to show that they can either walk faster or longer or have more strength than those in the placebo group, which is a pretty high bar when you're thinking about how slowly progressive some of these limb-girdle muscular dystrophies are. But just to remind ourselves that these small molecules have a different approval pathway. Biologics, so these are typically gene therapies used, really have heavy utilization of what's called an accelerated approval pathway, which means that simply by showing that the protein is restored in the muscle to at least a certain degree, that CBER will allow the drug company to have the drug reach the market through an accelerated approval, while ongoing phase 3 or now phase 4 clinical trials are demonstrating the clinical benefit. So what does that mean? It means that typically these are very small trials. They're a much shorter duration, and that after the drug is approved, there's typically additional clinical trials which really seek to show, can people who've received this gene therapy walk faster or longer or generally be stronger? And here, for biologics, there is a mandated 5-year surveillance for individuals who receive a gene therapy. So, I think it's a bit perplexing. I know the first time you're thinking about this, it's just you're like, well, they're both treating the same disease. Shouldn't they get the same approval pathway? But in fact, they have very different approaches in terms of how they reach our clinics, and I'm allowed to write a prescription to treat individuals living with limb-girdle muscular dystrophy. And it's just a reminder for all of us that really once you get the drug approved, that's just the beginning. After the drug reaches the market, you need to continue to work with payers here in the United States, that's both private insurers and the government, to get the drug approved. Many of you have been through a prior authorization process. You know how difficult that can sometimes be. And part of it is as providing individuals like Medicare, Medicaid, but also Blue Cross Blue Shield and others, what is limb-girdle muscular dystrophy? Why is it so important that you receive this drug? Why is this such a serious disease? I think these are some of the things that are important and allow those decision makers to advocate on our behalf so that all individuals can have access to therapy. And of course, beyond the United States, so we need to focus on disseminating these therapies to different regions of the world. And then we also really, as a community, need to continue to work through the appropriate use of potentially risky therapies like gene therapy. So much hope and so much promise, so much opportunity in the gene therapies, but these are risky therapies. They need to be used judiciously, and we all need to do more work to make sure that we're treating people at the right stage and with the right dose to avoid causing more harm than good. And with that, on behalf of our center, I'd like to thank you and wish that you all have a great rest of your meeting.
Thank you all for sticking around for our session. We are running a little bit over, so I think we're going to be starting session 4 just any minute now. Thanks.
Hi, everybody. My name's Kelly Brazo. I am the co-founder and CEO of the Cure LGMD2I Foundation, and more importantly, a mom to Sammy, who's 17, living with limb-girdle type 2I. And I'm honored to be here today to introduce Dr. Byrne and Dr. Wicklund as they talk about current drug development pathways for the LGMDs. First up, I'd like to introduce Dr. Barry Byrne. He's the professor and associate chair of the Department of Pediatrics and the director of the PAL Gene Therapy Center at the University of Florida. He's also the University of Florida College of Medicine and the current vice president of ASGCT, as well as the chief medical advisor of MDA. I could go on and say a lot more, but we'll keep it brief in the interest of time. He's going to be talking today about gene therapy for LGMD and the challenges and opportunities ahead. Thank you.
Thanks so much, Kelly, and thank you all for being inside today and not out on the lazy river. You can get there later this evening, probably. Kelly gave most of my affiliations. I'll just move on to say really up the road a little ways is Gainesville, where the University of Florida is. 30 years ago at the University of Florida, a virologist named Nick Maziska helped conceive of the idea that AAV vectors could be used to treat genetic diseases. And then a structural biologist named Mavis McKenna helped solve this complex structure, which has really brought us to the current era where we now have the ability to do directed evolution of AAV vectors and improve their potency. And I'll talk a little bit about that at the end. But really over the past 20 years, we've really tried to develop some strategies to innovate care for rare and genetic disorders by both our internal partnerships at the university, in our children's hospital and the neuro hospital, as well as the regional network that is now UF Health. Externally, of course, we want to be engaged with the community, and that's why I'm really delighted to be here with you all today. Florida reached an interesting milestone just a few months ago. The governor signed a bill to initiate whole genome sequencing as part of expanding the newborn screening panel. So beginning next year, there'll be a pilot project that will identify over 600 validated targets that will be identified in newborns that would identify really all forms of limb-girdle muscular dystrophy as well as Duchenne. And, part of that cycle of life of developing new therapies and is training and providing excellent care. So that's, of course, part of our future vision is to really become a regional or, in fact, international center for translating these early stage discoveries. And really, in my own career, I've really bridged that gap, hopefully, and developed a number of external partnerships. And just to give you an idea of the organizations that we work with, obviously our funders are really critically important. Industry partners that we have currently working with at our center of over 49 active studies, and academic collaborators, some of whom you've heard from today. So I wanted to take a brief moment to give some background. So you've heard some of these things from previous speakers, but it's just always helpful to reiterate that the concept behind gene therapy is to really correct either a dominant or recessive disorder through delivering genetic material into cells. And really some of the first targets for those therapies are listed here. We had a program started at UF in inherited retinopathies that led to the first marketing authorization of a gene therapy for Leber's congenital amaurosis. And it was actually Dr. Hesterly who was up here a moment ago when she first joined MTA that we began a program with Dr. Campbell to start the first gene therapy in LGMD2D, which was the first gene therapy first given intramuscularly. And then we know about the success of SMA. I'll touch on that in a minute. So the concept is to use this viral vector strategy to deliver a payload that enters through the endosome in the cell, traffics to the nucleus, and we've learned a lot about this pathway and how to improve its efficiency, both on the surface of the vector and the genome design itself. But that capsid delivers, it's really a delivery truck for delivering the genetic information that stays essentially permanently within a cell that's not dividing. And this has been really underlying the success of SMA because neurons are terminally differentiated even at birth. Muscle cells, however, are made up of many nuclei, so this is the challenge, is to how to sustain the effect, and that's one of the things we've been working on. So just going to touch on where we are now and then where are we going. So I mentioned LCA, approved in 2017, but at least in the neuromuscular space, the first systemic therapy was in 2019, and this was the first commercial approval, a first commercial patient that was treated at our center who was diagnosed clinically. Of course, now we have newborn screening in every state, and the majority of patients are treated really within the first month of life. And we'd like to emphasize the urgency of that. Novartis has told us that by tracking time from diagnosis to treatment, that we've identified the way to kind of expedite within our system access to care. This boy is the brother of the first patient we had from Atlanta. They're wearing the number 1, but his younger brother was treated at 10 days of age. So that's ultimately the goal. Because in this condition, really, time is neurons. And just to comment about the kind of transformative nature of this, in this picture of the family and their kids was at a celebration we had last month for our 100th patient treated by gene therapy. Mom just delivered her 3rd child, but at this time she was 8 months pregnant, and they knew they were having a girl, but they actually didn't even care about testing for SMA because they were so confident in the outcomes that their boys had had. So of course there's been a lot of interest in Duchenne gene therapy. Some of that has overshadowed the efforts, unfortunately, in limb-girdle, but we have to learn from both programs. And now there are really 3 dominant programs in Duchenne. We know that Sarepta has an approved product. But I wanted to call attention to the fact that in the complexity of the largest gene coding for dystrophin, we've had to truncate many of the important elements out of the dystrophin, microdystrophin constructs. And that was not necessary in Limb-Girdle, and I always feel like if we had pushed on more aggressively with the 2D program early on, we would have maybe charted a different course for that and other of the limb-girdle therapies, at least the sarcoglycanopathies. So this was approved in 2023. The label was expanded last year to include all ages. And I do think we do, even though there been a lot of focus on shortcomings, we also have to look at the successes. So I just want to show you an opportunity for a kid to be a kid. One of the patients in the Ignite DMD study that we had is now 6 years after treatment, loves theater, and this is not a skill on the North Star, but you can see what he does in his performance. We need to go. So you won't see many 14-year-olds with Duchenne who can spin on one foot, I can tell you that. So there are some benefits. And what we hope for is that this can be made durable. And that's, Billy, I think, one of the biggest challenges we face both in Limb-Girdle and Duchenne. We got more involved just recently when the Dion Foundation came to our center with the help of MDA to gain access to the Adamayo program for LGMD2C. And so I want to just highlight their story because I think it will emphasize a few of the things that maybe when you feel like there's limited access, there are pathways to pursue. We've also begun a program to, at least I want to highlight some of the unique features that exist in Limb-Girdle. We can use self-complementary vectors, which is not in the current programs. This requires them to be very compact to take advantage of the ability of AAV to express very rapidly. This will lead to earlier recognition of an effect. Rapid onset of expression really will help us develop earlier time points for efficacy and may allow novel strategies for manufacturing that lead to more potent vectors. In 2I, we think there's a means to get better control of expression, and we've started a collaboration with the 2I Foundation, thank you, Kelly, to develop self-regulated forms of this cassette, not using only the cDNA. So kind of back to the Dion's journey, they started the Dion Foundation when Maggie and Peter were identified with Limb-Girdle. Joe made the best of some of this opportunity on his platform. I think he would be here other than his role as the star of Harpoon Hunters this last season. And even though the bluefin tuna season is over, I think they wish they could have been here. They realized that it was hard for them as in the US to participate in the Adamayo studies, which were launched in Italy and France. So with the help of MDA and their perseverance to work with Adamayo to open a site in the US, they have been able to participate as the first two participants in the first cohort of the study. I love this picture because Maggie is certainly very proud of having access to this new drug. And because Peter and Maggie were both in the study sequentially, they had to be separated from one another for a month. And so Maggie wasn't around her mom for about 6 weeks, and you can see how happy she is. And then one of the things we are leveraging at our site is the way to get faster outcome measures. And this is really an amazing program initiated by Krista Vandenborn and Glenn Walter. I think Glenn is here somewhere. The Imaging Neuromuscular Disease group has spent the last almost 15 years developing a surrogate biomarker based on imaging. And you can see in this panel the effective time on fat infiltration in the musculature. And if that is correlated with clinical outcomes, it provides a way to approach a surrogate endpoint through an imaging study, which will really provide us with very rapid input on efficacy. So here's an example of some of the trajectories that patients can follow, and you can see in the first panel the example of early treatment where there's a prolonged effect. The fat fraction in the vastus lateralis in these 3 patients has remained low since they were treated at under 6 years of age and now over 12. The second group had an early benefit but had some changes, whether it was immune-mediated myositis or lack of durability because of their somatic growth. They returned to the natural history data that's shown in the 2 curves in the middle. And then there are kids who were treated late who really didn't have an effect, and that tells us that some aspects of muscular dystrophy or dystroglycanopathies, dystrophinopathies might be irreversible. But in the case of the 2C program, just at the 90-day time point, we're pretty pleased to see a very dramatic effect on T2, which is a measure of water in muscle that correlates with inflammation. So I think we should be optimistic that if there can be this dramatic an effect at 90 days, we should see a continued improvement over time. And so then where are we going? I'll just take the last few minutes to talk about some of the challenges, and particularly in an area that we've focused on extensively, partly because of our work in Pompe disease, which is also diagnosed in infancy. We had to develop ways to manage immune responses both to enzyme replacement therapy and to AAV vectors, and there's a lot of commonality there. The early responses involve the innate immune system that can be immediate and cause significant safety concerns, as well as acquired immunity in which antibodies, in the case of AAV, may prevent access to treatment in the first place or may inhibit the ability to be retreated. We've followed a cohort of 113 patients now for the past 5 years and know that once you are seropositive at baseline, this persists. Now, most of these antibodies are nonspecific and low affinity, and we think there are ways to address that, and I'll touch on one of those. And I'll just call your attention to this paper which is a plain language summary of this publication we had in Molecular Therapy. But the Future Rare Disease paper really explains thoroughly in layman's terms all the peculiarities of antibody testing and what are the consequences of that. And so knowing the mechanism of how antibodies interfere with AAV, we've been able to design some strategies for seropositive patients that either remove B cells or even remove plasma cells themselves, which is a little more challenging, or use preventative therapies that block the antibodies in the first place. And that actually those preventative strategies are some of the best concepts I think we have in place now that we've used in various other conditions that are going to be applied, hopefully in the near future, even for Duchenne. And then the last piece is that even the concept of potentially gaining access to repeat therapies, especially if they're given early, the nature of muscle growth would really necessitate retreatment. We're working with a strategy being developed by Biohaven to develop an antibody specific for AAV degrader molecule. And this degrader drags only the AAV antibodies into the asialoglycoprotein receptor in the liver and degrades them. This is an example of really where complementary therapies can be used to improve overall clinical outcomes. And then lastly, the other strategy I alluded to in the beginning is using a computational biology and directed evolution to develop new AAVs that actually have higher affinity. And right now, some of the candidates that have come out of this screen across species, primates, swine, mice, and human primary cells, have identified variants that are up to 20-fold more effective than the current class of vectors that are in use in the clinic today. And I think it really is incumbent on the field to immediately pivot to this because we can't keep trying to mitigate the high dose exposures that lead to systemic toxicities. So I'll just end with these key takeaways. We think that there are ways to approach the problem of antibody positivity, which does affect half of adult patients, just to give you an idea of the frequency of those issues. And then by measuring a lot of early time points, we can really find the critical events that contribute to safety problems in this use of this modality, and that we can block these antibody responses and in fact, most importantly, aside from the safety, increase efficacy. This changes the risk-benefit equation substantially. And ultimately, we think there's a strategy for generating central tolerance, which will allow children who are treated very early to have a sustained effect over the lifespan. And then using these next generation capsids, we hope to increase efficiency at least tenfold. So thank everyone at our group that's listed here, as well as our funding agencies and collaborators. We've worked with the hospital very closely to develop this new UF Health Center for Advanced Therapeutics, which is in our Clinical and Translational Science Institute. And of course, I always thank patients and their families for their contributions that are really just so important to moving the field forward. So thank you again for this opportunity.
Thank you, Dr. Byrne. Next up, I'd like to introduce Dr. Matthew Wickland. He's the professor of neurology and the vice chair for research in the Department of Neurology at University of Texas Health San Antonio. And he's going to be talking about non-genetic therapies for the treatment of LGMDs. Thank you.
It's good to see all of you here. I'll just start by saying I have the theoretically less sexy topic, but I think it's going to be the maybe the sooner to market topic. So here we go. We're going to talk about a concept, which is there are disease-specific therapies, and you've heard about this already. So Zolgensma, that's a great drug. It's great for SMA. It's very specific for that. And then you also heard earlier about Pompe disease. So enzyme replacement therapy is specific for that disease. But there are also disease-agnostic therapies, and these are things that can be used for more than one disease, and they may cover either a mechanism or multiple mechanisms. And so things like corticosteroids can be used in Duchenne, but they're used in a lot of other disorders. And then if you have a therapy that can reduce fibrosis, that might be effective in a number of different disorders. So let's talk about these. So disease-specific therapies, you've heard this next topic a couple of times, but I'll walk you through this. So a lot of different names for this, but we're going to call it enzyme substrate therapies. That's the latest phrase I've heard. And so if you look here, there are several of the limb-girdle muscular dystrophies, and especially all of the alpha-dystroglycanopathies that are enzymes. And if you look at the bottom, you'll see that an enzyme, you have a substrate that's on the left that will interact with the enzyme, and then after that you'll have a product. And so things you can do is you can either augment the amount of substrate, which helps push through that enzyme for more product, or sometimes you can have a therapy where you'll bypass the abnormal enzyme and give some of the product down the road that may progress further through other pathways, and then that will solve your problem. So if you have an abnormal enzyme, you can either push through it or you can bypass it. So this is that drug, which is for LGMD 2I/R9, FKRP related. And if you look here, the mechanism is that it's caused by variants in the gene for fukutin-related protein, so FKRP. It's not absent, but it's less effective than in norms when you have FKRP. That enzyme is less effective. It is an enzyme that glycosylates alpha-dystroglycan with ribitol. And in healthy muscles, alpha-dystroglycan plays a role that's important in linking, if you look at the bottom there, from the muscle membrane up through alpha-dystroglycan, up through that glycosylated matriglycan, up to laminin, which hooks up into the extracellular matrix. The problem, though, as you'll see on that bottom middle figure, is that if you're missing some of the glycosylation units because your enzyme doesn't work well enough, then you have a less secure hold between that muscle membrane and the extracellular matrix. And then you get shear forces and you get damage to the muscle and inflammation and then fibrosis. So just going through this again, you can see on the left figure, this is if you have an abnormally functioning FKRP enzyme, then you just don't produce enough of that linking between the muscle membrane and the extracellular matrix, which is represented by laminin. But then on the right side, if you augment the amount of substrate, sometimes you can push through and you actually get a greater amount of that adhesion between the muscle membrane and the extracellular matrix. And so this is in phase 2 trials / 3 trials. And so what you can see is on the left, if you look at the amount of alpha-dystroglycan, glycosylated alpha-dystroglycan, in patients that have the common mutation that's homozygous, then they have about 15% activity and 15% glycosylation of alpha-dystroglycan. But through substrate augmentation, you can actually get up to about 40%, and that's quite relevant because if you look at carriers, they're about 50% or so that's getting back closer to normal. And what you can see on the right is that in treated patients, they go from very high CK levels down to much lower CK levels. And then if you look at this next set of graphs, what you'll notice is that there is an increase in the velocity that they can move. There is a decrease in the amount of time it takes to move. And they also, in a functional measure, a composite functional measure, they have stabilization, whereas in all of these cases, the natural history says that they should have worsened. So this is promising. And this, I found out there will be a readout for early information on this sometime later this year, so we should hear. In a slightly different disorder, there's a similar mechanism. There's a thing called thymidine kinase deficiency, so thymidine kinase 2 deficiency, and this is another disorder with proximally predominant weakness. And in this one, if you look at the bottom, this is the opposite, which is they don't augment the substrate. If you'll see that little TK2 down in that diagram, you actually give something that is beyond that enzyme. And when that happens, you actually get restoration of function. This is a graph that shows in untreated patients, these are infants that usually do not do well. These infants in the gray bar, which you only see 2 of them sticking up, those are patients that improved, and there were only 1 for each of those 2 tasks. But in treated patients, anywhere from 1/3 to 80% have improvement in those tasks. So these kids do much better in terms of function. And more importantly, if you look here, this is mortality. So this is a disease that is fatal in about 50% of patients and early in childhood. And with treatment, it's extrapolated that there would be much less mortality. So let's go to a couple of the LGMDs that actually do have treatment. That's kind of interesting. So these are very rare disorders. So this is one which is HMGCR related, so LGMD R28. It's one of the most recently ones described. And this is actually for HMG-CoA reductase. That's the gene for that enzyme. And that enzyme you may have heard about because that's the enzyme that's associated with statin myopathies. And it's also associated with an autoimmune statin myopathy disorder. And what they have found in this very rare family is that if you give a substrate that's beyond, so that would be a product beyond this enzyme, you can have some restoration of function. What you'll see here in the patient is with treatment, each of those graphs in the upward sloping line, that is over time with treatment. If you see the map on the right, that shows that where it's red, they have more improvement. And then again, in my mind, what's most important for this 50-some-year-old woman is that if you look at her respiratory function after about a year, there's substantive improvement in her respiratory function. All right, another LGMD that has treatment. So this is LGMD R19 or GMPPB related. This is another enzyme that glycosylates alpha-dystroglycan, but it does so in a slightly different way. And this actually has, well, actually, if you look on the bottom right, you'll see that there is almost absent paraspinous muscles due to fatty replacement. So this is a lady that I have that was quite weak. And the interesting feature about this limb-girdle muscular dystrophy is they do develop a muscular dystrophy with fatty and fibrous replacement, but this also affects the neuromuscular junction, so they also have a myasthenic syndrome. And so, in this young lady, young, she was 50, that still makes her young, she went from using a scooter and falling frequently, roughly every week, to when she went on this drug, pyridostigmine, which is a commonly used medicine in myasthenia gravis. She went to no longer needing a scooter, walking independently, going back to walking. She even took up, it's short course, but short course 9-hole golf, and she no longer fell. So marked improvement in her quality of life just through a medicine that works for this particular type of LGMD. All right, now we have a lot of things that are going to be disease-agnostic therapies. So first, past attempts. There are things that are called fast skeletal troponin activators. And the whole goal here was to try to make muscles contract stronger, and maybe that would help patients out. And this has been tried over the last about 15 to 18 years, and the most recent study was published in ALS, and that was just this past year, and it had no benefit in ALS. And the reason that's relevant for this audience is because in a mouse model in 2013, it showed a mouse model of muscular dystrophy. It did show that that fast skeletal muscle troponin activator had this difficulty with causing a change in the structure, but no change in function. And so there was no benefit. The other one that you've heard about is myostatin inhibitors. And again, for the last 15 to 20 years, this has been very exciting that maybe we could use myostatin inhibitors to improve patient strength. And I will say that myostatin is a really kind of cool thing, because myostatin's whole goal is to sort of turn off muscle function. And if you knock out the gene for myostatin, you get this. You get what's called a double muscle cow. So you get big, huge, strong muscles. And there are double muscle dogs, and maybe about 15, 20 years ago, a double muscle human baby was born. That's kind of cool. The only problem, if you look at this double muscle cow, is it is big, it is strong, it has lots of muscle. But if you go back 10,000 years when it was running with that herd, guess what happened? It ran, well, it was strong, but it ran slower at the back of the pack, and that just meant it was more lion, tiger, and bear food. So this is not adaptive. And it does make sense to try to do this in humans, and so this has been tried. There have been 6 trials of myostatin inhibitors in muscular dystrophies, including the large study that was done in 116 patients, some of which had limb-girdle muscular dystrophy. And what they found is that there was no statistically significant difference between treated patients and controls. And in other muscular dystrophies, we've used similar things, which are follistatin, which acts in a similar mechanism to augment muscle size and strength, and also oxandrolone, which is just an androgenic steroid, and it makes muscle bigger and it makes it stronger. But the problem in limb-girdle muscular dystrophy is there's weakness in the shoulder girdle and in the hip girdle. And so if you make an arm 20% bigger and 20% stronger, it's also 20% heavier, and all of our patients say their net benefit is nothing. That's right. So I've never been a huge fan of myostatin inhibitors for early therapy. If you can replace muscle and replace proximally, or you can inject proximally, it may potentially have benefit. All right, let's move to a different concept, and this is going to be a drug that Dr. Johnson touched upon in the last talk before we got up on stage here, and that's this drug sevasemten. And sevasemten is a fast myofiber, so a type 2 muscle fiber myosin inhibitor. And this is relevant because there are two main kinds of muscle fibers. There are fast twitch and there are slow twitch. Fast twitch is associated with, in my mind, connote with sprinting and powerlifting, and slow twitch is for endurance activities, standing, long-term endurance. And so this is active in inhibiting the fast twitch. It's inactive against slow twitch and cardiac muscle, and it limits, but does not prevent fast fiber contraction, but it slows it. And so that tends to protect against contraction-induced injury. And this is nice because this is going to be disease and mutation agnostic. So this could span across a number of different limb-girdle muscular dystrophies. If you look at the figure here, this sevasemten is an inhibitor of ATPase, and you see that there in yellow. And ATPase is important because if you don't cleave the ATPase, then the myosin does not grab hold and contract. And so if this only happens in the fast twitch, then the fast twitch don't contract, but the slow twitch are still working. So if you look on the left side here, in healthy muscle, we contract, and occasionally we have small injury, and then we repair it. That's to tear it down to build it back up. But in dystrophic muscle, if you contract those type 2 fibers earlier and more often for activities, and that leads to these fast twitch contracting, but the slow twitch less so contracting. You get shear forces, you get damage, and then you have difficulty with repair. Then you get inflammation and fatty and fibrous replacement. It's relevant for this audience because if you have something that's at that dystrophin glycoprotein complex at the membrane, so that'd be the sarcoglycans or FKRP, or the other alpha-dystroglycanopathies, this could be protective, and there are trials ongoing for this. So once again, normal contraction in normal muscle works nicely. In dystrophic muscle, like in LGMD, you get inordinate contraction with fast twitch fibers and more damage. So LGMD, with sevasemten, theoretically, you will have less damage, whereas if you don't, you won't. So this is a video that should play, so we're going to give it a go. First is going to be a mouse muscle that's untreated. And so what you'll wind up seeing is with contractions, and this is at 100% of effort, you start seeing that there's breakdown inside that muscle. This is not a muscle fiber, but a muscle itself. And so you'll see that continues. And then after this, I think automatically is supposed to play, I'm going to find out, the treated muscle, yes. So this is a treated muscle that's contracting not at 100%, but 85% contractility. And what you'll notice is that with sevasemten, you do not see that contraction-induced injury. So theoretically, we're going to have damage, which we see with maximal contraction, and then with 85% contraction with drug, you don't see injury. And this is relevant also because in their early trials, what they've noticed is that in patients that are not doing powerlifting and not sprinting, they don't notice a change in their muscle strength. So there is no change in muscle strength that's noted by the participants in the trials. And what they've seen in the trials is that muscle enzyme levels have gone down. In that middle graph, you'll see that is their marker, that is their biomarker, and there's a substantial reduction. And then on the right is their early data for noticing that in the NSAA, so that is a change, it's a composite measure, there is stability, whereas in the natural history, you should have seen decline. So this is in phase 2/3 development now, and we'll see if that comes to market. Dr. Johnson also talked about vamorolone. Vamorolone is a dissociative corticosteroid that was developed over the last 15 years. It potentially has less problems with weight gain, less bone loss, and less growth retardation. It is now approved for Duchenne muscular dystrophy, and there are trials ongoing in LGMD R1 and R2. And the only cautionary note for dysferlinopathies is that we've already had a trial by Maggie Walter in using deflazacort, and that did not impact the ability of patients with LGMD R2 to do better. Another concept out there is this thing called ligand-mediated therapies. And so ligand-mediated therapies have three distinct parts. First, there is an antibody, which you can see is that big bluish blob at the bottom. Then they have a non-cleavable linker, that's that small little yellow at the bottom. And then you have what I call an effector mechanism, because even though these are drugs in development, what they really are is a delivery mechanism in development. And so we're going to talk about it as antibody, linker, and then effector mechanism. And in this case, this is an effector mechanism that's being used for myotonic dystrophy. And what they have found is that this antibody is to the transferrin receptor, and skeletal muscle has lots of transferrin receptors, which allows this to be incorporated into skeletal muscle. And with treatment, their patients have shown improvements in strength, which you can see in the graph. And in terms of functional measures, so down is better. They have had faster times, so it's taken them less time. And there are several companies out in this space, and some of them are working on LGMD targets. All right, we've done all the complicated stuff like gene therapy and drugs, et cetera, and we kind of forgot. We have something that works, and actually we have an article just this year that says, yes, we know that it does work. Exercise. Exercise works. And a lot of you may say, ooh, should I be doing exercise? And we have answers to this. So in LGMD, low-intensity exercise is good. This has been shown. There was a nice trial by John Vissing's group with 6 patients with LGMD. They looked at strength training with weights at 40 and then gradually increasing up as close as they could to 80% of what their initial maximum was. And what they showed is that in the white bars, there was improvement. So that's improvement in the treated limb versus in the untreated limb, they had much less improvement. That's in both biceps and in quadriceps. We also know that aerobic exercise is good. So again, 6 patients with LGMD R12 and Octamin 5 related. This was a home-based, pulse watch monitored, moderate intensity exercise on a cycle ergometer for 30 minutes 3 times weekly for 10 weeks. Now, I look around the room. Not everybody can do this with their legs. I get that. The same would hold true if you had an arm ergometer, and if you still are walking and you can ride a bike, this would hold true. And what they found on the right in that top graph is it shows that there is better oxygen utilization over time. There is decreased amount of time it takes to do tasks that are motor strength tasks, so there's greater strength, and there was no significant change in the muscle enzyme level of the patients. So, in 2024, the 281st ENMC International Workshop occurred, and that was the second ENMC workshop on exercise training and muscle diseases, and this was their statement. Personalized exercise is safe and beneficial for patients with muscle disease and is recommended. And they were good enough to put out guidelines for what you should do for both aerobic and for anaerobic, for aerobic and for resistance training. So, exercise is good. I tell patients, no P90X, no powerlifting program, but somewhere in between there, low to moderate, go for it. All right, last couple of slides. What else is out there? So for the past, again, 15 years, they've been work on these things that are exoskeletons. And in the old days, the big problem with exoskeletons was the battery size. So to get enough force, you had to have this thing that weighed the same as a car battery. And so how do you put that in your hip pocket and try to make that work? And the answer is, it didn't. So the difference now is some of these exoskeletons and these bodysuits, the battery pack is about the size of a wallet or a little bit bigger, and yet you can get augmented strength from those. And so these are things that are reasonable, and there are some trials in the LGMD space. Also, this is very important. You need to make sure that not just your skeletal muscle is working, but you have to optimize your other organ systems. And since 2010 is when the seminal article was published saying that heart transplantation in muscular dystrophies, including LGMDs, is just as safe, if not safer, than in patients that don't have muscular dystrophy. And so I have a gentleman who was sort of for strength, but he literally had spent 2 years, the previous 2 years, in and out of the hospital because his heart was failing from his muscular dystrophy. And then when he finally got his heart transplant, he is back to being a house husband, walks the dog, he's active, his life's much better. He still has his weakness in his skeletal muscle, but his life is vastly improved. And then you've heard talk about nocturnal non-invasive ventilation. So don't forget about that. If you do have respiratory insufficiency, if you use nocturnal non-invasive ventilation often, this will lead to improvements in fatigue, strength, mood, cognition, and more. All right, I'm going to end with my final slide. I like this one. In 2013, I had a gentleman he was in his mid-50s, had a sarcoglycanopathy. His legs did not move. He had no movement at his shoulders. He could drive his wheelchair. And he just said to me, "Doc, they come back from the war, their arms blown off, and they get an artificial arm. You can cut my arms off." And I looked at him, I said, "I can't do that." And so I can't do that. But it got me thinking. In 2013, I said, who regrows arms? And the answer is salamanders, right? Right. So salamanders regrow arms. So I said, oh, how do they do that? So I went looking. And the answer is, we didn't know. So fast forward 3 years, and in 2016 is when it was published that they figured out what you have to do to regrow arms in salamanders. So if you turn on one gene called fibroblast growth factor 8, you get a little nubbin in one direction, and you don't regrow an arm. If you turn on a different gene, sonic hedgehog, you get a little posterior nubbin, and you don't regrow an arm. But if you turn them on in the right sequence, iteratively, you get a perfectly regrown salamander arm. Now, we are not salamanders, just like we are not mice, But this is a proof of concept that we can do this. And so what I tell patients is this may be 2050 or 2070 science, but if you think back 20 to 40 years, things that we thought were impossible are now possible. So I'll leave you with that. Thank you.
Thank you so much, Dr. Byrne and Dr. Wicklund, for providing us with a boatload of information, things that we can utilize now and things that we can be hopeful for, hopefully in the near future. So we could all use some of that. We do have a break scheduled until 3 o'clock, so you have about 6 minutes if you'd like to take a quick break. After that, at 3 o'clock, we have the Ask the Expert session, Q&A, right here in this room. If you haven't turned in your cards with any particular questions, you can do so at the Speak Foundation table and just across the hall. That's right here. There is an exercise, weight management, and nutrition LGMD in Palazzo A, and there's also navigating mental health with changing disability in Palazzo B. So go ahead and take your break, and we'll see you back at 3 o'clock. Thank you so much.
Great. Welcome, everybody. My name is Sarah Shira Emmons. I'm happy to be moderating the Ask the Expert session today. I'm with the Jane Foundation, an organization focused on dysferlinopathy research. So we have an amazing panel of experts, and we've been collecting cards from everybody all day with different questions. A wide range of topics will be covered. Hopefully we'll get through all of that. But I do want to make an announcement about the group photo, which will be happening in this room immediately after this session. So please stay after the session for the group photo. So before we start with the questions, I just thought we would go through, and each expert here can just give a quick introduction of themselves and their role in the field and where they're from. So maybe we'll start over here on the end.
So hi, this is the third time I'll say hi, Matt Wicklund. I'm at the University of Texas at San Antonio, and I've been involved in LGMD clinical care and research for the last 25 years.
So I am Bjarne Udd from Finland, from the University of Tampere, where I did set up the Finnish Neuromuscular Center at that hospital, University Hospital, some 25 years ago. And that is based on our experience with the big titin gene and all the other aspects of limb-girdles after that.
Hello, my name is Volker Straub, also for the third time now. I'm trained as a pediatric neurologist and for myself a neuromuscular geneticist as well. I've worked with Limb-Girdle Muscular Dystrophy for about 30 years now. Did my postdoc in Kevin Campbell's lab when the first genes for Limb-Girdle Muscular Dystrophy were identified.
I'm Peter Kang. I'm a pediatric neuromuscular neurologist at the University of Minnesota, and I've been doing clinical care and research on LGMD for about 20 years now.
Hi, my name is Vivanti Jones. I am a physical medicine and rehabilitation physician with a specialty in neuromuscular medicine at the University of Missouri.
Hello, and again, everyone, I'm Barry Byrne. My clinical background is as a pediatric cardiologist, studying almost exclusively neuromuscular patients, and I'm at the University of Florida.
And last but not least, I'm Lindsay Alfano. I'm a physical therapist and acupuncture specialist at Nationwide Children's Hospital in Columbus, Ohio.
Thanks, everybody. So Lindsay, maybe we'll start on your end. The first question we'll have here came in, and it is, what is the right amount of exercise for a kid 13 years old with LGMD R1?
Great question. I'll say there's right now an exercise talk happening in the Palazzo A room. So if you're in here, that's a great talk to hit. Dr. Tina Duong's talking about exercise in NMDs. The frustrating question is I can't specifically answer that because every exercise and activity prescription is really individualized to the patient. So what we encourage is that everyone's doing enough activity to really challenge your muscles a bit, but you're not getting to that point where you're pushing your body and you're sore for days and days, or you don't have energy to do your typical activities during the day. You don't come home and fall asleep at 5 p.m. without eating dinner because you're so exhausted. And so we talk through in clinic about ways to identify that right amount of activity, which is where you're pushing those muscles, but not to the point of prolonged pain or increased muscle cramping or that excessive fatigue, like I said. We talked a little bit in the room before I came over here about finding your local team and how if you attend a multidisciplinary neuromuscular clinic, we can serve as kind of those experts to help guide your local team, and you are the expert in your body or your child's body and typical behavior, and so as a team we can put together the perfect exercise regimen for you at whatever stage of LGMD you are.
Okay, we'll take another question, which is, maybe we'll, Dr. Straub, maybe we'll start with you with this question. How does the fat accumulated in the muscles, how does that process evolve in muscular dystrophy in general?
So that's, again, a very good question. Often, I think, it's wrongly referred to as fatty infiltration. I don't think that the fat cells don't infiltrate the muscle. But within the muscle, there are some cells, they are called fibroadipogenic precursor cells, a highly specialized cell that can develop into fat cells. And if muscles are chronically damaged, then these cells get activated, and they can both generate connective tissue and also fat. So it's triggered by a process of constant damage, which ultimately means that muscle tissue is replaced by fat. And so when we do muscle imaging, we then can see the amount of fat that is within the anatomical region of a muscle.
Great. Maybe Dr. Jones, we'll start with you on this question. But anybody, please jump in. Can physical activity help to regenerate muscle?
All right, so we talk about it, and I always say that when we look at the muscles and how they decline, that it's not always every part of the muscle declines at the same rate at the same time. And so sometimes it can have areas where you might have part of the muscle that has declined, especially we can notice these things when we do biopsies and we don't always see the same amount of degeneration in the same areas of muscles. And so I often tell people it's not necessarily a build back that you can have, but sometimes just by doing the physical activity, trying to maintain what is still there and what is still left is what we try to kind of focus on when we're doing some of the therapy there. But when we talk about like actually build back and taking over the strength of what is lost, that's not necessarily what we're seeing.
I could maybe continue on this issue because a peculiarity with the loss of muscle tissue in muscular dystrophies, limb-girdles, is that it's not even. Highly specific selectivity among the different genes causing LGMDs take different muscles. And if I'm just looking at titin, the huge gene in the muscle, if you have mutations in one place of the gene, some muscles are destroyed and replaced by fatty tissue, whereas other muscles remain for the entire life quite well. And if you have a mutation in another part of the gene, it can be almost the opposite. And that is still not well understood, how the different muscles are so different on the molecular level. I mean, if you look at them, they look all normal like muscle. But there has to be very different aspects of individuality on the molecular level between the different muscles.
Thank you. Dr. Jones mentioned biopsy briefly. We have a couple questions that came in centering on biopsy. So I'll start with one that's in general. for anybody, so please just jump in, panel. Are muscle biopsy findings actually prognostically useful? And specifically asking for tendinopathy.
Okay. Well, good. I can continue on my last talk. Yes. Again, differences. We have some tendinopathies that cause same type of destruction or loss of muscle tissue and replacement with fat that we do not call limb girdles. And there we have a range of different aspects of the muscle biopsy, such as the rim vacuoles in some of them, whereas in the limb girdle type, we usually do not see those rim vacuoles on the biopsy. So there are essential differences and value from the muscle biopsy still. And even more than what you see under the microscope on the muscle tissue, the value of the muscle biopsy is frequently in the possibility to do RNA transcript evaluations, because some variants on your genetic analysis may not be clarified by just the gene variation. And you have to go down to the muscle tissue to get the proper knowledge on how that variant affects the transcript and the protein.
Could I just make a quick comment as well? So coming back to the question, I think muscle biopsies in general are primarily taken for diagnostic purposes, not for prognostic purposes. The only exception from this is really in clinical trials, when muscle biopsies are also taken to look at the efficacy of treatments, treatment effect. But yeah, we don't take biopsies for prognostic purposes, but for diagnostic purposes.
Dr. Straub, that leads me right into this next question, and maybe it'll flow with some of the other comments the panelists have on this subject. But one question that came in, if we back up just a little bit and talk about diagnostics, is what is the advantage or disadvantage of muscle biopsy versus a DNA test? And so maybe Dr. Byrne, we can start there, and anything else others want to share on this topic would be great.
So luckily, really the Human Genome Project helped address the significant costs that was associated with doing whole genome sequencing, and now testing, aside from specific panels, is more readily available and it's affordable. So often that is the first move towards making a diagnosis, and then when there's uncertainty, it's possible to back up that diagnosis with specific testing done from a muscle biopsy. But I think it's really revolutionized the opportunity for more rapid diagnosis and shortening this kind of uncertainty that patients often face when they are identified with weakness.
If I look back early in my career, it was pretty common to start off with a muscle biopsy if we suspected that a patient had Limb-Girdle Muscular Dystrophy, and then we would do targeted genetic testing after that, because back then genetic testing was very expensive. Now since it's much more affordable, we typically start with DNA testing, but there are times when muscle biopsy can be useful if you get ambiguous results or unclear results from a genetic test.
But yeah, just to follow up from this, I think it's really important for patients and families to understand, if you have a diagnosis and never had a muscle biopsy, you don't need one. Okay, it's not that the biopsy will inform us necessarily about care or treatment or physiotherapy. So if there is an established diagnosis on DNA, you're not missing out by saying, well, that the clinician doesn't have my biopsy.
Well, maybe add one more thing that's worth commenting on. Is that probably in the last 5 years, We've moved away from the surgical or open biopsies to percutaneous devices, that some of which actually acquire very small samples, and as long as the testing methods continue to improve that allow for these smaller samples to be informative, that is, I think, also lowered the threshold and the risk for doing biopsies, particularly when we're, at least in the course of a clinical study, monitoring for some of the outcome measures that are based on the biopsy data. Of course, correlating that with the imaging outcomes has been an important advance too, because then you can really examine all the musculature. And so once that, as correlations established, hopefully in the future it'll be possible to do a lot of these investigations really based on advanced imaging techniques.
It's good to know.
I could
yes?
even continue on this aspect, because the combination is really good. If you have the muscle imaging, and if you then later see from the genetic report, yes, we would also wish to have a muscle biopsy for further investigations on RNA and protein level. Then you can optimize the place, the targeting, which muscle to be the best one for a biopsy. Because if you don't have that information, you may sort of even do a biopsy in vain, in the worst case.
Okay, thank you. Maybe Dr. Wicklund will head down to your end there and ask, and start with you on, is anesthesia considered safe for people with LGMD in general and also specifically 2I?
I think the short answer is going to be yes in terms of the anesthetic, but as we've talked about before, depending on the respiratory and cardiac status that you have associated with your LGMD, that's what your anesthesiologist certainly needs to know about, and you need to make sure that they're aware of your diagnosis and of your cardiac and respiratory status.
Lindsay, maybe we'll head back over to you. The question is electrostimulation a sufficient substitute for physical activity to prevent atrophy?
Great question. So typically we would say active movement is likely to be have long-term effects than something like an electrostimulation. There haven't been a lot of studies in LGMD specifically, so I think there's opportunity to learn there, but what we recommend is, again, that active movement and finding a way to activate those muscles that you're looking to strengthen, or if there's a functional activity you're really hoping to improve, finding ways to address that with physical therapy or potentially water-based aquatic therapy. Sometimes you can move some of the muscles and exercise muscles that are harder to move over ground. But some of those more passive, just having electricity move through your muscles, may increase blood flow in that area, but won't necessarily have a long-term impact on strength.
And I'll add on to it. And when we talk about electrical stimulation, also, I mean, we think about it, it's a short time that you'd be doing something like that. Whereas all day, every day, that you should be doing your range of motion, your movement, like Lindsay said, your functional tasks are the things that kind of are important throughout the day. And that even with electrical stimulation, especially if you're not familiar with it or are using too high of a voltage or sustained contraction, that actually can be damaging in the long run too. So you really want to know a little bit about what you're actually doing when you're trying to do that process.
Thank you. Switching gears a little bit, talk a little bit about gene therapy. The question is, have there been any clinical long-term data collection that show gene therapy has to be given at such a high dose as opposed to something in a lower range? Dr. Byrne?
Well, maybe I can get started. So I think one of the things we've learned both from non-clinical studies across various species as well as human studies, that there is a certain threshold at which many of the currently used vectors traffic to the hepatocytes in the liver. And then after that threshold is reached, then they start to reach the musculature, and there's not really a continuous dose response that you might expect if there were stronger affinity for vectors for muscle cells. And so modifying the receptors for the vector to reach muscle cells has changed that characteristic so that it's not necessary to overcome the events in the liver to reach muscle cells because they're preferentially binding to receptors on muscle cells and heart muscle cells and the diaphragm. So that's will allow, it's not been widely used yet, but that will allow about a 10-fold reduction in the dose, and that should enhance safety and improve efficacy.
Maybe to make another comment, so we have also seen that the dosage depends a bit on what you want to deliver. In LGMD R9 with FKRP, it was possible to administer lower doses than, for example, and it's an enzyme, and I think that makes a difference, that it's an enzyme, and you may need less protein amount if it's an enzyme compared to a protein that has a mechanical function. And so you may therefore have the need of a higher dose. So I think it's not that there's one dose that you can apply across all the limb-girdle muscular dystrophies, but it depends probably on the limb-girdle muscular dystrophy.
On the topic of liver, just kind of a general question, maybe Dr. King, we can start with you, but assuming healthier liver gives better gene therapy outcomes, how can we promote liver health prior to a therapy?
The liver is a complex organ. I think having as healthy a diet as possible will help keep your liver healthy, and avoiding exposures to infections such as hepatitis, which can be tricky, especially for some of the ones where transmission is hard to track. So there are ways to try to optimize liver health, but it's also difficult to assess sometimes in muscular dystrophy because some of the commonly used transaminase levels can be elevated at baseline, not because your liver is having a problem, but because those enzymes are also found in muscle. So that's something to keep track of, periodically checking those tests and just making sure that they remain stable, and if they're a little bit elevated, that they stay at that same level as much as possible.
Yeah, I mean, in our societies, in terms of liver disease, the main problems is fatty liver disease, both non-alcoholic fatty liver disease and alcoholic as well. So it's very much lifestyle as well. Dr. Kang already mentioned balanced diet. That includes also, less alcohol.
Does anyone on the panel know whether atalurin is being considered as a possibility for muscle regeneration in LGMD?
So, I mean, there have been studies in dysferlinopathy in mice, and the published data showed that you do get better dysferlin expression. So in South Korea, and these were actually results from South Korea, it seems that patients with dysferlin-related limb-girdle muscular dystrophy more frequently have so-called stop mutations. So this is when atalurin is indicated. This has not yet been translated into patients with limb-girdle muscular dystrophy. And my personal view would also be that I would be doubtful that this is effective.
Okay,
but I think that's the only one where it has been tested so far.
Okay. Kind of a practical question for a family who has a 22-year-old LGMD 2, I guess not specified what a recessive type, who is using a power wheelchair full-time, needing to have wisdom teeth removed and feeling concerned about what can be done in terms of a sedative, what would be safest. Does anyone have opinion on how to help guide a family in that situation with their oral surgeon and helping to direct that team safely?
I can start there a little bit. So again, a lot of these things depend on respiratory status as well when they're doing surgery, but like wisdom tooth removal can be done under local anesthetic. It's not as fun as I say, the laughing gas and some of the stuff that other people get when they have their wisdom tooth done, but it can be done. So for individuals who are in power wheelchairs, the important part is working with your dental office to be able to make that transition, if you can, into their chair. So having the appropriate devices or transferring to make that a safe process, but then laying back, as long as you have good respiratory function, you should be able to handle a wisdom tooth removal. But if you don't, then having that discussion with your oral surgeon about what your needs may be. Do you need to be on your pressure machine, so whether that's a BiPAP or a vent during the procedure? And if you do, then what types of modifications need to be made? And sometimes that might also include not doing it in office, but actually going to a surgery center or something like that, where they feel like they have better control and better support in case something does happen. Because surgery centers are a little bit more set up for emergent situations if they occur.
I would say if there's any question of respiratory compromise, as Dr. Jones said, it's probably safer to go to a place where there's anesthesia backup and other resources rather than in a small office.
What about vitamins, minerals, herbal supplements? Are they beneficial to people with LGMD?
Well, I'm happy to start. So most importantly, if you have a balanced diet, normally you do not need supplements. The one exception is in countries like the northeast of England, where vitamin D deficiency is quite common because of the lack of sunshine. I think in Florida that's not a problem. So what we do is we do test patients as well for the vitamin D levels, because if you have vitamin D deficiency, that can contribute and complement weakness as well. So it's important, but that's really the only vitamin that I think plays a role.
That's an issue in Minnesota also.
Yeah, okay. Probably also in Finland.
Yeah.
Thank you. This question centers around inflammation in general. Just first acknowledging that there is an inflammatory response with all different types of LGMD, but the question is whether or not the panel is aware of any upcoming research or current research trying to control systemic inflammation for people with limb-girdle muscular dystrophy.
Well, I mean, Dr. Wicklund has presented data a bit on steroids as well. I mean, steroids have an anti-inflammatory effect. Steroids have been prescribed for some forms of limb-girdle muscular dystrophy, particularly with a severe Duchenne-like phenotype in the childhood. But you need to really balance the side effect against the benefits. And there hasn't been any systemic study that has shown a clear benefit that outweighs the side effects. So, that's the only compound where really I think the anti-inflammatory aspect has been tested, but without much, I think, benefit for patients with limb-girdle muscular dystrophy.
Yeah, maybe I'll chime in. Just one more thing that just came to mind. First, just to remind, deflazacort was not effective in LGMD 2B/R2, so we don't have any data that says it's effective. But in Chicago, they had a trial that was a small pilot trial with very low dose, weekly prednisone. It's like 10 of prednisone a week. And there's some theoretical data that may be of benefit to skeletal and cardiac muscle. And Beth McNally showed trends, but the study was too small, and I think they do not have funding to do a larger study. But it would not be a home run, as I talked about earlier. This would be a real rapid bunt single, hopefully get over to first base before the ball got there. So.
Thank you. A little bit about hormones. A couple of questions came in related to hormones. The first one is specifically for men with 2I. Would TRT, or testosterone replacement therapy, help increase muscles? And if so, or if not, why?
So I'll jump in. The answer is there's not data, though we do have data in other disorders that androgenic steroids can increase muscle mass and strength a little bit, but as I talked about, that if you have proximal weakness, it does not translate to much functional benefit. But I do have some patients that self-dose, and there's placebo effect, but they say that they have better stamina, and maybe they're a little bit stronger, but that is all I have as anecdote.
And maybe if you have heard or read about testosterone in Duchenne muscular dystrophy, that's a different aspect. So testosterone is there, part of standards of care, because the steroids can delay puberty. And so the indication is not to build muscle, but actually to induce puberty. We have done a study where we did also show that testosterone has an additional benefit for the muscle. But again, these are boys, and this is not something that we have ever tested in adults that are post-pubertal.
Along the same topic, and I'm glad this question is asked because this has come up in our community, our dysferlinopathy community. Individuals have shared their experiences on this topic, but this person says, I would like to ask the expert, can a person who is undergoing gender transition, would like to know how the hormone treatment could affect the progression of the disease? Does anybody have experience with patients doing this? Or I don't think there's publications that I know of, but
No experience.
I think it's important to bring up because it is something that our communities are going through, but there hasn't been data collected that I'm aware of in limb-girdle. So a little bit more about gene therapy. This question is, can the patient that is non-ambulant have gene therapy? I know this is a sensitive subject, so we'll consider recent events, but Dr. King, would you like to start us off with this one?
Well, I think overall, if you look at all neuromuscular diseases, most of the human research, the bulk of it has been done on younger children who are ambulatory. So I think just because of where the bulk of the data are, I think in general there's more experience with ambulatory patients. For non-ambulatory patients, I suspect that we can do better and have a more optimal path for treating these patients more safely. That's something that we should be working on in the coming years.
But maybe to emphasize, I mean, the status, whether you are ambulant or non-ambulant, is of course artificial. I mean, it has a lot of meaning for the patient, and we used outcome measures based on gait, but the disease doesn't change. So of course, if gene therapy has an effect in an ambulant patient, non-ambulant patients could also get gene therapy. The efficacy might not be as high. It's also, when you get older, your immune system changes. The immune response might be different. But in principle, the response would be, yes, you can, if you're non-ambulant, also get gene therapy.
For the experts, what's the difference between gene therapy and stem cells or stem cell therapy? Dr. Wicklund?
I guess I'll take it, not the expert, but stem cells are giving cells that theoretically you want to turn into the tissue that you inject them into. And most of the time, up till now, we've not seen that occur, whereas gene therapy is you're either transferring in a gene or you're adjusting the genetic material through some sort of a gene editing format. So They're totally different, and we heard a little bit about a promising program for stem cells, but it's years away from being in humans in clinic.
Yeah, but again, I think it's important to, in principle, of course, if you get a cells therapy, that is also a gene therapy. Yeah? The same, if you get bone marrow transplantation, for example, you get, cells with new genes as well. So, but in terms of the dosing and in terms of the transfection of muscle cells, it's a very different concept. But
typically, I agree that it's sort of a subtle distinction between gene and cell therapy, because when you're receiving therapeutic stem cells, typically they are genetically modified, unless it's a case of a bone marrow transplant where you have a healthy donor. So I think everything that we're learning from our gene therapy experiences will be helping us develop stem cells in the future. One big obstacle to stem cell therapy for muscle disease is that it's been very difficult to deliver it systemically, and so that's one of the barriers that's different for stem cell therapy versus gene therapy, the virus-based gene therapy.
Just a couple left here. One back to exercise. What studies have been done in respect to physical exercise that is deemed to be beneficial for stretching of tendons rather than overloading distressed muscles, particularly the legs?
Sure, so those are kind of two different activities. Stretching is an important activity to kind of keep the smoothness or pliability of your muscles, the supple feeling of your muscles. There is a lot of research actually in stretching, I'd say in a variety of kind of typical controls, athletes, as well as patients with various forms of neuromuscular disorders. I think what's important to realize is when you are moving your body, you're kind of actively stretching all of your joints. The more that you are in a certain position, if that's sitting in a wheelchair, your body's not getting that same opportunity to actively stretch. If you are passively stretching your muscles, think about the amount of time that you're spending doing that across a whole day. So if you do, a 30-second stretch here or there, that'll be nice to kind of increase movement in that area, maybe make those joints feel better, but that's just a small part of the day. So once patients are moving a little bit less or they have some weakness and aren't able to actively move their joints, it's really nice to think about positioning. So we talked a lot about, elevating leg rests, getting in and out of your chair as you're able to change positions during the day, getting those arms out of this kind of 90-degree position to kind of stretch those elbows. And it's thinking about that positioning across the day, which can really maximize that maintenance of range of motion.
Okay, great. And for our last question of the session, what is needed worldwide to get studies and approvals aggregated so that LGMD subtypes have enough treatable patients for drug companies to focus on us? I can add a little bit, or maybe start us off a little bit by talking about some strategy for centralizing patient identification, which can be done through registries, global registries. Anybody else have anything to add in terms of helping prepare, get the attention of drug companies for the limb-girdles?
Yeah, so, one aspect is indeed diagnosing patients. Having as many patients as possible. There are big sequencing projects that are currently helping to do this, and Dr. Wicklund showed some of the data that are coming now from Latin America as well. From Asia, we see more and more genetic data. So we are, for example, our team are working with colleagues in India to identify limb-girdle muscular dystrophies. Once the number of patients is big enough and we need to do natural history studies, the most important aspect is to hear patients very loud. So having patient communities, having patient advocacy is almost a prerequisite for industry also to see there is a field that is organized, that has patient registries. So everything that we label under trial readiness is important to establish. In the limb-girdle muscular dystrophies, there is a strong community. There are many patient advocacy groups. So these are very good prerequisites to then show industry, look, we are keen to get therapies, and please invest.
That's what I was going to say, is this, what you're doing here, this is what is really important in building this community. And then also remembering, shameless plug, natural history studies. The more we know about the course of disease, the more we understand, then the more data-driven we can be. And having those answers before a therapeutic pipeline comes along the way, I think the more attractive LGMD will be as a disease group, because we'll know which outcomes we should select, we'll know what those outcomes, how those look as a natural course of disease, and then that helps us kind of measure change over time and really show that treatments are effective or if they're not. So again, more engagement and participating in those activities is really helpful.
And I'll also add that there are times when it'll make sense to focus on a community of LGMD subtypes, and then there'll be other times when it's very helpful, like in this setting, for everyone to come together. As we've seen from some of the prior presentations, there are some therapies that are gene-specific and other therapies that may be applicable for multiple subtypes. And so it's very helpful to work together as a community, both within individual subtypes and all together as an LGMD community.
And I think it's also good to see that a lot of this is happening now. I mean, where people are working together. There's an initiative also from called CPATH, where we are trying to collect data together from various limb-girdle muscular dystrophies to understand better the patient trajectories. There are also aspects that are applicable to all the limb-girdle muscular dystrophies. So there's a lot happening in the field.
I could comment that there is a disadvantage for patients in countries with smaller populations. So I have many patients that are very eager to participate in any sort of trial, but the companies, the pharmaceutical industry, they can't set up a system just for 2-3 patients at a hospital in Finland. So they have to wait, unfortunately, for other centers and collaborating groups to have the possibility to have enough numbers of patients.
Speaking of numbers, one way we can demonstrate that as a community is by really all sticking together here for our group photo, because that is evidence. But I just wanted to thank everybody on the panel and give them a big round of applause for this session. Thank you. So if you'll just hang tight, and others will be gathering in for the group photo.
No. No.
We have to all put our flashlights on for lighting.
I don't think it's going to reach there, but it's a stage walk, so it's meant for the stage, not everything else.
All right. Is everybody ready? All right.
Do you want the microphone?
No, it's all good. I'm ready. All right. Just making sure. 3. Well, sincerely, everyone that's here in this diagonal line is cut off. So there's only so much I can fit.
She's asking if you have a wide angle. This is way bigger than the last one.
There you go. Squeeze it.
You need to do a panoramic.
Whatever.
Let me give you my phone.
We'll give you an iPhone.
Do it, yeah, do a panoramic, and then you can do one like this, but I really need to get
Okay, just take whatever you can. I'm going to do a panoramic. Can you stand behind him so he doesn't fall? Excuse me.
Good evening, everyone. It's wonderful to see you all again. I hope your day was filled with building connections, valuable learning, and moments that remind us all why our community is truly so special. The insights, conversation, and dedication shared throughout the sessions today really show the heart of our entire LGMD community.
As we move into this evening's ceremony, poster session, and cocktail reception, it's the perfect time to recognize the amazing individuals and teams who go above and beyond for the LGMD community. Those who never stop supporting and fighting for LGMD patients, research, and treatments. To kick off our award ceremony, let's give a warm welcome to someone who brings so much passion, leadership, and heart to everything she does, Catherine Bryant-Knudsen.
Hi, everyone. We're so excited about our first ever scientific poster session. Yeah, you're not my son. Hello? Can you hear me? Hello? You have my headphones? I think that's just this. You're fine. No problem. Okay, we're good. And do not worry, that is such a minor thing. Thank you all for being here, and we're so excited about our first ever scientific poster session. And to begin this session, we have awards that we are going to give out tonight to recognize those who work so hard for our Limb-Girdle Muscular Dystrophy community. Our first recipient of awards tonight is someone that you all know, Dr. Matt Wicklund, who is our Clinician of the Year. If you guys will give him a round of applause. One of the reasons why Dr. Matt Wicklund was chosen is because of his willingness to work not only with limb-girdle families, but he is always willing to help and always accessible for patients. Anytime we have any kind of questions, he's always there for our community, and we're so thrilled to honor him with this award. Thank you, Dr. Wicklund. Our next award winner is Dr. Kevin Campbell. He is our Scientific Excellence Award winner, and we want to welcome him up on the stage. Dr. Campbell? Here he comes. Dr. Campbell has a heart of a scientist, and he always is providing so much to our community, discovered so many things for our community scientifically, and this is the award that we just want to honor him with tonight. And will you guys just let him know what a difference he's made, because scientifically he's had so many discoveries for our field. Let's give him a warm round. Our next award winner is Dr. Volker Straub. He is winning the LGMD Innovator Award. Please welcome Dr. Straub to the stage. Dr. Straub is being honored tonight because he is an innovator in the field of limb-girdle and in muscular dystrophy. He's made such a difference, and he is the person that can create so many innovative programs and has made just an impact for our community. Thank you, Dr. Straub, for all that you do. Our next group of awards are to recognize our patients in our community. And the first person we want to award is Carol Abraham. She is our LGMD Community Impact winner. This award is going to Carol for all of the ways that she participates in our community, volunteers, and helps our community. She is the founder of Awareness Day that we celebrate every year, and we are so grateful for all that she does. We always joke around and say that if we had 10 Carols, we would have already cured limb-girdle. Will y'all please give her a warm round of applause? And then our award winner for Lifetime Achievement Award is Mr. Donovan Decker. He was unable to be with us tonight, but he wanted to be here in person. And he personally said to me, if I could be there, I would be there. He said, it's so hard for me to travel. But I believe that he actually was able to take some time and actually made a presentation back to us. And we have a video, if you'll cue up, of Donovan.
I want to say thank you to the International Limb-Girdle Muscular Dystrophy groups for receiving this award. This award means a lot to me for the recognition for my journey for over the last 26 years of being involved in research and advocacy. So I say thank you, and we have a lot more work to do. Thank you.
And we all love Donovan in our community, and he is so well deserving of that award. And then our two awards that are going to be presented at LGMD Day on the Hill go to Senator Roger Wicker and Senator Amy Klobuchar, and they're both winning the LGMD Congressional Champion Award. And both of their offices are aware that they've won the award. They're very excited. And when we're on the Hill Day this year in September, we're going to be able to give those awards to both of them. And would y'all give them a round of applause as well, even though they can't be here? And I want to explain the reason why they're getting those awards, because Senator Roger Wicker is the one that helped pass the Wellstone legislation in Congress, in case you didn't know. And then Senator Amy Klobuchar is one of the sponsors of the Scientific Expert Act that is currently in front of Congress right now. And for those two reasons, that's why they're winning those awards. So, and then we want to thank you so much for being here at our first ever scientific poster session. And I want to take a moment just to also say thank you to everyone who submitted a poster. This was the first time we ever did this. And JP Laurent, who is here. JP, where are you at? Hi. Come on up. Yes. So we're bringing JP up here for just a minute, and I just wanted to say, just in front of everyone, how grateful and thankful we are to have JP be a part of this. Hey, come on up. Come on up. I wanted to give you a hug. JP took this whole project on. I had no idea how to do a scientific poster session, and I'm admitting it publicly, and I'm not even embarrassed. And JP was like, I know how to do it. And then he led this whole thing, and then Laura from Jane Foundation, Laura Rufibach, and then Jen Levy, who are awesome. They also helped and were just great, and all three of you together combined pulled this off, and I just want to say thank you so much.
You're welcome.
And now we're going to have this at every time we have International LGMD Conference, so thank you so much. And then I just also want to say thank you to Rachel and Kelly. Kelly Brazo and Rachel DeConte are amazing people, and I know you know the most incredible people in our community that volunteer and work so hard for our patient community, selfless, loyal, and dedicated. These are ladies that would do this all day long if they knew that their kids would get a treatment. They're going to do it even beyond when their kids get a treatment. These are the most selfless people I've ever known in my life, and I just want to say thank you to them. They are wonderful, and we're just like a team, and so we're a package deal, okay? Where I go, they go. Where they go, I go. So we're just so grateful and to our whole community, and thank you all for being here.
Thank you all.
You finished? Okay. I don't even think I used it. Good morning. Here we go.
It's a big crowd.
Welcome.
Surprise.
This is our session on updates on clinical trials. And we're going to start in just a second. I'm so glad to see everyone here and all of our panelists here as well. And we're excited to hear from our companies that have clinical trials in the LGMD space. And before we start, I just wanted to make sure I gave you a quick rundown of the day. After this session, then we will have our emerging therapies session. We will also have another lunch, and that will be sponsored by ML Biosolutions. Then we'll have our afternoon sessions with our advocacy panels and several other sessions that will be very enlightening. And then we will have an early departure for sessions at around 3:30, and then the activities for the evening and tomorrow are free time, and that's a time for you to really get to know each other as well. We want this to be just a wonderful experience for you, and let me just do this. Give a round of applause if you've had a good weekend so far. That's so great to hear, so wonderful. I just want to take a moment to say thank you to all of our sponsors. We are so blessed to have wonderful sponsors in the limb-girdle space. I want to thank ML Biosolutions for their platinum level, Sarepta Therapeutics for their platinum level, Ask Bio for just wonderful sponsorships there as well. So we're so blessed and honored. Okay, so let's move on to our updates on clinical trials. Our first speaker is Dr. Douglas Sproul. He is the Chief Medical Officer at ML Biosolutions. He brings extensive industry experience from leadership roles at Avexis and Genzyme, where he led global efforts in rare neuromuscular diseases. A board-certified pediatric neurologist with a background in clinical research at Columbia University, Doug combines deep medical expertise with a passion for advancing therapies in complex genetic conditions. Would you welcome Dr. Doug Sproul?
Let's see if this is on. All right. Well, actually, figure it out. Can you guys hear me in the back? All right, I'll talk loud. My name's Doug Sproul, and thank you for that kind introduction.
It's a pleasure and an honor to have the opportunity to join this meeting, be part of this conference, be part of this community, and to be able to represent ML Biosolutions, which is a BridgeBio company, in presenting an overview and an update of our clinical program. So, I'd be remiss without, I always like to kind of go into the history to remind us of where we've come from as a company, as a community, and, remind people of how much progress has been made, especially in the last few years, advancing diagnostics, advancing care, transforming this disease from this hand wave description, LGMD, into something where we understand increasingly the complicated genetics and pathogenesis of the diseases, and that gives us an opportunity and a springboard to develop clinical therapies for the individual, specific, and discretely distinct forms of this disease. And so just to remind everybody of where we've come from, and ML Bio is a product of that. It stems from a diagnosis, like many and most of the people in this room have experienced, of a young child with Limb-Girdle Muscular Dystrophy, and that led to a philanthropic effort by the McCall and Lockwood families to create a research laboratory at Atrium Health in North Carolina. And that reaction and the efforts that emerged from that have led directly to the development of ML Biosolutions and our product, BBP-418. It's also provided a great deal of the springboard and efforts that have led to the gene therapy programs that have emerged for LGMD2I, R9 as well. ML Bio specifically was formed in late 2018 to try to take a research concept of ribitol or BBP-418 and move it from an idea into the clinic and into clinical trials and hopefully ultimately for patients. The decision was made, and I think it was a fortuitous one, to partner with BridgeBio in 2019. And that has given us massive resources, expertise, and support that's really helped drive forward and accelerate our progress to date. We had an IND, Investigation of New Drug, application approved in 2020. And in 2020, we moved into phase 1. 2021, we moved into phase 2, first inpatient dosing at VCU in Richmond, Virginia. And then we moved into an ongoing double-blind randomized controlled trial, multi-center, multinational study in June of 2023. It was fully enrolled a little less than a year ago. And at this point, we're really excited to be looking and staring in the face an interim analysis that will be performed and result later this year. So it's an extraordinarily exciting time. From our perspective, a breathtaking pace. From the standpoint of the community, I can only imagine a glacial pace plodding along. But we're moving forward, and it's a very exciting time for us. I'd be remiss without thanking all the amazing partners that we've been able to work with in the development of our program, our advocacy partners have been instrumental in providing that and helping to provide that human voice and keeping us focused on the ultimate goal, which is to deliver therapies to advance the care and the lives of patients affected by this disease. I don't want to get into science, but I do like to always remind people of a salient point, which is own your disease. Understand as much as possible, and we can all do it, understand what underlies your disease, what your diagnosis actually is, what the approaches that could be entertained to treat your diagnosis. Understand as much as you can. Open a biology book if you need to. Educate, educate, educate. Neuromuscular disease is obviously a very complicated field. I'm not going to get into it, but just to remind everybody, historically, limb-girdle muscular dystrophy was a catch basin diagnosis. It's not a real diagnosis. It is a description of a pattern of weakness of the upper limbs, the proximal muscles of the limb and the girdle musculature. And historically, it was we have a muscular dystrophy. It's in this pattern, we'll call it limb-girdle muscular dystrophy. And it's really only in the last 10, 15 years that we've moved away from this kind of descriptive term, hand wave term, into the understanding that there are dozens of discrete, genetically distinct forms of the disease. And that's what this complicated, crazy cartoon that I won't go into really identifies. But there's, as you can see, there's a whole bunch of different proteins that all play a complicated and critical role in anchoring the muscle cell with the extracellular matrix, providing that anchor and support that during muscle contraction leads to contraction of the muscle and avoidance of significant injury with muscle contraction. LGMD2I R9 is a specifically result from is a result of a mutation of an enzyme called FKRP. This enzyme is involved in a specific step, which is the attachment of a sugar molecule onto a chain of sugars called a glycan chain on another protein called alpha-dystroglycan. These, if you've ever heard Dr. Matthews give a presentation on this, the protein is the body, the glycan chains are the arms, and if the FKRP doesn't work in its attachment of the sugar, you end up having little dinosaur arms that aren't able to reach out and grasp the extracellular matrix effectively, and this leads to instability of the muscle membrane, injury with contraction and muscle breakdown, and ultimately leads to progression of all the pattern changes that lead to a muscular dystrophy. So in healthy muscle, the fukutin-related protein works correctly in this step of glycosylation. When it doesn't work, you end up having disease. And this is what happens. This is what happens in the unaffected state on the top, and in the bottom in the disease state. So in the unaffected disease state of affairs, you have a molecule called ribitol. It gets converted by an enzyme called ISPD into something called CDP ribitol. And that is used by FKRP to attach a ribitol phosphate molecule onto this glycan chain. And so, and it works correctly, you end up having a complete functional alpha-dystroglycan. For patients who are affected by LGMD2I/R9, that enzyme, that FKRP enzyme, doesn't work correctly. And so that leads to a state of affairs where only a small fraction of those alpha-dystroglycan anchor glycoproteins have that fully formed glycan chain. And so this leads to instability of the muscle membrane and leads to all the breakdown and pattern changes that we see in muscular dystrophy. So one of the things that's interesting about LGMD2I, R9, and a number of other types of limb-girdle muscular dystrophy is that there's a founder effect. So somewhere back in prehistory, there was someone in Norway or Denmark or somewhere who ended up having lots and lots of kids and was affected with, carried this mutation called L276I. Colloquially, it's a common mutation or the Viking mutation. And about 2/3 of patients with this disease have what's called homozygosity for L276I. And so these patients tend to present later, sometime in the second decade of life, and have a slower progression of disease compared with patients who have other genotypes. So have usually one common mutation and one uncommon mutation. Those patients will typically present in the first decade of life. So these are people who would develop this disease during childhood and experience a much more rapidly progressive disease course. And so, what this underlies is a critical point that's specific to LGMD2I/R9, but also spreads to other diseases, which is understand both the diagnosis, but also the specific mutations and genetic background that you have as a patient, and what the implications of that are towards your course, and hopefully, ultimately, towards the care and treatment options that you select. We don't know how many patients there are with this disease. There's varying estimates. We estimate maybe there's 7,000 patients across the US, EU, and elsewhere. We don't know. And so this is one of those things where getting tested and coming back to clinic is something that's going to be so incredibly important, regardless of what your disease is, to be present so that we understand the epidemiology as well as possible, so we can understand the potential abilities to treat this disease. So I'll get into actual drugs. So what is BBP-418? It's being developed as a glycosylation substrate therapy that's designed to treat LGMD2I/R9. And this is important. There's potentially 2 other forms of limb-girdle muscular dystrophy, 2M and 2U, that's caused by fukutin and ISPD, that could potentially be treatable using this therapeutic approach. It's not directly applicable to other forms of limb-girdle muscular dystrophy. It's provided in the form of granules in a sachet, so it's dissolved in water and consumed orally. So it's an oral treatment that you take twice a day. To this point, it's been very well tolerated. There have been no dose-limiting toxicity or serious adverse events that have been observed related to BBP-418 in our phase 2 trial. Our phase 3 study is a blinded study, so we have limited ability to comment on that. And the early clinical study of patients with this disease have provided encouraging, particularly biomarkers, as well as some clinical data supporting this disease, or supporting this therapeutic approach in this disease. So I talked about the disease mechanism on the left. And so again, you have ribitol is converted by ISPD into CDP ribitol. And then FKRP enzyme attaches it onto that growing sugar chain. And in patients who are affected by LGMD2I/R9, the FKRP enzyme doesn't work correctly. And so you end up not having effective glycosylation, effective attachment of that sugar molecule onto that sugar chain. The therapeutic strategy is to provide elevated levels of a synthesized pharmaceutical-grade form of ribitol upstream. And this will aim to drive the residual activity of that enzyme by providing high levels of CDP ribitol in the cell. So basically, we provide lots and lots of ribitol. That gets converted into lots and lots of CDP ribitol. And even though that enzyme doesn't work correctly, it works enough that by giving lots and lots of fuel, you can drive forward that process. And if you can do it enough, you can increase the number of effective glycan chains, fully effective glycosylated alpha-dystroglycan, and this can reduce the potentially, if it works, reduce the severity of the disease at the level of the muscle cell. We have a large clinical program to date. We have completed, we participated and supported a natural history study that was performed by the GRASP Consortium. Many of the investigators have been at this meeting. We have conducted 3 phase 1 studies in healthy volunteers, if you heard some of the lectures yesterday to describe that. We have an ongoing long-term phase 2 study in patients with LGMD2I/R9, and we have a large phase 3 study called Fortify that I'll talk about briefly as well. One of the things that supports our program is a bioassay that we've developed. And I know everybody hates muscle biopsy, but for this program, it's an extremely critical thing. It provides the opportunity to measure directly the amount of glycosylated alpha-dystroglycan in a muscle cell. And that allows us to understand the severity of the disease in untreated patients. And it allows us to assess the response to therapy, be it our product or be it other potential therapies that are addressing the underlying mechanism of disease. It allows us to say what levels were here, and they can increase it to there. We know from looking at natural history populations that patients who are homozygous for L276I as a group have less rapidly progressive disease. They also have higher levels of glycosylated alpha-dystroglycan than patients with other genotypes who again have typically more severe disease. And so the glycosylated alpha-dystroglycan levels, while imperfect, they track very well with the overall understanding of the underlying disease course. When we look at our phase 2 data, what we've been able to see is that in patients who are homozygous for L276I, we saw an increase from approximately 16% in those patients to approximately 40% of a normal reference standard. And in patients with other genotypes, we went from about 5% to about 10% of that reference standard. And so what we've been able to see in our phase 2 study is that giving BBP-418 has driven an increase in glycosylated alpha-dystroglycan levels. And demonstrating that at the level of the cell, this therapeutic strategy there's evidence to suggest that it does work. We're also seeing a commensurate decrease in creatine kinase. It's a marker of muscle injury and breakdown that's released in the context of muscle injury. And we've seen a more than 80% decrease in CK in patients who have been treated in our phase 2 study and measured over serial periods of time over several years. We're also seeing some evidence that this actually translates to clinical results. We don't care about CK levels. We don't care about glycosylated alpha-dystroglycan levels. We care about the impact on the person in their clinical status. We are seeing some evidence that we have an improvement in the 10-meter walk test velocity, an improvement in the time to complete the 100-meter time test, and an improvement in the North Star assessment for limb-girdle muscular dystrophy when compared with the trajectory that we see in untreated natural history populations. And this made us very excited to move to a longer-term phase 3 study, which is ongoing. At this point, to summarize phase 2, it's been across a large range of doses studied. We haven't seen any serious adverse events that are dose limiting. There have been 3 adverse events in the study. These were deemed unlikely to be related to BBP-418 and were related to the underlying disease. There have been no safety-related discontinuations in our phase 2 study. And most of the adverse events that we've seen have been gastrointestinal in nature, which makes sense when you're giving a pentose alcohol-based compound to the gut milieu. Generally, they've been short-lived and for the most part well-tolerated, although certainly having an increased bowel frequency can be of some challenge for patients, particularly non-ambulatory patients. We're really excited to be here in that kind of pre-announcement stage. We don't know what the results yet are. We'll be coming out later this year, hopefully with really positive results from our interim analysis. But we have an ongoing, large, double-blind, randomized controlled trial of BBP-418 in patients with LGMD2I/R9. We've enrolled 112 patients aged 12 to 60 years in the US, European Union, and elsewhere. It's a blinded study, so patients don't know their treatment status. We don't know their treatment status. The investigators don't know their treatment status. And so we're able to follow these patients independent of what and not biased by what they're doing. We plan an interim analysis that's going to result later this year that'll involve the first 70 patients approximately who've completed 12 months or more of study. We're going to be looking at several biological biomarker endpoints, glycosylated alpha-dystroglycan, impact on CK, and also impact on selected clinical endpoints as well. And we hope that this will allow us to have discussions with our regulatory partners about potential pathways and the opportunity for a potential pathway for an accelerated approval. But this is obviously very speculative. We don't know how the studies will result. We don't know how our regulatory partners will react to that data. And there's a lot of ongoing discussions that will obviously need to take place. That said, it's a period of time of real excitement for us as a company, and we're very much looking forward to being able to offer additional information as it comes available later this year. One other additional factor that I feel like has been kind of overlooked is the partnership that we have and commitment that we have to the community. We do plan and are in the process of developing what's called an open label extension study for patients who have participated in our clinical trials and completed their participation. We expect we'll make this product available through an open label extension for all patients who participated in our studies. And this, the further details of that will be ongoing, but it's an exciting time, and certainly thank everyone for your attention this morning. Thank you.
Thank you so much, Dr. Sproul. What a wonderful presentation. And I am going to take just a second because I know on our program, Sarepta Therapeutics was supposed to present, and they chose not to send anyone for that presentation, to my disappointment. Louise did present yesterday morning in a pre-taped presentation that our community did see that's available for download on our streaming site, and you can also go back in the webcast and watch that as well. And our next presentation is from Dr. Samuel Hopkins. He is a distinguished research scientist with more than 40 years of experience specializing in antiviral therapeutics, gene therapy, and rare diseases. Dr. Hopkins received an A.D. Williams predoctoral fellowship and earned a Ph.D. in biochemistry and biophysics from the Medical College of Virginia. This was followed by a Wellcome Foundation postdoctoral fellowship where he completed postdoctoral training at the Wellcome Research Laboratories. He is currently the Senior Vice President of Therapeutics at AskBio. AskBio is a gene therapy platform company dedicated to the discovery, development, and marketing of adeno-associated virus vectors for the treatment of patients with rare genetic disorders. Would you please welcome Dr. Samuel Hopkins? Thank you, Dr. Samuel Hopkins.
Thank you so much. I could only say I wish my parents were here right now. So that would be great to have them here. Let's see. So let's move straight into things if we can, or if I can. So AskBio, again, for those of you who aren't familiar with the company, we operate independently. However, we are now incorporated into Bayer Pharma as part of a platform affiliation in cell and gene therapy. So why I bring this to mention is that affiliation provides resources and infrastructure that transforms us from our founding as a startup biotechnology company to now a company with truly global capabilities. So it is transformative for the company. Let's see. Since I can't see my slides, folks, can you tell me what you're seeing? We're going to look at pipeline next. Is everybody seeing that? Yeah. Fantastic. So to speak to that point, this is the clinical pipeline that the company right now is exploring, and you can see that there's a wide variety of programs. Congestive heart failure, we're in phase 2 with this. This is a large indication, and this is conducted on an international basis. So again, when I talk about the capability of the company and what Bayer provides, this is a clear example of that. You can also see a clear cascade from large indications such as congestive heart failure and Parkinson's, all the way down to what we're talking about today, which are typically recognized as rare diseases. Pompe disease, a metabolic condition with neuromuscular complications, as well as limb-girdle. So I'd like to simply now begin to tailor the talk on the run. So what I'd like to do is amplify points from this point forward that reflect some of the conversations I've had with many of you yesterday. So let's see how this goes. We've already talked about the complexity of limb-girdle muscular dystrophies. We don't need to expound on that anymore other than to say this simply reflects the biological complexity of the connection from dystrophin all the way to the extracellular matrix. There has been a change in nomenclature to make things more easily discussed, and I think that was born out of necessity, certainly as all of you can appreciate. At Ask Bio, our main focus has been LGMD R9. Now again, simply to try and reflect some of the points from conversations yesterday. FKRP, as we've heard all of you who have R9 express FKRP, you just don't simply express enough of it. So in gene therapy, our goal isn't necessarily to replace a missing enzyme, it's only to augment a function that you already possess. And again, that function is a tethering function. All of you possess all the structural proteins you need to reconstitute the function of your muscle and to alleviate the stress that occurs during muscle contraction. Again, that enzyme, as stated previously, adds that extra bit of connectivity that now gives you this continuous string and connectivity from dystrophin all the way to the extracellular matrix. So gene therapy can be a confusing topic, so let me just hit a few points. So biology, just as a reminder, cells, that's the basic functional unit of life itself. We heard many times yesterday there's a hierarchy of terms. We've talked about DNA, genes, chromosomes, and even protein. Deoxyribonucleic acid, these are the chemical constituents of what goes into a gene. A gene is so defined if it has a particularly defined sequence of DNA precursors that code for a functional protein. Genes themselves are associated into clusters into a superstructure called chromosomes. Being humans, we all have 23 pairs of those. In terms of what is genetic disease, a single change in one DNA precursor in a gene that codes for a protein, and then that protein then has a diminished or altered function, that is the basis of what a genetic disease or genetic condition is. In terms of when a gene can be, let's say, mutated or harmful, again, in a decrease in function, the idea is to augment that function, again, by a singular gene transfer. We talk about different kinds of mutations, some of which are inherited in families. Limb-Girdle Muscular Dystrophies are those, from grandparents to parents to children. These are inherited mutations. We sometimes call these Mendelian inheritance patterns. Remarkably, there are mutations that occur that are not inherited. We refer to these as de novo mutations, spontaneous mutations that are not inherited among families. These tend to be exceedingly rare and exceedingly pathogenic. Ion channelopathies, for instance, are an example. These are profound conditions. The particular mutation in FKRP that we're talking about, and as I referred to, is only a change in one amino acid. And a protein is composed of hundreds of amino acids. So in this case, we've heard the nomenclature L276I. Leucine is an amino acid in the normal FKRP protein. At position 276, it's changed to an isoleucine. That single change diminishes both the function and the distribution of FKRP within muscle cells and in other tissues throughout the body that give other manifestations of limb-girdle R9. So in terms of the experts, there are genetic overexpressed, interrupted, and genetic deletion technology together. At first, that's referred to with CRISPR technology, Those two technologies can now be coupled so that whole gene insertion can actually happen into the chromosome. But again, this is typically for much more profound conditions. Neither of these approaches are necessarily what we're using at AskBio to address this condition. What we're talking about today is gene transfer. So whole gene transfer into your cells to supply FKRP function, the normally functioning gene. A few concepts here just simply to talk about. Gene therapy itself. So what is gene therapy? And when we use the terms, you may see this if you've been in clinical trials or considered them. We refer to gene therapy vectors as infectious and non-replicating. This is the state of affairs. We want to transfer DNA into a cell. It has to be therefore in a particle that itself is infectious. But as such, you do not have a viral infection. The idea of using AAV is such that the constituents of that virus, of its DNA, can be removed, but only the two terminal segments of its genome remain. What is replaced that then takes out the replicative capacity of the virus, that's taken out. So the virus is not going to replicate in you. You do not have an ongoing infection. But a cargo, the gene of interest, in this case FKRP, is spliced in between those two terminal junctions. That allows multiple functions to happen. The DNA can then be transited to the nucleus, replicated, and then FKRP protein can be produced. Why do we need a virus to begin with? Well, DNA itself in a biological environment is highly unstable. It can be degraded, so there is no good, perfectly efficient way to deliver only the DNA. It will have to be protected in a protein shell. That protein shell comes from AAV. To date, delivering DNA through viral means is still the best way to ensure stability of that DNA cargo into the body, into the cell, through the cytoplasm to the nucleus. So it's essential that we do this as a virus. Now, that I hope answers the question of why. Next, why do phase 1 studies take so long, okay? I've had this conversation yesterday. Again, if you look at the cartoon, some of the things we want to address in phase 1 are the pharmacology of the virus itself, meaning once it's administered to you, how long is it in your body, and when is it eliminated? So when you see in an informed consent a viral shedding study, this is what you are going to consent to. So blood, saliva, other tissues may be collected from you so we can understand the pharmacology, the elimination of the virus, and as such, either environmental contamination concerns or actually spread to other individuals through unintended means. So this is one of the things we're doing with pharmacology. The other that we want to look at, the capsid and the virus itself, we want these things to be transient in the cell. The DNA, on the other hand, is something we want to exist in the cell in perpetuity. And this goes back to our previous speaker's point, why do we ask you for biopsies? This is largely the reason. The studies themselves take the time that they do because in order to ascertain if DNA has been delivered stably to a cell and is resident there, this isn't a process that takes days or weeks. It takes at least months and much closer to a year until we're fully convinced that that DNA is stable, it's in the cell. Also, from the biopsy, we need evidence that it's actually functioning. So we look for FKRP protein, and on the other side of the coin, we're also looking for biological effect, meaning do we reconstitute cellular architecture? Do we see binding of glycosylated alpha DG to its binding partners within the cell? That's a critical rationale to tell us we're in the right dose range and that dosing further patients is warranted. Also, just a particular sticking point with AAV, the capsid itself is a protein. The immune system sees proteins and makes antibody against that capsid, against that protein. Yes, it delivers DNA, but it also has the consequence of immunizing you against further AAV infection. This is, again, the reason why we're very cautious in phase 1 and proceed slowly. As the field exists now, you can receive an AAV-based therapy one time. So we want to give everyone every assurance that as enrollment proceeds in our clinical trials, it's warranted, meaning we have the right dose, we've delivered the cargo, and it's safe. Just another point, only to amplify on this. Yes, as we've said, all of you make FKRP, so all of you have this in your chromosome. When AAV is delivered to you as a therapeutic agent, AAV is not integrating into your chromosome. The DNA will penetrate the nucleus. It will exist outside the nucleus and express FKRP protein itself. This, we feel, is a safeguard. There is a remote, very remote, and really only an academic chance. We refer to this as insertional mutagenesis. If AAV were to insert into the chromosome, it could, in theory, cause some form of latent cancer. To date, there has been no evidence of that in any clinical studies of any kind. I just want to dispel that. But again, AAV is non-integrating into the chromosome, again, as a safeguard against just those kinds of events. In terms of gene therapy, again, the part to take home on this cartoon, you, if you participate in a gene therapy trial, will likely receive the therapy as an intravenous infusion. What this means is that your entire body will be exposed to AAV. So not only your musculature, which is the target of the therapy, but your liver, your kidneys, other organs. The target gene in this case is regulated such that it's coupled to another sequence of DNA that only makes that target protein within the muscle cell. Yet, as I've said, AAV will distribute throughout the body. This is the reason we have intensive safety monitoring, and I know it's burdensome to make the visits, but this is the reason we have the intensive safety monitoring. Just because we're expressing in muscle doesn't mean AAV itself, although non-replicating and not expressing FKRP, is present in other tissues throughout the body. So please be conscious of that. Again, individuals, as you all know, you express FKRP, but simply not enough. Again, the goal of the therapy is to deliver just enough FKRP to take you back into the normal range of function. In the second half of the cartoon, the point we're trying to get across is that this itself is more than just simply delivering AAV to a cell and off we go. FKRP itself as a protein must be expressed. It itself functions in a discrete location within the cell where the maturation and development of all that protein architecture that stabilizes, again, the dystrophin to the extracellular matrix complex. It's a processing enzyme. So FKRP has to be expressed, assemble, get to the Golgi apparatus, modify proteins, and then allow assemblage so that you can now recover from the stress of muscle contraction. Get to the status now of where we are. So the compound we have, or entity that we have in clinical trials now, has the company nomenclature AB 1003. It's an investigational therapy. It is not an approved therapy. So again, this hasn't been approved by a regulatory body for marketing, but it has been approved for clinical trials. We've been scrutinized on multiple levels and have orphan drug designation, fast track designation, as well as rare pediatric disease designation. The compound itself, like all of us in gene therapy, has been studied extensively in animal models, but we're now in our first foray to make that translation into human systems. We are in a phase 1 study right now as we speak. An outline of the cartoon of the study, and yes, I want to cut to the chase. There are lots of study visits in the first year. It is an intensive burden, and we admit that. But for the points we've made previously, this is required. The details sometimes are in the fine point, and if you just look at the middle of the slide, you'll see that some of these visits will be done at home. So please, as you contemplate clinical trials, understand that there's not a burden on you to come to see your doctor every week or every other week. Schedules can be arranged so that parts of the clinical trial can actually be accomplished in your home with home visits if you so consent. Again, you will see that there are muscle biopsies that are part of this, not open biopsies, but needle biopsies. And again, this supports the rationale for us to propose that the gene therapy is active, it makes the target protein, and it has its intended biological effect. That is the primary reason for the biopsy itself, not to determine is the therapy working or not, but does it support the biological thesis that we're pursuing. The inclusion criteria are listed here again in cartoon form. Again, from a general point in clinical trials, as we start trials, criteria tend to be rather restrictive. This is where we start. It's not necessarily where we finish. You'll see age restrictions. We would like to relax those as we go forward, including both younger and older patients. The LGMD-R9 diagnosis, we had conversations yesterday about the fact that one needs a confirmed genetic diagnosis to go with the clinical diagnosis. There are other conditions that resemble R9, so this is critical. We're starting with individuals who have the L276I mutation on both of their chromosomes. As we gather data, we hope to move into studies where individuals are not homozygous, but now heterozygous. L276I on one chromosome, but a different mutation on the other chromosome. And we ask that everyone be ambulatory, again, in order to ensure safety in the population. Just some notes essentially on what we'd like to do. The primary goal, as I said, is safety. We do say efficacy, but I'd like to stress efficacy endpoints and safety endpoints sometimes can be one and the same. The condition that all of you have, we recognize is slowly progressive. On the other side of the coin, we do not yet know what the kinetics of response are going to be. That means that response kinetic may not take weeks, it may not take months, it may have to be measured in a year or more. The efficacy endpoints that we take in these initial phase 1 studies, just as they're targeted to potential positive effects, we want to ensure that no one's condition is degraded as a result of taking gene therapy. So they're used and interpreted in both ways. Just to give you a status on our ongoing phase 1 study. And this is, I want to take just a brief side trip. We have planned 2 doses. Why do we do that in the pharmaceutical world? I've talked to many individuals. I want to wait for the next dose, or as things advance, I'd like to get more drug, if you will. As I've said previously, all of our work to date has been in animal systems. A big question in phase 1 is to understand how that animal work translates to human systems. So even though low dose may translate in some parlances as less effective, high doses could be more effective, I'd like more, we need to address the question, what is the scaling from an animal system to a human system in order to get to the optimum dose? So please, to the extent you can, free yourself from the parlance of low and high, good and bad, etc. This is really dose optimization to understand our models and our human systems much better. But just as a brief summary of the results, our cohort 1, our entry dose is completed. We've reviewed all the data with the Data Safety Monitoring Board, and the DSMB has agreed wholeheartedly to continue in that dose escalation, which we have. So patients are now entered into that second cohort receiving, yes, the higher dose that I said, and that cohort is ongoing. And well, just I should mention there have been no serious adverse events, no grade 4s, no grade 3s, no evidence of a dose-limiting toxicity. So the therapy itself to date is safe. And again, that's the primary driver for the DSMB's decision to move forward in clinical trials. If any of you are interested and wish to learn more about the study, either just to learn about the study, gene therapy, or possibly enrolling yourselves, here's a QR code that all of you can take advantage of. So thank you, folks. I'd be glad to talk to any and all of you as the day proceeds.
Thank you. Thank you so much. What a great presentation and very informative as well. Our next presenter is Joanne Donovan. She is an MD and PhD, has been Chief Medical Officer at Edgewise since 2021. She has been in multiple roles in industry for over 25 years and has been working to develop therapeutics in the muscular dystrophy field for a dozen years. Please welcome Dr. Donovan.
Thank you. Thank you. And I'd also like to thank you and the organizers for having the opportunity. It's really very impressive, the group that you have brought here today. And I'm honored and delighted to speak to you. So this is about limb-girdle. I'm talking about sevasemten. And in fairness, we have primarily been looking in Becker and Duchenne muscular dystrophy. So why? And actually, when you go back, when limb-girdle muscular dystrophies, the phenotype, as Dr. Sproul said, was identified, Becker fit into that phenotype. It was generally a disease that progressed during the adult years, diagnosed around age 10 or so, but progressing over the adult years, and with proximal muscles particularly affected. And it was only when the dystrophin gene was identified that it was realized that Duchenne was the absence of dystrophin and Becker was partial absence of dystrophin. And Becker actually fits very well in a group of limb-girdle muscular dystrophies in which the dystroglycan complex is affected. Now, I'll speak to that. So I will say we are a public company. And this is an investigational therapy, so we have to put all of this fine print that I appreciate that you don't read. But you can if you want. So what we have been doing, we were founded in 2017. And we are a company that is very much focused on the muscle unit, on the biology of the muscle unit. And we have a really spectacular basic science lab to look at the effect of the molecules we've discovered on muscle contraction. And the aim was, can we modulate contraction in a way that can have a beneficial effect on a number of muscle diseases? So the initial observation, which actually dates back to a couple decades ago, is that there are two types of muscle fibers, fast and slow. And it turns out that the fast muscle fibers are particularly susceptible in a number of muscular dystrophies. What sevasemten does is it targets the fast muscle fibers. It is a daily oral tablet that is designed to protect the fast muscle fibers from the injury that happens upon contraction. And this is a mutation agnostic therapy. So it doesn't matter what kind of mutation we're looking at, it has the potential to act basically in the same way because it does affect the root cause of the condition, the contraction-induced injury that happens. So we've done a lot of animal work. And in that, sevasemten protected susceptible skeletal muscle fibers and prevented and looked long-term to prevent muscle damage. We started in clinical trials, and in our initial trials, that we were able to see that sevasemten decreased biomarkers of muscle damage. That's the thing that you can see fastest. When muscle fibers are damaged, they leak these biomarkers that are in circulation, and we can very easily see the changes in biomarkers. And that guides us to, for example, to select dose of the drug. We saw that very early. And then as we went on in dosing, we were able to see functional improvement compared to the natural history of the disease. And now we are in a pivotal study, that is the last study before you go to the regulators and say, here's a package that we think the drug should be approved. So we've made a lot of progress over the last several years. The drug has really been in patients for since about 2022. So I have to go to the next slide. So what does the dystroglycan complex do functionally? And you've seen this a lot of different ways, and Dr. Campbell told us yesterday that the complex doesn't actually look like this. It looks very different. But what it does is it cross-links the muscle fibers to provide support during contraction. So the muscle fibers are stressed during contraction, and an analogy that I like to make is a rope. If you think of the fibers in a rope, you can snap the individual fibers quite easily. But if you twist the rope and those fibers have lateral support, then the rope is very strong and it's resistant to damage. So that's what the dystroglycan complex does. It actually laterally supports across the muscle. It doesn't contract the muscle, but it allows during contraction the support of muscle fibers to support each other. And that complex is composed of multiple things. It's composed of dystrophin within the muscle cell, and it's composed of a number of other glycoproteins, including the FKRP, or related protein, as well as a number of sarcoglycans that all link together, and damage to and mutation in any one of them causes this same contraction-induced damage. So we see that sevasemten could be useful not only in a disease like Becker, but in other diseases that affect the dystroglycan complex. Now that's not to say all of the limb-girdle subtypes, but there's definitely a number of them that share this contraction-induced injury and could be potentially positively impacted by a drug like sevasemten. So what sevasemten does is it actually inhibits the power mechanism of the fast muscle fibers, only the fast muscle fibers. And on this slide, this is the only mouse data that I will show you, but on the left-hand side is a mouse muscle. It is a finger muscle, so as you can imagine, finger muscles in mice are small enough you can see through them on the microscope. And when the muscle is subjected to maximal contraction, you can see the damage happening. What happens is calcium flows into the muscle, and the muscle fibers actually rupture. That's what those blebs are. And that is with contraction. If you weren't contracting the muscle, it would not have the damage. On the right-hand side is with sevasemten, which has ratcheted down a little bit on contraction, about 15%. So I don't think I can make it run again, but the muscle contracts, but it's not damaged. And that visible contraction-induced damage that you see is completely ablated with sevasemten, but the muscle can still function. And that's where we want to be. When this happens, as you can imagine, with the rupture of muscle fibers and damage to the membrane, what happens is biomarkers are released into the circulation. So that's something that we can follow clinically in our early studies. So we have developed sevasemten with multiple clinical trials. After an initial phase 1 study in healthy volunteers, we actually included men with Becker in that study. And then we had an open label study to continue 12 men. And now they're actually out to 3 years of dosing with sevasemten. And I'll show you some of those results. We started Canyon, and we have the results of that I can show you, which is a phase 2 study in adolescents and adults with Becker. And we also then morphed that into a pivotal study. So we have now became Grand Canyon. And that study has enrolled 175 patients and is the study that will ultimately take to the FDA. We have an additional open label study that is now enrolling patients who have completed the ARCH study, the Canyon study, and Grand Canyon. And of the participants who have completed, 99% have actually gone into MESA. And that's very important for clinical development. You know, the open label study provides access to drug, but it also tells us important things about the longer term effects. We don't want to make a placebo trial run too long, and this allows us to continue to follow patients. It's very important for the FDA to see that longer term change. We also had done a pilot study with Dr. Vissing in Denmark, who you've heard his name mentioned several times. And that started to explore other diseases in which fast muscle fibers are particularly implicated. And that is the DUNE study. We looked at Limb-Girdle 2I, which you heard a lot about this morning. We also looked at McArdle disease, which is a glycogen storage disease, but nonetheless, fast muscle fibers are uniquely affected. And I'll also say that sevasemten is targeted and it's designed, you look at all different molecules to look at something that's very specific for fast muscle fibers. So it doesn't affect slow muscle fibers, it doesn't affect cardiac fibers either. So it's very targeted to where the damage is occurring. Now, how do we measure? We can look at biomarkers early, but then how do we measure disease progression in a disease that continues over decades? And how do we measure it in a population of people that we can see changes compared to placebo over a reasonable period of time? We don't want a trial to go on for years and years. And what we have been looking at is the North Star Ambulatory Assessment and also the NSAD that was originally designed for dysferlinopathies but expanded to other muscular dystrophies. And the NSAA was designed for Duchenne. It actually, all of the assessments in NSAA are also in the NSAD. So we've included both of them in the studies and looked at now this group of functions that are important in everyday life. So when you think about things like climbing a step, well, can you get up a curb when you cross the street? Being able to get up from a chair. So do you need to use your arms to get up from the chair? That makes a huge difference. And all of these assessments are assessed on a score of 0, 1, or 2. Can you do it at all? Can you do it with compensation, like using your arms to push up from a chair? Or can you do it without any form of compensation? So that's a general assessment of how function is. And these are of different, some of them are harder than another, so therefore that gives us over a whole range. It does confine it to ambulatory patients, so you'll see we've enrolled ambulatory patients in the study. There are other measures for non-ambulatory patients to look at upper arm function, which we've also included, as that is obviously incredibly important for daily life. But these, we have more in the way of natural history of the North Star in order to be able to design a study that will show change over, say, a 1.5-year period. So that's why we're using this, and that also guides our selection criteria for the study. As I mentioned, these are, even a 1-point difference can mean the difference between activities that are important every day, obviously. So this is something to try to put this in perspective. So we've now had men in the ARCH study over 3 years. And the symbols at the top show the North Star over 3 years. in this. And actually, the FDA guided us to, we really want you to focus on the North Star. They feel more comfortable with that than the NSAD, although we're collecting those data and actually in conjunction with the GRASP network are doing a study looking at North Star versus NSAD. So the North Star is stable over 3 years. What would have happened, what would you have predicted would have happened with the natural history? And we've collaborated with a natural history study with the University of Leiden, with patients with Becker, that looked at people up to 5 years, an average of 3 years, and designed or derived a model to see, well, what predicts decline? And using that model, that would have predicted that these patients that were enrolled would have gone down considerably, about 4 points. So that's very clinically meaningful, and 11 of those 12 are still participating. It's been generally well tolerated in that study, and that gave us a lot of information to start our phase 2 placebo-controlled study, Canyon. Again, we are looking at ambulatory patients with North Stars between 5 and 32. So they've started to decline, but because there are some genetic mutations that people do not decline very much over time. So in order to power a study, we want to look at people who will change over that period of time. We looked at biomarkers as the primary endpoint in this study. This was our initial study. We didn't have enough information to be able to power that, and enrolled adults and adolescents. Now, adolescents in Becker are typically at the top of the curve, and so there it was for safety. It was for to look at biomarkers, and it was a 12-month study with visits ultimately every 3 months. In terms of safety, it was very well tolerated. The most common side effects have been dizziness and sleepiness. We give the drug at night. It also happens right at the beginning of treatment. So I think that affecting a little bit how the muscles function can affect your perception, and it feels a little bit what ultimately gets described as dizziness. It's not the room spinning, and it's not associated with falls, for example. So what we saw was the biomarkers decreased significantly. The CK went down significantly over time, as well as TNNI2, which is specific to fast muscles. It's the troponin in fast muscles. It's not cardiac troponin that you've seen other places. And so that is very good proof of concept that the drug is doing what it's supposed to do. When we look at the North Star over a year, now the natural history is shown with the bluish triangle, and that's the range of estimates of what would change over a year, between 1 and 1.7 in several studies. And what we saw was that the participants who were on sevasemten, the 10 milligram dose, were stable over a year. So again, we're now looking at the 40 men in this study on top of the patients in the Becker study, and compared with the folks who were on placebo for the 12 months who did decline consistent with the natural history. And the natural history is really important to be able to put placebo groups in perspective, to be able to understand that it wasn't that they were different at baseline, that yeah, this matches what you would have expected the natural history to be in these patients. We have continued those folks in the MESA trial, as I mentioned, and after now 18 months, they're all stable. Continue to be stable, and the folks that were on placebo do not continue to decline. They are now stable. And even in the extension phase, generally well tolerated still. So a point is that they need to remain blinded. We can't tell them what they used to be on, because the FDA really wants to look at that data and say, well, when you moved over, did you change? And if you know what you were starting on, then it's not placebo controlled. So the FDA wants us to keep participants and sites blinded to the treatment assignment. We also, as I mentioned, did this DUNE study. This was a proof of concept study. It was a short study, and it was to look at contraction-induced injury in these 3 diseases, done at a single site, and a small number of patients, 9 patients with Becker, 9 patients with Limb-Girdle 2I, and 3 were on placebo for that period of time. For the beginning part, it was placebo-controlled, and they did a cycling protocol with maximum exercise. They did eccentric contractures with weights, and they did cycling. So it was designed to cause the biomarkers to go up. And Dr. Vissing and his colleagues had shown that previously. So we knew what would happen the 24 hours after they had that extreme exercise. Of course, we're also following them long term for changes in biomarkers, but it's very specific to that 24-hour period we want to look at. And what we saw was in Limb-Girdle 2I, we again saw the fast troponin going down. So again, it's targeting, it is Limb-Girdle 2I, the dystroglycan complex is compromised, and so you would expect, and you do see, contraction-induced injury. Fast troponin is down. Same thing with CK, although fast troponin is more specific. So these trended down these came down at baseline, small numbers, but nonetheless, we're seeing proof of concept in Limb-Girdle 2I as well. So we saw multiple biomarkers. We do lots of biomarkers over a whole panel of circulating biomarkers, and sevasemten was well tolerated here as well. So our Grand Canyon study is fully enrolled. That is looking at North Star after 18 months. We've gone to the FDA to discuss it with them, and they are very pleased with the design of the study and want us to come back with the full data. And that's what we're planning to do. The information will be available towards the end of next year. In February, we fully enrolled the study. And it's adequately powered, we believe, to be able to answer the question, which is, of course, what you really want from a clinical trial. Is it going to have enough people in it to power being able to see a difference? So we feel that is good. We are, in this trial, because of the safety, so each trial builds on each other. And because of the safety we've seen, we're able to spread out the visits to now every 6 months. After the first 6 months. There's telephone calls in the middle, but to try to decrease the burden. And we're looking at the functional tests. We're also using an accelerometer to be able to look out in the real world how people are functioning in terms of their gait. So these are the trials that are ongoing and completed. We also have a program in Duchenne where we recently announced data that we've identified a dose in Duchenne and are moving forward with that and talking with regulators and planning for a future trial. So we're excited about the possibility of not just in Becker and Duchenne, but across a range of muscular dystrophies as well. So thank you for listening. There's an email there to ask for more information. And of course, all of this rests on the burden, the hard work of the participants, the sites, and everybody who is literally, it takes a village to do these studies. And we are very appreciative to the community that enables us to move this forward. So, thank you.
Thank you so much, Dr. Donovan. And I would just implore everyone in the room, I'm sure that our presenters would be happy to take questions after the session if they'll stick around. Would you mind? And then if you have an individual question that you'd like to share with them, I'm sure they would answer. And also, don't be afraid to ask the question, I have this particular subtype. Do you think your treatment could possibly be applicable to mine? Our companies are always willing to answer those types of questions, and And in my experience, I think all of the companies are open to subtypes that they think that their treatment would work effectively. They're not cherry picking particular ones. They're really looking for the ones that are the best match and the ones that they think would be effective for their therapy. So you guys ask away, and they're such generous people. I'm sure that they will be happy to answer questions. Thank you so much to our panelists. Wonderful to have you here. What an honor, isn't it? And thank you most of all for all you're doing for Limb-Girdle and the time that it takes and the investment it takes with your, I know it takes a lot away from your family to travel a lot and be here for patients, but we really thank you. So one last applause. Thank you.
Welcome to the cardiac and respiratory involvement and management session at this conference. And this is a session that we've had at every conference because it's a very important topic in limb-girdle muscular dystrophies. You've heard a couple of the people speaking yesterday sort of mentioning that some LGMD subtypes can have respiratory involvement, others can have cardiac involvement, others can have both, and that's one of the reasons for that it's important to try to find out what subtype you have. And to begin this, I just wanted to, give a sort of mention in honor of a couple of, beloved and, very important community members that unfortunately we recently lost, both due to, either cardiac or respiratory complications. So the first person I want to honor today is Mark Barnett. I had known him online for several years, as did many people in the community. I got to meet him in person, you see the photo up there, at the first LGMD conference in Chicago in 2019. Next slide. And a couple of the things that he was known for, he was very active in the LGMD patient Facebook community, and sort of just for fun, he created this group where every Friday he would post these sort of interesting facts about history, science, trivia, and actually, since his passing, his daughter has taken it over and kept it going. On a more serious note, Mark, for many years, didn't know what LGMD subtype he had. He participated in all of the sequencing events that were out there. Finally, he got a diagnosis. It turned out to be something that's not officially considered an LGMD, but is kind of one of the close lookalikes. So clinically it looked like he had LGMD, although that wasn't the official diagnosis. But as reaching out to the community, he created this group, LGMD subtype unknown, for all the other people who were out there looking for a diagnosis. So Mark was a respected and beloved member of the community. I was fortunate to know him. I was fortunate to have met him in person. Next slide. So the other person I want to mention is Jill Dopp-Viles. She has a muscular dystrophy caused by mutations in lamin A, which now is most commonly categorized as an autosomal dominant Emery-Dreifuss muscular dystrophy. But in sort of the previous LGMD nomenclature was, also designated as LGMD 1B. And one of the things about this you'll hear in the upcoming talk is it tends to have a lot of cardiac involvement. She just came out with a book, which unfortunately she didn't quite live to see the release, but it was all completed. And one of the things about her was she didn't have a science background, but she learned the science and called herself a citizen scientist, to find out about this gene, figure it, get herself a diagnosis first, and then wrote many blog posts and interviews, and now this book about her experiences in learning about the science of neuromuscular diseases and also her self-advocacy journey. So it just came out about a week ago. So thank you. And I did have the opportunity to meet her about 10 years ago as well. So thank you for your services to the community, Jill. Okay, with that, we're going to have our first presentation is going to be pre-recorded from Elizabeth McNally. She is both a medical doctor and a researcher at Northwestern University. She's worked studying various forms of muscular dystrophy, including LGMDs, for many years. Her medical specialty is cardiology, so she's an extremely well-qualified person to talk about, issues both of the heart, in the context of LGMDs. So we'll watch her pre-recorded talk.
Hi, I'm Elizabeth McNally. I'm a cardiologist and I direct our Center for Genetic Medicine here at Northwestern, and I also staff our muscular dystrophy clinic at Northwestern. And I'm going to talk today about cardiac management in limb-girdle muscular dystrophy. These are just some of my disclosures, and they are unrelated to the topic of my talk. So I will give you a brief overview, which is we'll talk first about genetic diagnosis and the importance of knowing what your genetic defect is so that we can properly manage your heart. Certain gene changes are what cause cardiomyopathy associated with muscular dystrophy, while others of the genes don't tend to affect the heart very much. We'll talk briefly about some biomarkers that are important for following your heart. We'll follow with talking about managing heart rhythm, because that's very important in some subtypes of limb-girdle muscular dystrophy. And then we'll emphasize the importance of having a multidisciplinary team, which includes respiratory management, which you'll hear about later in this session, and then some very brief considerations as we begin to enter the era where we think about gene therapy. So first, there are multiple types of muscle. There is smooth muscle, which is found in the gut and in arteries. There is the heart, which is cardiac muscle. You have both atria and ventricle, which are slightly different from each other in terms of what they look like. And then we have skeletal muscle, which most people are familiar with, and that is what is targeted in the muscular dystrophies. And some subtypes of the muscular dystrophies also have associated cardiomyopathy, and that's because the genes that cause this problem are also expressed in the heart, and so that's why you get associated cardiomyopathy. And so the key neuromuscular diseases that have cardiac involvement, we're familiar with Duchenne and Becker having cardiac involvement, but when we think about the limb-girdle dystrophies, there are both dominant or type 1 forms of limb-girdle muscular dystrophy that can have cardiac involvement. And here I'll mention the genes LMNA or lamin-A, Desmin and Titin, so that's DES and TTN. And then the recessive forms, of which there are many, but the ones that we think of the most in terms of having cardiac involvement are the sarcoglycans, FKRP, Titin again, and then as I said, there are others. And there are these other forms of neuromuscular disease that can also have associated cardiac dysfunction. And I only mention all of these because there is a lot to learn about how to manage it in the limb-girdle muscular dystrophies that can be be gained from knowing more about these other disorders. And so ideally, when you're working with a cardiologist, you're working with a cardiologist that has familiarity with these different diseases and how to manage your heart. This is data from a profile of over 4,600 limb-girdle muscular dystrophy patients who had genetic testing. And it just gives you the breakdown of what limb-girdle muscular dystrophy looks like in this population, where the majority of mutations were found in calpain and dysferlin. And then you see all the other genes that are smaller contribution. FKRP is 9% of this population, ANO5 is 7% of this population. And then all the ones with little red hearts next to them are associated with having known cardiac involvement. The ones that have yellow hearts are the ones that have been described as possibly having heart involvement, whereas the ones with the red hearts indicate that we have seen much more consistent heart involvement in those forms of disease. And that's depicted the same data along this line here, where again, we're very familiar with titin having an important role in the heart. This one here, I'll mention lamin, and why it has a little lightning bolt here is because the arrhythmia issues are very important here. And desmin also has arrhythmia issues associated with it. But all of these with red hearts can have heart involvement. And I will just emphasize, while these other forms may not have as much cardiac involvement, there's nothing to say that your heart can't be affected by the ordinary things that can happen to hearts, meaning blockages in the arteries or atrial fibrillation. And so it's always important to recognize that heart disease is pretty common in the population. And just because you have muscular dystrophy doesn't mean you won't have heart disease. This was another big study of 25,000 patients. This just highlights that a lot of the time you get variants of uncertain significance, and it can be hard to get a genetic diagnosis for yourself to know what this is going on here, but this has gotten better. But overall, when we test limb-girdle patients, we get a yield about over 20% of the time to get a genetic diagnosis. So flipping to the heart, there are multiple types of cardiomyopathies. Dilated and hypertrophic are the most common. Cardiomyopathy is what we see when we look at the heart, so that's usually with an echo or with an MRI. Heart failure is based on the symptoms and measures, and heart failure itself is a pretty terrible term. It sounds awful, but it really just means that your heart isn't quite doing the job of what you need for your body. And sometimes you don't have heart failure symptoms at baseline, but when you get under stress, get a bad illness, or have other things going on, that can be when heart failure symptoms manifest. How do we treat heart failure and cardiomyopathy? We have what's called the 4 pillars of medical treatment, which are well established in the cardiovascular literature, and include what we call ARNIs, beta blockers, mineralocorticoid receptor antagonists, and SGLT2Is. And I'll talk more about those in the next slide. So what do we mean by these? Neprilysin inhibitors are a newer class of medications called ARNIs, and the main one is called sacubitril valsartan, otherwise known as Entresto, and it is going actually off patent, so soon will be more known as sacubitril valsartan. ACE inhibitors and angiotensin receptor blockers were what we used to use, but now that in the cardiology field, that's really been supplanted by using ARNIs. Beta blockers are things like metoprolol and carvedilol. They are beta adrenergic blockers, so they block adrenaline and they help the heart in that way. Mineralocorticoid receptor antagonists are spironolactone and eplerenone. And then more recently, over the last probably 5-10 years, we've been using SGLT2Is, which are primarily for diabetes, but also have tremendous benefit for the heart. And those are medications like Jardiance and Farxiga. Special considerations when managing the heart in muscular dystrophy. A lot of what we do in managing the heart has to do with how well people can tolerate their activities that they do, whether that's exercise or just day-to-day life. And obviously, activities are different in people who have muscle disease. And so sometimes it can make it hard to figure out whether people actually are experiencing heart failure because they are not as active as other people. For that reason, biomarkers are really important to use to follow. And there are multiple studies in the Duchenne population and some studies in some other neuromuscular patients showing that NT-proBNP is actually a very sensitive and useful biomarker to know whether somebody's in heart failure. There's also a test called BNP, but the NT-proBNP is actually the more sensitive one. Low blood pressure or hypotension can be a problem. If you don't have normal muscle mass, measures of kidney function don't work very well. That's serum creatinine. And so instead we use a marker called serum cystatin C. And other heart markers can also be up, like serum troponin, which can indicate heart injury, and that can happen in muscular dystrophy. And then liver function tests may be up also, and that's just a side effect sometimes of having a lot of muscle involvement. And we talked about those 4 pillars, and we can use these 4 pillars of medical treatment and see an effect on our markers, which can be our biomarkers like NT-proBNP, but we can also see that in terms of following cardiac imaging, which is done by MRI and echocardiography, which you'll hear about from Dr. Rauchi. So, oops, I'm sorry, I think I've gone the wrong way. So air exchange is especially important when we're thinking about muscular dystrophies, because the muscles like the breathing muscles, diaphragm, intercostals, and abdominal muscles can all be affected. And so that can put strain on the right ventricle and the pulmonary artery and can contribute to having further cardiac dysfunction. So this is why it's critically important to make sure you have a good pulmonologist on your team that knows how to treat muscular dystrophy patients. In the last minute or two, I'm going to talk about the electrical system. The electrical system is separate in the heart. It starts up in the atria, the electrical, and then goes through the atrial ventricular node and down through the ventricles. And this is what makes the changes on the EKG that we see. So the P wave indicates the atrial activity, and that can be very disrupted in certain forms of muscular dystrophy and manifest in the form of atrial fibrillation. We use heart rhythm monitoring devices. Your cardiologist or doctor can order a patch monitor. That's very common, can monitor up to 14 days. This is a device you can buy yourself, which is called a Cardia. You put your 2 fingers on it and get a pretty decent tracing on your cell phone. The smartwatch gives you just a single tracing and is really only good for looking at atrial fibrillation. And then you just have simple heart rate monitors that will just tell you if your heart is going faster or not. But they can still be very useful. Lamin deserves special mention, LMNA, because you can have heart rhythms that go too fast or too slow, both of which are demonstrated here. We treat rhythms that are going too slow with a pacemaker, and for rhythms that go too fast, and if they were to continue doing this, they are treated with a defibrillator that can deliver a small shock or pacing that can reset the heart. Hopefully, most people don't need this, but I mention it because Lamin really does require special monitoring. I also wanted to mention Titin, TTN, which is an enormous gene that can cause muscular dystrophy and is a very common cause of dilated cardiomyopathy in the absence of having muscle disease. And so sometimes we see patients with Titin who have 2 copies of Titin having a problem in them. And it's important to look at those because while that person may have muscle disease, other of their family members, by just having 1 copy of Titin having a problem, can also be at risk for dilated cardiomyopathy and atrial fibrillation. So this is when family management is really important because we know, again, increased risk for atrial fibrillation as well as ventricular arrhythmias because of the cardiomyopathy. We do have advanced options for treating abnormal electrical activity in the heart. So for atrial fibrillation, ablation has become a fairly common approach, which can have good efficacy. And there are some really newer techniques that work extremely well for this. Sometimes people have abnormal rhythms coming from the ventricles or ventricular premature beats that are in excess numbers. That can be treated sometimes with ablation, although we don't typically need to do that. We can use ICDs or intracardiac cardioverter defibrillators that can be used to treat abnormal rhythms. For advanced heart failure, we can use something called pacing or biventricular pacing, which paces both the right and left ventricle, which is called CRT. And then it's also important to consider the use of anticoagulation, especially for patients who are having atrial fibrillation, because if your heart is having atrial fibrillation, you have an increased risk for having thrombus or clots develop inside the heart, which can create an increased stroke risk. And these days we use medications called DOACs, which are very easy to take and do a great job at reducing stroke risk for people who are in atrial fibrillation. Very advanced measures for managing the heart include left ventricular assist devices or transplant. These are, quite frankly, very rarely used in our muscular dystrophy patients, often because our other treatments are just very, very effective, and we usually don't need to move on to these very advanced measures. I also want to mention, because we're now in the era where we're thinking about gene therapy for limb-girdle muscular dystrophies, there are a number of muscular dystrophies that have already begun to have some patients be engaged in clinical trials looking at gene therapy. This includes the sarcoglycans, FKRP, and then planning for calpain. These are mostly limited right now by, can the gene product itself fit within the AAV? So that's the virus that we use to deliver it. And so only the smaller genes can actually fit within that. And so that's what's the major limitation in moving this forward. But as you can imagine, with all these different genes and proteins causing muscular dystrophies, the concept of doing gene therapy is quite complicated because we are dealing with so many different diseases and so many different genes. And then as we think about gene therapy, and especially for those LGMDs that have heart involvement, we need to have not only a virus that gets into the heart so the AAV can transduce the heart, but we also need to have a promoter, which is the sequence that drives expression of that gene product. It has to be active in the heart. And so that's very important when thinking about gene therapy, which is to make sure that that the virus is getting into the heart, and that once that gene gets into the heart in the gene therapy, that it can be turned on effectively in the heart at not too high of a level and not too low of a level, but so that it's effective in treating disease. And so in conclusion, it's really important to know your genetic subtype of disease, because this is what determines whether you're going to develop cardiomyopathy, heart failure, and arrhythmias. Certain genes have an exceptionally higher arrhythmia risk. That's lamin, desmin, filament C is another one. The heart can be treated early, so it's important to have a good relationship with a cardiologist who's knowledgeable. And as we move into the gene therapy era for LGMD, we have to consider the effects of treating the heart. Thank you. And with that, I'll pass it back to Brad.
Thank you, Beth. So our next presentation will come from Frank Rauchi. He's an assistant professor of pediatric cardiology at Children's Hospital of Richmond at Virginia Commonwealth University. And so he's going to talk about the sort of cardiology aspect of LGMD in younger patients. Thank you.
And I just want to thank Brad and the rest of the organizers for inviting me to give this talk. I have no financial disclosures. So I wanted to talk about this more. You heard some of the information, and I may touch a little bit on that Dr. McNally talked about, but really, so you're just diagnosed with LGMD. What do I need to know about my heart? And then that can mean many different things to different subtypes of patients. So not all LGMDs carry the same risk for heart disease. And so what you need to know may be different. But when we talk about heart disease, I just wanted to take a step back and talk a little bit about the three main types of heart disease that we think about as cardiologists. One of those is conduction disease. So this is problems with the way that the normal pacemaker cells can communicate from the upper chambers in the atria to the lower chambers of the ventricles to have coordinated blood pumping to the lungs and to the body. Then there are arrhythmias, which are abnormal heartbeats that don't originate from those normal pacemakers, and there are many different pathologies, different ways in which those abnormal heartbeats can be formed, and we'll talk a little bit about that. And then sort of a bigger class is cardiomyopathy, and this is where there's something that happens to the normal heart muscle where it either can't pump blood effectively or normal heart muscle is replaced typically by scar or fat or some combination. And complications of these can lead to heart failure and or sudden cardiac death. And so clearly these are important things to keep in mind. I like this little cartoon just to show what the normal conduction system looks like. And you can see over here, we're going to talk about ECGs in a moment, but the ECG over to the other side is that electrical signal that we see whenever that is representation of the electrical system in the heart. And so there's a signal that comes from that sinoatrial node is the pacemaker. It tells the atria when to contract, and then when the ventricles, which are the main pumping chambers, when to contract. So everything is coordinated. I know that Dr. McNally already touched on these, so I'm just going to show these. I do want to mention, though, that The LGMD Family Guide that was presented and rolled out yesterday, there's a very extensive list of cardiac involvement and importance for screening for different subtypes. So if you hadn't had a chance to look, please take a look there. And when we talk about arrhythmia, arrhythmia is important not only for the potential to cause a lethal arrhythmia, but also because it can affect how the heart beats. And so this is just another cartoon showing an example on the one side of normal rhythm, and you can see those big arrows are supposed to represent the amount of blood that comes through. And so the atria are putting most or all of their blood into those ventricles, and then they pump out the blood effectively. In atrial fibrillation, where the atria have an abnormal rhythm where they're beating too fast compared to the rest, to the ventricles, there's an inefficient movement of blood in there. And so you can have symptoms of dizzy, pass out, or other things like that. Atrial arrhythmias are not the only type of arrhythmia that can be seen in LGMD. Atrial and ventricular arrhythmias have been described, again, in many different subtypes. How does this occur? The mechanism can vary depending on the subtype and the gene mutation involved. I'm just going to present some broad general categories. One is obviously you have a defective protein, and the protein may be involved in normal muscle function, and as that function changes, that can affect the way that the muscle cells communicate from cell to cell. Disrupted protein complexes, you've heard a lot about sarcoglycan and dystrophin glycoprotein complexes and how those are important for transmitting the force between the cytoskeleton and the extracellular matrix. However, that damage can also potentially affect the conduction system, and over time can also predispose to rhythm problems as well. Instability in the sarcolemmal membrane, which is the muscle fiber membrane, can result in death and degeneration of the muscle cells, and this can disrupt the normal way in which those cells communicate to each other, causing abnormal electrical signals. And then calcium is very important for what we call excitation-contraction coupling. And so the excitation part is that electrical signal that is caused by movement of ions that carry charge across the membrane, and that as it moves from cell to cell is what tells each cell when to contract. And so if calcium is disrupted, which happens in many forms of LGMD, then that can predispose to abnormal rhythms or abnormal signals being transmitted. And then in general, disorganization of muscle fibers or myofibrils can lead to abnormal conduction pathways and again predispose to rhythm problems. I just wanted to point out this was a really nice study that sort of puts this into focus. So this is from patients with LGMD who had dilated cardiomyopathy, so already had signs of muscle disease. And they took cells from those patients and from healthy controls and created induced pluripotent stem cells. And these are cells that you can then induce to form different types of cells, including cardiac muscle cells. And so they did that, and here's just an example, a picture of some different types of proteins, troponin, actinin, and dystroglycan in those healthy donors. And then you can see that there is disruption in those different proteins whenever we look at the cardiomyopathy patients with limb-girdle. And what's important, what I want to point out from the mechanism for arrhythmia, is that there are actual properties changes to the action potentials, and that's the unit of electrical signal as we go from cell to cell that are changed actually in these muscle cells. So the height, the peak, amplitude of that action potential is altered, the duration of the action potential is altered, and this has important effects on both rhythm and potentially contraction as well. And I don't want to go into the details about this, but the other important thing that they found is that at least in part, the alterations that they see in this is due to changes in ion channels. And again, those ion channels are important for the conduction of the normal electrical signal. are altered. And so those properties being altered can predispose these patients to rhythm problems as well. So when we talk about a cardiac evaluation, really we start with a baseline. In pediatric patients, most pediatric patients are not going to start with heart disease, or at least not severe heart disease. And so really we're trying to establish a baseline and to move forward so that we are able to catch cardiac disease early. I will say that it is also important to note that there's a lot of variability in when cardiac disease can occur in the group of limb-girdle muscular dystrophies. And so some patients, even with the same subtype or the same exact mutation, may present in childhood, whereas a family member may not have any involvement at all or may have involvement late. And so it's really important. We can't just depend on what the mutation is for determining that. One of our most common screening tools is an ECG or EKG, electrocardiogram. We saw some of these before. It's really just a 3-second snapshot of the electrical activity of the heart. And it's very good for screening for things like conduction disease, because conduction disease is usually stable. So as it develops, it doesn't change very much. And so it's easy to see even in that 3-second snapshot if there's changes that are important to follow. You may also catch abnormalities that could be predisposing to arrhythmias, but these sometimes can be transient. You may not see them every time. So for those types of screening, we also do something called a Holter monitor. I think Dr. McNally also showed sort of a picture of this sort of thing. Does the same thing as an ECG, except that we look at all of the heartbeats over a period of time. Usually we do this over 1 to 3 days, but can be up to 2 weeks. If we're having, this is in particular, if we have patients who are having symptoms, we may do something called an event monitor. And so this is similar to a Holter, except it looks at the heartbeats in a particular time when you're having symptoms. So it has a buffer, it's always recording, but then it deletes those heartbeat data if you don't press the button to show whenever you're having symptoms. And so you can look at this over a longer period of time to see if those symptoms are related to an abnormal rhythm. And then for really difficult ones, we also have something called an implantable loop recorder. So this is a small device that gets implanted just under the skin and works like an event monitor, but lasts much longer and doesn't have any limitations. You can go in the pool, you can get wet, you can do things like that without having to worry about any kind of damage, and it continues to capture arrhythmias over longer periods of time. And these can stay in for years if needed. So moving on to cardiomyopathy, the incidence of cardiomyopathy is mutation dependent. But interestingly, there's a study of 100 patients with various subtypes that found about a quarter of them had heart involvement. And again, the sarcoglycanopathies have an even higher rate of cardiac involvement. Up to 2/3 of patients may have heart involvement in that case. And again, just like with arrhythmia and conduction abnormalities, the mechanism for this is going to be subtype dependent and mutation dependent. Defective proteins are clearly important, but also this disruption in the protein complexes, as has been mentioned by several speakers, leads to muscle cell death and cardiac fibrosis, which is that scar formation that replaces normal healthy muscle cells. The instability of that sarcolemmal membrane can also cause fragility of the cells and muscle cell death and fibrosis as well. And calcium handling, so we talked about the excitation part, but also calcium is very important for the contractility and the contraction, the ability for that individual muscle cell to generate force and for those muscle fibers to generate force. And so if the calcium is disrupted, that can also alter the ability for each of those subunits to be able to contract and can affect muscle strength as well. And then the disorganization in those muscle fibrils can lead to disrupted contractility because they're just not as effective, as well as ultimately leading to cell death and scar formation. So how do we look at this? One of the best ways to follow this is using cardiac imaging. This lets us ensure that the structure of the heart is normal and also allows us to look at the function. When we talk about function, the most common way of expressing that is ejection fraction. We're usually talking about the left ventricle, which is the ventricle that pumps blood out to the body. And it's really just it really is just a fraction of the blood in that left ventricle that is pumped out to the body with each heartbeat. And the normal range is 55 to 75%. You'll sometimes may see other measures of this, particularly if it's difficult to get an estimation of the ejection fraction in some cases, which we'll talk about in a moment. But shortening fraction or strain can also be used as markers of function as well that you may see if you get an echo report. And so the echocardiogram is probably the most ubiquitous of our cardiac imaging modalities. And this uses high-frequency sound waves to take pictures of the heart. And these look something like this. And you can see here on the one side, we have these two-dimensional pictures that are in different planes showing what the ventricle looks like. You can also use Doppler, which takes advantage of the movement of the sound waves towards the probe or away from it to make pressure estimates within the chambers. And we can also make, again, some more detailed measurements. However, there are some drawbacks to echo, and I'm going to talk about why cardiac MRI may be a better test, in particular for neuromuscular diseases. So cardiac MRI uses a strong magnetic field to take detailed pictures of the heart without exposure to ionizing radiation. And it has a few benefits, like I said, over other imaging modalities. So first of all, it's considered the gold standard for determining volume and quantifying the function within the ventricles. And so this is a picture of a cardiac MRI, and you can see quite clearly both ventricles, how they're moving. And the advantage for us is that we can take multiple slices as we do these pictures, and we calculate the volume in each one. So rather than having to make an estimate like we do in echo, we can very closely measure the volume and thus the ejection fraction in the MRI. It also lets us do something that we call tissue characterization. And so we are able to use different sequences in the MRI to look for early evidence of disease, such as early scar formation or inflammation or edema within the heart that we can't see by imaging with echocardiogram. And one of the problems that, in particular, that we see with neuromuscular diseases, LGMD, is that we are dependent with echo for what we call acoustic windows. So the sound waves have to go into the tissue and come back to be able to make those pictures. And those imagers can be difficult to obtain, particularly as disease may advance. If you have involvement, for instance, of the intercostal muscles, then the rib spaces where we're looking may become narrower and more difficult to see. Or if there's respiratory involvement, there can be air trapping that can make it difficult to get accurate pictures of the ventricles to be able to make that functional assessment. We also give what's called gadolinium as a contrast agent, and this is part of the tissue characterization process. And the importance of this is that gadolinium stays within the blood pool, goes to areas that are perfused by the blood, and is cleared very quickly by normal muscle. But if we look then after that initial phase where the healthy muscle has cleared the gadolinium, we can see what's called late gadolinium enhancement, and this is typically a marker of abnormal tissue that shouldn't be in the muscle wall. So scar, sometimes fibrofatty replacement with this combination of scar and fat. In one small study of 16 LGMD patients, about 50% of them had evidence of late enhancement. And this is important, and I think one of the powers of using this as a screening tool, in that all but one of those instances were subclinical. And so they had no evidence of dysfunction on echocardiogram. They had no clinical symptoms, but almost half of them had late enhancement, so early involvement of the heart by MRI. In another small study with a higher proportion of patients who had heart failure, so in this case 60%, almost 90% of them had late enhancement in the left ventricle, and a significant amount had right ventricular involvement with either fatty replacement or LGE in the right ventricle. Why is this important? You don't need to see all the details of this chart. This is just from a study looking at the number of cardiac events based on cardiac MRI estimation of ventricular function and late enhancement. And as you might expect, if your function is lower, so the blue here is with a normal ejection fraction, and the red as you go down is event-free probability, about over 50% of patients who had less than 55% ejection fraction, so abnormal function, had a cardiac event during the study period. And although not quite as large of an effect, if you look at just patients who had late gadolinium enhancement, those patients who just had enhancement also had an increased incidence of cardiac events during the study period. And so what do we do then if we see any kind of abnormalities? Usually we reserve treatment for patients that have abnormalities on their testing, although in some patients that are particularly high risk of cardiac disease, we may use prophylactic treatment. And really our goal is to prevent what we call negative remodeling, and also to improve or stabilize abnormal function, and if symptomatic, to improve symptoms. And when I talk about this remodeling, when we talk about it as cardiologists, we're talking about this replacement of normal muscle that you can see in the healthy heart here on the one side, and then over time that gets replaced as the cells die and are replaced by scar by this abnormal tissue. And so all of this yellow staining here is non-contractile tissue. And so as you might imagine, that's not going to be efficiently able to provide the pump ability that the heart needs to get blood to the body. I'm going to just show that Dr. McNally already talked about all of these cardiac medications. I will just mention one other one, in that in more severe heart failure, we may use diuretics that will help to decrease the amount the size of the chamber. As it gets big, it can be less efficient to pump blood, and so we will sometimes use diuretics as well in more advanced heart failure. I do want to talk about lab monitoring just briefly. I've had several patients that ask, well, why do we need to do imaging? Why can't we just follow labs? And Dr. McNally talked about this slightly as well, but BNP and troponin are often used as biomarkers in patients with heart failure. And in patients with muscular dystrophy and heart failure, they can be useful to follow those patients. But as you can see here in this middle section, in patients who have muscular dystrophy without cardiomyopathy or diagnosed cardiomyopathy, those biomarkers, this is for B natriuretic peptide and troponin, they're really not any different than healthy controls. And so if you have cardiac involvement, these biomarkers can be predictive of events, and that's why they show in this bottom panel that elevated BNP and elevated troponin, or the combination, is predictive of having a cardiac event in patients who have heart failure. However, it's less clear that these are of benefit in screening patients without cardiomyopathy, and really imaging is much better at determining that. Dr. McNally touched on this too, but I want to emphasize that not only is it important for trying to get the packaging the gene therapy into cardiac muscle for the beneficial effects, but sometimes there can be inflammation or other side effects that happen within the heart, even whenever that is not intended. And so increased surveillance is needed during active therapy, and at least in the short term after completion of therapy. And I want to emphasize too that we really don't know what the long-term cardiac complications will be of treatment. And again, tying this back to the pediatric population, as pediatric patients also may get some of these therapies, we really don't know how that will affect over the longer term their cardiac function as well. And so they'll need increased surveillance as well. So I just want to thank everybody again, and that after the session, I'm happy to answer any questions. Please come find me.
Thank you, Dr. Rauchi. Okay, so for the pulmonary part of the thing, first we're going to have a recorded presentation from Megan Lowry. Your program says that she's at University of Florida, but she recently changed affiliations and went to Pennsylvania, and so she wasn't able to be here in person, and so we'll hear her recorded talk.
Hello, everybody. Thank you for having me. Today, we're going to talk about navigating respiratory challenges in limb-girdle muscular dystrophy. We'll review some of the respiratory effects that happen with the respiratory function, the signs and symptoms of respiratory function when it's compromised, as well as some strategies for monitoring and some management strategies for common complications. So the things that we see in limb-girdle muscular dystrophy are very common to most neuromuscular disorders, and that includes restrictive lung disease, or where the muscle weakness can lead to respiratory failure and the inability to take a big breath. Ultimately, this can lead to something called hypoxia, which is low oxygen, or high carbon dioxide, called hypercapnia. But there are other respiratory complications that include sleep disordered breathing, like sleep apnea, the inability to clear phlegm from the airways that can result in mucus getting stuck in the lungs, or aspiration, so swallowing food down into the lungs because the mouth muscles may be weak, and this can all lead to the potential of respiratory infections. All of these potential complications are in balance with one another. So as weakness grows, cough may become weaker, lung restriction may become worse, the diaphragm can be severely affected, and all of this goes into conjunction with what we would call respiratory failure and ultimately lead to potential symptoms in those who are experiencing ultimately neuromuscular weakness. The most common symptoms tend to be shortness of breath, and it's not uncommon for people to maybe describe panting or rapid shallow breathing. When the muscles become weak, it's limited how much air we can move in or out. Though if we're not as active as typical, then we may not actually be able to describe this as having weakness. One potential thing is that with diaphragm weakness in particular, laying flat can be particularly difficult, and this is called orthopnea. Some things that we tend to forget about asking people about is whether or not their voice is softer, whether speech is more difficult to understand, if they're having to repeat themselves more frequently for those around them. That can indicate that the breath isn't big enough to really project the air through the vocal cords to be essentially louder. We also know that with the respiratory muscle weakness, there can also be weakness in the mouth, so in the oropharynx. And when that area collapses, this can lead to snoring or gasping at night. And this is an indicator of sleep apnea or sleep disordered breathing, which may be an early indicator of respiratory problems in neuromuscular disorders. And that may progress to later include respiratory failure and hypoventilation that can cause low oxygen or high carbon dioxide. So what are some of the things that we look for in clinic? Well, most of you have potentially gone to a clinic and had someone take your oxygen level on your finger, and we look for low levels. Typically less than 88% is considered abnormal. We also look for high carbon dioxide with specific testing on labs called blood gases, and an abnormal level greater than 45 may be indicative that there is some respiratory problems. But a lot of people have no symptoms. And so how do we manage, or what should we be looking out for in those who don't necessarily feel that their breathing is affected? Well, the first part of this is understanding that the severity of involvement of respiratory weakness in limb-girdle muscular dystrophy does vary depending on the type of mutation. So this was a large cohort of people. This encompassed about 784 different people that had different mutations for LGMD. And of those, 36.4% had respiratory involvement. Now, this is very limited because only 58% of these people actually had respiratory assessments. So it really highlights for us that even knowing that we're seeing patients in specialty clinics, we're not always doing the necessary respiratory evaluation to determine truly who may be at risk for respiratory failure. So the range of the severity of respiratory complications was 0%, and this was really seen in the LGMDR12 mutation group. None of those patients had respiratory weakness, and when we looked at some other affected groups, this went up to all 4 of the patients that had an R6 mutation had some respiratory dysfunction, and everything in between. Now, again, this is a limited sample size, and these numbers should not be taken at face value, as each individual person is different and may present differently. But when we looked at this, there have been some other studies, and this is of a smaller cohort, so only 155 patients. We did see a range of what we would call respiratory weakness and restriction, meaning that inability to take a big breath really went from a very severe 14% forced vital capacity to 53%, which is more moderate. But this really indicates that a lot of people may have significantly affected respiratory function. And we did note in this small study that the R1, R2, and R9 mutations tended to have more respiratory dysfunction. Now, interestingly, a lot of physicians, we look for diaphragm dysfunction. So the inability of the diaphragm to move up and down that can limit our ability to breathe. And this was only about 7%. Now, it did increase to 10% over about 8 years. But if you think of inflation going up 3% in a year, that is something to take into account, that it's really not that much of an increase. So how do we assess for this? We use something called a peak cough flow and pulmonary function testing, where we look at a variety of parameters to determine if the respiratory muscles are weak. On the pulmonary function testing, we're really looking for your total lung capacity, the ability to take a big breath in and the ability to blow it out, which is your forced vital capacity. That's an easy parameter to be measured at clinic visits. We look at the mean inspiratory pressure at times, and that gives us another indicator of the ability to take in a breath. And when we're looking to see if someone's cough is strong, we can use either a cough flow, a normal number being greater than 270, or a mean expiratory pressure, where a higher number indicates the ability to actually produce an effective cough. So how often should we have these kinds of testing done? Well, there is no expert consensus, but most of the specialists do recommend having this done about every 6 months. Now, for very stable disease, we may only do it once a year. All of this is dependent on travel time to and from your center, and how often you're being evaluated. If we're seeing decline in the numbers, this is an indicator we maybe should be intervening with some different strategies, which we'll talk about shortly, or that we may need to monitor more frequently. But there are those who pretty much look normal on pulmonary function tests. So we can also look at blood gases, arterial blood gas, to look for carbon dioxide that may indicate we're not taking a big enough breath. We also look at oxygen levels at night, and in some contexts, particularly when those are normal and we're concerned about sleep disordered breathing, potentially someone who is snoring, waking up gasping at night, having awakenings at night for an unclear reason. This is where sleep studies can be helpful. They can detect high carbon dioxide that may only occur at night. It can detect low oxygen that may only occur at night, as well as airway closures that are indicative of sleep disordered breathing. Now, these have to be done in specialized centers and interpreted by physicians who understand that sometimes neuromuscular weakness can have what we call pseudo-central appearance on the sleep studies. And so that is something to consider when you're having this testing done. So what happens over time? We know that with age in general, as well as with time, that our lung function decreases. Now, this is true of anyone with or without a neuromuscular disorder or an underlying lung disease. However, when we take a look at some of the different mutations in limb-girdle muscular dystrophy, one thing that we found with both cough flow as well as the forced vital capacity in the LGMDR12, that actually slightly improved with time and age. Now, this is again a cohort where this may be biased due to limited sampling size, but we do know that the different mutations may negatively impact breathing function to a different degree. So the question is, knowing that, what can we do about it? The age-old saying, if you don't use it, you lose it, does come into context. So one of the things that is very important is conditioning. So how you are using your respiratory muscles. Anyone who is deconditioned, for instance, can notice that they're weaker, a little more short of breath, doing things that they used to do are no longer as easy. And so this becomes an imperative part, in my opinion, as part of an all-encompassing and comprehensive care. Airway clearance is essential for anyone with a neuromuscular disorder. Anytime that we have phlegm that's immobile in the lungs, we have the risk of mucus plugging. So collapsing that airway, this can be painful. It can cause more shortness of breath. And if we cannot relieve the obstruction, it can also lead to pneumonia, which can have the potential to be life-threatening. Now, the next part of this is, what do we do if that oxygen is low at night or the carbon dioxide is high? And this is where we start considering non-invasive or invasive ventilation. So what that essentially means is using a device and positive airway pressure to help improve and inflate those lungs at night, to blow off carbon dioxide that can give us problems, and to ability to oxygenate properly the body. And then, as always, swallow evaluations become part of routine visits. So asking, hey, does it feel like something is going down the wrong pipe? Are there any foods you avoid because we are having some issues swallowing them? Does it feel like you're choking? And swallow evaluations and working with speech therapists can be imperative on preventing aspiration events where food goes down into the lungs. That is not a place that we want it, because it has the potential to cause inflammation, low oxygen, lead to hospitalizations and infection. So muscle training. So there are very few studies in muscle trainers for neuromuscular disorders. And it is true that there is not consensus opinion on this. In my own practice, though, I have seen patients that have committed to doing muscle training or working with physical therapy, and they've been able to more plateau some of the changes or decline I see in their respiratory function on their pulmonary function tests. So for me, clinically, that's very important. In one small study where they combined limb-girdle muscular dystrophy as well as Becker muscular dystrophy persons and tested them with muscle training before and after, we didn't have conclusion on whether there was clear benefit. Now, the problem with these studies is that the muscle weakness and all of the muscular dystrophies may progress over time. And so invariably the outcome may be affected by the disease alone. And so lack of seeing what we would want in terms of a response doesn't mean that it's not helpful. Now, the issue with muscle training is we have to be able to form a seal. We have to have a proper device. You have to be able to lift this to the mouth or have a caregiver or caretaker that's able to help with that portion of it. And over time, if the muscles become too weak, then this can become a modality that is no longer able to be performed. So moving on to airway clearance, and I know Amy is going to talk a little bit about the devices used, but airway clearance is that ability to get phlegm out of the lung and potentially food if it is swallowed in there. This helps prevent the mucus plugging. It's very important if we know that we're aspirating or at an aspiration risk and continue to have a certain diet. But the devices can also help with lung recruitment. So inflating those lungs to help improve shortness of breath or vocalization. Now, typically we look at using specific devices when the cough flow or peak cough flow is less than 270 liters per minute. In general, I recommend for airway clearance for those who need it at least twice daily and more if sick or having a lot of chest congestion. And somewhere between 5 to 15 breaths, it really depends on the person and how adequately they're able to clear their airway. There are different techniques. So there are manual percussive techniques. I generally avoid these. There are some dangers with breaking ribs or causing damage to internal organs that I don't find this to be particularly effective, that it really benefits that potential risk. We have bag valve masks, which are great for breath stacking and lung recruitment, but they're a little less helpful in terms of clearing the airway. We have vest therapy. Now, vests can be very important for airway clearance. However, they're more used to break up thick secretions. They don't actually help produce a cough. And so with that being said, my favorite device for airway clearance is the cough assist. So this is an insufflator exsufflator that pushes air in and then sucks it back out to literally physically move secretions and phlegm and help stimulate cough. And in particular, this helps to recruit lung by inflating different areas of the lung. This can help shortness of breath as well as vocalization. So it really is a multimodal approach. So what happens when airway clearance, and we were doing all of these things, but we're having what we call respiratory failure. So the inability to take a big breath, and we believe that this is negatively impacting sleep or breathing during the day. This is where we consider non-invasive ventilation, and there are several devices that we can use, but to get these devices improved can certainly be a headache. We have to have documentation of the neuromuscular disorder and one of the following: either high carbon dioxide, low oxygen at night for at least 5 minutes during a 2-hour recording where we're below 88%, or specifically for neuromuscular disorders, a MIP less than -60 or more negative than -60, and a forced vital capacity less than 50%. And that's how most patients are being qualified. Now, there are some expert opinions that recently have come out within the last 2 years that have a much lower threshold for having devices approved. That has not currently been uptaken by many of the insurance plans. We hope that there will be a change in the guidelines in the near future. The devices that we use can include a bilevel positive airway pressure. And this is a device that gives a high pressure on the way in and drops it when someone is breathing out. And this may include a backup rate. So if someone is not taking enough breaths, this particular device will kick in and give someone the breath. We have volume assured pressure support, which is basically a fancy BiPAP machine that also allows us to guarantee more of a volume is delivered with each breath. And then we have our most fancy devices, which are home mechanical ventilators that can be given with either a mask or with a tracheostomy. So if we have the availability to do home ventilators, why is everyone not on this? And the reason is that for a long time, home ventilators were very easy to get because you only had to document in the notes the need. And the problem is that they are expensive devices. Now we are having more pushback from insurance companies for these devices. Medical equipment companies are more reimbursed for the devices. And it is true that as weakness progresses, a lot of people may end up requiring or needing this kind of support, and it has the ability to support someone more during the day, which we'll go over. But these aren't indications necessarily to give it. So the BiPAP device that you see on the top part of this screen, it's more portable, it's less heavy, it's easier to travel, and it doesn't alarm at night. You can also put oxygen into that device. Now the ventilator on the bottom can have backup batteries, which is a plus in areas where weather can become a problem, though that isn't an indication to give the ventilator. You can add oxygen. Some of the ventilators can also do monitoring with carbon dioxide. Some medical equipment companies will do that out of pocket because it's not currently reimbursable by insurance. They are very heavy and they're very costly. So ventilators are always rented, never owned, whereas a BiPAP device, after a certain period of time, does become your own personal equipment. So if you are started on non-invasive ventilation, it's important to troubleshoot your device. And where this starts is the mask. So interface matters. For a lot of us, starting with a nasal interface is the most important and typically most comfortable. If we have mouth weakness, the mouth can come open at night, and that's where consideration of a full face mask should be considered. That being said, we have to take into conjunction the ability to be able to remove the mask in an emergency in the middle of the night. And that is a discussion to be had with your provider. Now, the settings that we put on these devices can really range, and it is not a one size fits all. At every assessment for these devices, we should be going over how comfortable is it to wear? How comfortable is the breath? Do you feel like the breath is big enough for you? Is it too small? Is it just right? Are you able to get a breath when you want a breath? Is the breath too fast, too slow, or just right? And does the machine end your breath too soon, too late, or just right? All of these are comfort measures that can be adjusted on the cases with an experienced provider. Now, some of the complications we tend to see or reasons that people may not use non invasive include a lot of leak from their mask. If it's a nasal interface, they may need to cover the chin or use a chin strap. If there's nasal obstruction from allergic or chronic rhinitis, we would want to use that. If we're swallowing air into the lungs, that becomes a very difficult problem and sometimes does result in having to decrease the pressure to unwanted pressures. So, what do we do if we're short of breath during the day? We can always use these devices during the day, but our other options are something called sip and puff or mouthpiece ventilation. So, this is used with a ventilator that can be connected to the back of a wheelchair, and it's used for breath stacking maneuvers where we can give a set volume or a set pressure to take multiple breaths at once to allow vocalization, the lungs to fill with air, and to improve shortness of breath. And this can be very effective for during the day for those who don't want to be constantly on a non invasive mask, allowing them to talk in between, but be more independent. So, when do we consider a tracheostomy? There's no clear consensus on this. In previous times, we used to go to early tracheostomies, and that's a hole in the neck to help us breathe with a ventilator support. Most of us don't recommend this initially unless we've had significant discussions about what this would entail. Trachs have an increased risk of infection, but they can be really helpful for helping to extend life if respiratory failure becomes severe or non invasive ventilation is not an option. But again, we can't guarantee the ability to talk or eat with a trach, and these are discussions that should be had ahead of time. So, when do things become an emergency? So, fevers should always be worked up. If shortness of breath at rest that's sudden or not improving, if lips are turning or skin are turning blue, if there's significantly low oxygen that's not improving, particularly if we're used a cough assist or non invasive ventilation, if there's ever confusion or inability to wake someone up, those can be indicators of low oxygen and high carbon dioxide and do require immediate attention. Some things to consider having a more non urgent appointment with your provider is if a cough is not going away, if you're talking persistently much softer, or people can't understand you, if you're losing weight because you can't get through a meal because you're too short of breath, or you're having choking episodes. And overall, if the shortness of breath is causing you to do less than you want to do or were able to do before. I would encourage you in all of those instances to seek care with your providers about what can be done to optimize your respiratory function. Here are some references if you're interested in further reading. Thank you so much for having me today. It's been a pleasure, and we'll send this back to Brad.
Okay, thank you. So we're running rather late, and we need to move on to the lunchtime session. So Amy, will you stand up? Yeah, so I wanted to introduce Amy Fulford. She had a few slides which we're going to skip over, but she's a respiratory therapist with Millennium. Okay, anyway, she's demonstrating some equipment, used in respiratory management. There's a table out there, out the doors and to the right, and she will be happy to talk to you. Thank you, everybody.
All right. Thank you, Brad. All right, good afternoon, everyone, and welcome to our lunch session. We're getting started a little bit late, but that's okay. My name is Anna. I am from ML Biosolutions. We are actually going to let y'all eat for about 20-30 minutes, and we will get started about 12:30, 12:35. But before we get started, I just really quickly wanted to introduce, what the objectives of our panel are. It'll be a roundtable panel discussion with 3 speakers, Kelly Brazo, Conrad Chris Weil, and Doug Sproul. Maybe I'll introduce them a little later, actually, before we get started. But for now, for the next 20 minutes, please enjoy your lunch. We'll be back. We're going to reconfigure the stage.
and then we'll get started. And when we do get started, we'd appreciate if everyone kept their conversations down. It'd be great if you could talk now. And we'll see you in about 20 minutes. Thank you so much. All right, can everyone hear me?
I wanted like an 18-month,
Yes,
24-month study. I think
All right, thank you
been a
guys
little-
so much.
yeah, 24 months
I
to
am
think through.
going to introduce our panel. Hopefully you guys had started your lunch. It would be really appreciated if we could keep the conversations down and give our panelists who are here a chance to share their thoughts. So my name is Anna Talaga. I am Director of Medical Affairs at ML Bio, and we have our esteemed panel here. We have Kelly Brazo, which I think everyone already knows Kelly. She needs no introduction. She's the co-founder, the co-founder of Cure LGMD2I, which was actually the first patient advocacy organization for 2I-R9 specifically. We have Dr. Conrad Chris Weil, who is a neuromuscular physician scientist with a special interest in neuromuscular diseases, and he's at Washington University in St. Louis. And then we have Dr. Doug Sproul, who is the Chief Medical Officer of ML Biosolutions, and I know everyone heard from him earlier today, so he was already introduced. But thank you for our panelists for being here, and I guess we can get started. So the first question is for Kelly. What are your thoughts on being here this weekend as a parent and as an advocate?
Yes, so can you hear me?
Yeah,
so I'm so glad to be here, and it's so amazing to see so many people in the audience that are here together today. Over this weekend, I think we all can agree that being together as a community, to be here to support each other, to build each other up, and to share our stories of success, our stories of hope, and more importantly, some of the heavy news that we have gotten over the past couple days. I think the timing couldn't be better that we are together to be together as a community and learn how to advocate together to take over the next steps. I think all of us in the room that are affected by LGMD, whether you know it or not, you were born to be an advocate. You were born to advocate when people have asked you, why are you using a wheelchair if you can still walk? You've had to advocate for explaining that why, and you shouldn't have to advocate for that. But, or when someone says, oh, my aunt has MS too, I totally understand what you have, right? We've all heard that before. So whether you like it or not, you're gonna be an advocate, and we encourage you to continue to do so. And you can learn so much by being with our community, and we encourage you to support each other and stand up together as a community. And I think it's a great time to do that.
We can. Hey everyone, can we just ask you to keep the conversations at a minimum so that everybody can hear the panels? Thank you.
Hello? All right, thank you. Dr. Weil, why is clinical research in all the LGMDs more important now than ever?
That's a great question, and I think when we think of clinical research, we think of it from many different angles and many different buckets. And so having someone come in clinic and allowing me to examine them and enter them into a natural history study, that's a form of clinical research, and that's something that benefits not just the patient, but benefits the whole community. Being involved in a clinical trial, that's another form of clinical research that may or may not have benefit for the patient depending on the design of the trial, but it's building an infrastructure so that we can start to develop more and more therapies. I think as Kelly said, we're learning that maybe there needs to be multiple different strategies and therapies, and so by creating infrastructures, and these infrastructures, we call them sometimes clinical trial readiness programs, where we're able to identify patients, so I need to know where the patients are, meaning I realize I'm saying this to an audience that's here, but whenever I'm in clinic, I need to have patients come and see me in clinic so that I can offer them research opportunities. These research opportunities may be just to see how a patient progresses over time. That's something called natural history. It may be collecting biosamples so that I can start to build what we call a biobank so that we can have biomarkers so that we can understand how the disease might be different amongst different people or how it also progresses. And then it also allows us to start to answer more fundamental questions. And these fundamental questions are, why is your disease different than another disease? Why did somebody start having weakness whereas somebody else is still remaining ambulating at a certain time? And these are questions that I can then bring back and ask students in my lab to start to explore and think about. And so just by having patients engaging in our clinics and engaging in research, it allows building of all of those questions that will ultimately not just serve single diseases, but perhaps many different muscle diseases.
And then the next question is for Dr. Sproul. We heard a lot today and this morning about LGMD2IR9, but obviously there's a lot more diversity here in this room than just LGMD2IR9. Why should folks with other forms of LGMDs care about our program for LGMD2IR9?
Yeah, I think
You're...
can't even hear myself. I think that the, in one sense, having, I don't know. All right, in one sense, having, sitting here in the audience, if you have some other form of limb-girdle muscular dystrophy and you're listening to multiple speakers talk about LGMD2I, a reasonable reaction to that is why, how does this impact me? Why do I care? Right? We obviously want we want there to be development of therapies and cures for everybody. And I'm very happy for these other patients who may have a therapy that's in development for their form of disease, but how does that affect me? And that's a really tough question, right? And you're sitting here in the room seeing therapies that are specific for this disease or specific for that disease. But the reality is that any successes that occur, build the community. And they build the community in important and practical ways. As a company that is, as an investigator developing a potential therapy in a lab, who's then working with folks trying to come up with a way to develop this therapy and ultimately bring it to patients affected by your disease, it's immensely helpful and critical that you are able to identify markers that can help you identify a signal, that you are able to identify and understand who the experts are in a disease, where the patients are, how many of them there are, but also to understand the pathway that you need to achieve. And seeing other programs move forward in a space, in a disease area, creates a pathway. It smooths the road so that a company that is trying to develop a therapy for a different form of limb-girdle muscular dystrophy knows what they need to do, how they need to do it, how they can approach the agencies, what are the things that they need to see in order to ensure that this product is safe and efficacious. And so every success that is seen in this disease area writ broadly, in the limb-girdle muscular dystrophy space in general, begets and accelerates the next success that comes down the line. And so it's all part of the same, and so we can celebrate small successes as a community, individual successes, knowing that it builds the broader community as well.
I just want to echo what Doug just said, and Doug emphasized the successes, but I think it's also important that we talk about even whenever there's a failure, we learn so much from the failures. And so those are times where companies will contact me as a researcher and ask me questions, and I'll be able to say, well, I think that this company did this right, and this company didn't do this right. And so it's building this learning experience. And so in addition to successes, even if a study doesn't meet its final endpoint, we have learned so much from that. And one thing we've also learned is we've learned that we can bring the community together. And that's really the very first step, is identifying and bringing patients together.
Thank you guys for that. The next question is really for Kelly. I've heard a lot of folks talking about being an expert in your disease or owning your disease. What does that mean, and why is it so critical?
Yeah, and to piggyback off what Dr. Weil said, the best way to be an expert in your disease is, one, come to conferences like this, because we are surrounded by the best clinical and scientific experts that we could ever ask for. So kudos to all of you that could make it, and for you that are listening online, you can't be surrounded by more educated people that can help us learn about our disease and become experts in our own path. I think the other thing too is, getting to clinic if you can. Find an MDA clinic or, someone with a expertise in neuromuscular understanding, so that you can learn more, and make sure that you are following along all of the standards of care guidelines that have been developed and that we're still working on actively in multiple subtypes for the limb-girdles. We heard a little bit in the Lunch and Learn yesterday about the standards of care that TreatNetMD is working on for us. And so just keep educating yourself, keep learning. And the other thing you can find out about is by going to your clinics. You'll know when there is a clinical trial that opens up for your subtype and whatever that may be. And whether it's a natural history study, a clinical trial, all those things are going to be so important, because numbers matter. And if you're not going to the clinic, you're not going to be counted as someone who could be eligible for a certain clinical trial. So I think that's really important. Just make sure you take these guides and tools with you if you're in the emergency room for any reason, or if you have a surgery coming up. Your local general hospital most likely won't know anything about limb-girdle. Chances are. It is so ultra-rare and it's so specialized. And unfortunately, many of the people in this room can only be in so many clinical settings. So the more you can learn to take those tools with you, the better and more safety you will have when you have any sort of procedures being done.
Dr. Weil, why should patients come to the clinic? How is that clinic experience evolving? And why is it important, especially right now, to come to the clinic?
Yeah, that's a great question. I get asked from patients all the time. Why should I come? You don't do anything for me. All you do is tell me that I'm getting weaker. And I understand that. I do. I want to quickly, though, echo what Kelly said, which is advocating. And I know that a doctor might not know you might see a community doctor who might not know your disease, or you're going to hear me say, please bring your genetic test result, and I'm putting it on you to do it. And I understand that that's an extra burden that I'm asking you to do. And just hearing Kelly say how you're advocating for yourself every day just because of who you are, I understand that extra burden that I'm asking. But it's important that we do that so that we can provide the best care. And so I'm not saying I shouldn't be a better doctor. I'm just saying, how can I help you advocate for yourself in a way that I can then be a better doctor? And that means coming to clinic. And why do I want you to come to clinic? I know that getting to St. Louis, WashU, parking is terrible. I know that there might not be an elevator that's working. Like, I understand all of that. And so, but I'm asking you to come so that I can understand your disease better, so that I can train the next generation of physician scientists who need to see the diseases that are so rare. In addition, whenever a company contacts me and says, do you have any patients with LGMD R87? I can say, yes, I have them. And the next question the company will ask is, how many have you seen in the last year? And then the next question they'll ask is, how many of them are ambulatory? How many of them are non-ambulatory? And if I haven't seen you in the last year, I can't answer all of those questions. And then the company's going to say, I don't think your site has it together, and we're going to go to some other site. And so that's just the honest truth about how it works. And so coming back to clinic and being engaged in clinic is a burden. I understand that. But it's important so that we can offer not only the best care, but that we can advance research and accelerate it. I didn't even bring up the importance of the care that we can offer, but those are other aspects too.
Well, what is the difference between clinical care and clinical research? Can you explain that?
Yeah, so the difference between clinical care and clinical research, so all of the MDA sites and physicians will provide you with clinical care. That's actually the first and foremost. If you were to ask me what's the most important thing I need to do, it's offer clinical care. It's being able to answer your questions and engage in a relationship that I can help you understand your disease, understand the trajectory of disease, anticipate when things are happening, offer support through other ancillary staff. That's what clinical care is. Clinical research is really a selfless gift that you are giving to us by being involved in a clinical study so that I can help educate myself, my research team, others in the community. And the clinical research doesn't necessarily stop you from getting clinical care. And I want everyone to understand that. You will get clinical care no matter what, even if you're not associated with a clinical research study. A clinical research study is something that helps us kind of move the steps forward.
Awesome. And what does it actually mean to have a genetic diagnosis, and why is it important to actually have that genetic diagnosis, like the paper on you all the time?
Yeah. So we've learned, I think, a lot, and I think many of you have heard about the different genetic subtypes of disorders. So one reason to have a genetic test result is because many patients will say, I have limb-girdle muscular dystrophy. And we've learned now that there is a much more specific way to starting to understand that. And so not only do I need to know that you have limb-girdle muscular dystrophy, but I'd like to know that you have limb-girdle muscular dystrophy type R9 or R2. However, the world is becoming even more complicated because I want to actually know the genetic mutation you have. And the reason is as we start to develop therapies, they're going to be focused on the genetic mutation that you have. And so I'm going to say this, the same questions of how many patients do you have in clinic? How many patients do you have that are ambulatory? How many patients do you have in the last year? The next question is, how many patients do you have that are homozygous for this mutation? And so I need to know that. You guys have seen medical records that are electronic, and they are complicated, and they are not easy to sift through. There is no special tab that says genetics on it. And so I need patients to bring their genetic tests with them. You can ask any physician, if you had your genetic test done, ask them for a copy of it. If they don't give it to you, say, Dr. Weil said I could have a copy of it. You need to get a copy of it. It needs to be your new Social Security number. It goes in your lockbox at home and have it, because it's implications not just for you, but for your family as well. And so I just really want to bring that up.
So you're saying that we should laminate the genetic test results and...
That would be great, yeah, yeah.
Okay, Kelly, the next question is for you. What does standard of care mean, and how does it impact how the community or individuals actually think about their care?
Yeah, so with standards of care, I think that, just to, add on to what Dr. Weil was saying is knowing your subtype is so important. It's crucially important because the different subtypes, although we are all limb-girdle muscular dystrophy, we're all here for the same reason. Each subtype has significant nuances. Some of them may have cardiac complications. Some may have respiratory complications. Some may have very different standards of care. So when you go to the clinic, depending on what your subtype is, you're going to have very different recommendations for assessments each year to assess whether you have cardiac, extensive damage over the years and things like that. So yes, knowing your subtype matters, but also making sure that when you do go to the clinic, as we talked about earlier, not all clinics are equipped with neuromuscular specialists that really understands the nuances of all these different subtypes. So making sure you're taking the standards of care guidelines with you if you have them for your subtype, or the family guide that we talked about yesterday, bring that to the clinic with you so you can educate your providers so that they are aware of what nuances your subtype might have.
Real quick, I just want to ask again if we could keep conversations in the room to a minimum. It gets quiet and then it starts to go back up. If we could just keep it quiet, they only have a few more minutes. I understand you have a lot to say to each other, and networking is great, but let's give them the attention they deserve. Thank you very much.
Thank you. Actually, this next piece of information is really relevant for everyone in the room. There are free and complimentary genetic testing programs. So please go to your neuromuscular specialist, and if they don't know that there's a free program for genetic testing, let them know there is. It's through the Lantern Project, and the other one is Invitae. So the Lantern Project and Invitae, those are the two complimentary, which means free genetic testing programs, and you will be able to determine your specific limb-girdle subtype.
And I would also, just to add to that, is also many people in this room have been misdiagnosed over the years, right? So years ago, before your specific subtype was identified, you might have been told you had a very different condition than limb-girdle related. So I encourage you, if you haven't had that done, it's not too late. You can have it, tested again now that more genes have been identified.
That's another great reason to come back to clinic. I tell every patient I reserve the right to change your diagnosis every time I see you, because I learn new things every year. I learn new tests. I understand diseases more frequently. And so that's really important to come back to clinic, not just to hear about new treatments, but so that we can revisit your diagnosis. And I know every time I see a patient in clinic, I start from the beginning, and they look at me like, you should already know this, but no, I am rethinking your diagnosis every single time.
And one last thing is, please make sure, if you haven't, that you see a genetic counselor. This is a quick plug to genetic counselors. They are invaluable resources to help you understand what your diagnosis means, what those genetic mutations mean, and whether you have heterozygous or homozygous. There's many people I talked to this weekend who don't know. They have their subtype, but they don't know which type of mutation within that subtype. So there are a lot of details that you can learn, and if Colleen Campbell were in the room, she'd be proud of me for saying that.
Okay, well, I have one more question, and then I'll let all of our panelists kind of say their final thoughts. But my last question is about ICD-10 codes, which is something I'm sure a lot of you heard about. What is an ICD-10 code, and why did Cure LGMD2I Foundation and other patient advocacy organizations petition to get specific ICD-10 code for limb-girdle 2I-R9, and why is that important?
Well, I have to give a shout out to our entire LGMD coalition. I would say going for an ICD-10 code was actually one of the first major projects that we all worked on and came together, from the Speak Foundation to LGMD Awareness Foundation to the 2D Foundation. I could go on all day, Cure Coalition, Cure Campaign, you name it. We all came together and we said we can no longer be known as muscular dystrophy unspecified. We deserve more than that. So about 4 years ago, a group of multiple advocacy orgs came together and we petitioned, including with the help of MDA. We were able to get several ICD-10 codes for several of the LGMD subtypes. 2I was not included at the time, so we just in the last year went back again and we revisited for 2I-R9 specifically, and we were successful, so we are celebrating that. It will be in effect in October. But why is that important was the ultimate question. So really, they are basically the gateway to your healthcare. Without an ICD-10 code, you aren't going to be counted. When we talked about the numbers, if a drug company wants to study a certain indication, they're going to look as how many patients are identified for this condition, and is it worth it? Is it worth the return on the investment? And so if we don't have that identification code, it's harder to find out how many patients there are. Also, when a drug is finally approved for one of our conditions, we want it to be covered by our insurance provider. And when you have an ICD-10 code, that there is more likely that they can justify reimbursement for the coverage of that drug. So I'll let the other experts on this panel elaborate on that. But
I think you're spot on. I think knowing the prevalence through the healthcare system is important to know. I would say the other reason we do ICD-10 codes has to do with the care that goes and is associated with your disease. So getting durable medical equipment, ensuring that you get a cardiologist appointment, all of that is then linked with that ICD-10 code, which then says, oh, this muscular dystrophy can have cardiac implications, and the reason I'm prescribing this. And so it ends up having this whole kind of cascade of differentiating each of the limb girdles.
Wow, everyone just quieted down. So we are going to conclude, and I just really wanted to thank our panelists and thank you as members of the community for listening. Our panelists are going to be available for Q&A afterwards, so please feel free to come up. But if we could give a round of applause to everyone, and thank you guys for being here.
That was really good. So we were scheduled to have a break right now from 12:50 to 1, but we are going to, I believe, move right ahead into our LGMD advocacy opportunities. So if I could invite Catherine Bryant and Annie Kenny to the stage. And while they're coming up, in the interest of time, we can go ahead and get started. We do have a pre-recorded session from none other, oh, thank you. I'm just jumping right into it. Thanks, guys. From Amy Comstock-Rick. She is the CDER's Associate Director for the Rare Disease Strategy and the Director of Strategic Coalitions for FDA's Rare Disease Innovation Hub. And she has a pre-recorded video that was interviewed with Catherine Bryant-Knudsen, Speak Foundation, Brad Williams from the Jane Foundation, and Carol Abraham from LGMD Awareness Foundation. So if I could call your attention to the screens, that will be playing here shortly. Thank you so much.
Hi, everyone. Thank you for being here to our session. And I'm excited that we have here Amy Comstock-Rick. She is CDER's Associate Director for Rare Disease Strategy and the Director of Strategic Coalitions for FDA's Rare Disease Innovation Hub. Amy, thank you for being with us today. Would you be willing to just share a little bit more about this position and how long you've served in it?
Sure. Thank you, Kat, and thank you so much for having me here today. I am sorry that I have to join you virtually, but I'm glad that I'm able to join you in that way. I appreciate being here. I joined at the FDA in November of 2024, specifically to direct the new Rare Disease Innovation Hub at the FDA. Just a quick sense of my background. I am a lawyer by training. I had many years in the government and then did a little bit of a subject matter switch, and about 25 years ago went into health policy and really had primarily from a patient advocate perspective. I was the CEO of a Parkinson's disease patient advocacy and health policy organization. And then for 8 years, the CEO of an educational organization that focused on FDA issues. So I come from a very nonprofit and again, patient advocacy perspective. When the FDA announced the hub, which I know we'll talk about in more detail clearly, in July of 2024 and announced the vacancy for the director, I just felt like it just melded so well with my background of strong interest in policy from a really multi-stakeholder perspective, with the goal, my personal goals of how can we more efficiently, time is such an important commodity, particularly for the rare disease community. What can we do to do what we do better, faster, and advance more treatments? And so I was so excited to raise my hand for this position, and I was excited the hub was launched, and I was very excited to join in November.
Thank you.
Can you explain
what exactly is the Rare Disease Innovation Hub and what motivated its creation?
Sure, Carol, thank you. Of course, I wasn't here, but I've certainly talked a lot about what motivated its creation. As many of you may know, in the last number of years, drug approvals, and when I say drug, I mean drugs and biologics at FDA, about half of them have been for rare diseases in the last number of years. Also, FDA, with the incredible innovation scientifically, FDA has launched a number of rare disease programs, primarily since 2019. A lot of activity in the rare disease space. And has been building interest amongst the rare disease community, or I should say within the rare disease community, for a home for rare disease. And there was really a push to have a centralized place for communication that was separate from individual product reviews and separate from the patient-focused drug development or listening sessions, which again tend to be very disease specific. So the FDA, which in particular the two centers, the Biologics Center, CBER, and the Drug Center, CDER, jointly launched and announced and launched the hub in July of last year. The first actual activity of the hub was in October of last year with a public meeting to hear ideas from the community. That's one of the strong values of the hub, is to hear from the community how it should, what their concerns are. And then I joined in November. So the mission of the hub is to ultimately advance more treatments for rare diseases, particularly the diseases of smaller populations and subpopulations, as subcategories, if you will, of that ultimate goal that we all share. Is what can we do as a community to communicate with FDA better on some scientific innovation opportunities, some potential challenges within the scientific questions. Also, strong interest in the hub of CDER and CBER enhancing what they do together. Anyone who has spent time over the years working with FDA knows that the three medical product centers certainly communicate with each other and work together, but they are separate centers, and strong push with some of the unique challenges in rare disease therapy development for particularly CBER and CDER to ensure they are coordinating and are consistent as much as is possible and needed. So that's a serious goal. Kat, you gave my title as Associate Director for CDER, which I am. Everybody needs a home for HR purposes and administrative purposes, but I really view myself as within both centers because I deal directly, my supervisors, if you will, are the center director for both CDER and CBER, and I take that very seriously, that it is a joint center effort.
Thank you.
So the next question is that your job title includes the phrase strategic coalitions, and I'm wondering if you could give a little bit more color as to what that means, both within FDA and, also externally, and then maybe get a little more general about, how the role of collaboration between stakeholders in facilitating drug development for rare diseases.
Sure. So, and thank you for that question. You're absolutely right that strategic is very intentional in my title. The mission for the hub, and I know Kat mentioned the strategic agenda for 2025. The mission of the hub is read literally quite broad. And so one of the first things that I focused on was be strategic. And we got to work and created the 2025 strategic agenda. Actually, Kat, we don't call it a strategic plan, and I'll tell you why we chose the word agenda specifically, because it was the first year of a new program, and we needed to ensure that in its first year, we had enough activities where the hub would make a difference, have activities that are visible and people would know that the hub is grounded, but not be so broad that we kind of can't get anything done. And a strategic plan tends to be more lofty with a 2, 3, 5-year vision. And we just thought we weren't quite ready to do that. So we very intentionally called it strategic agenda. The strategic part of it is very much to focus on what specifically can we do to help advance therapies, to work internally on communication between CDER and CBER, so to be very strategic about where we put our energy. When we published the strategic agenda, when it was released on January 15th of this year, those of you who look at it will see it has 3 goals. One is focusing on the scientific challenges and advancing therapies. In the communication we received about launching of the hub, there was a lot of interest in FDA hosting, facilitating, if you will, or hosting, I guess, scientific conversations about challenges in rare disease therapy development, particularly in the smaller populations. So we announced the RISE workshops, research, innovation, science, and exploration. We're having 2 in 2025. The first one is September 3rd on control options in clinical trials, in trials for very small populations. And it covers internal controls as well as external controls. And we're covering all the control options except placebo in that workshop. And the second workshop will be later in the year. Topic is TBD. And the reason for that is we are looking to the rare disease community to tell us what we need scientific workshops on. So we opened in the Federal Register a public docket on June 13th, seeking proposals on topics for that second RISE workshop, which will occur in November of this year. So I encourage you, I encourage anyone listening, but companies, disease organizations, patient advocates, think about common issues. It doesn't have to cover all rare diseases, but we're looking for workshops that will benefit more than one product or presumably one disease state. So classes of diseases, or as our first RISE workshop shows, we're discussing internal and external arm options, but disease agnostic. Some of the case studies obviously will be specific. So we're looking for topics where it could be beneficial to many, not all probably, pipelines and disease states in the rare disease community. So that's the first goal. The second goal was very internal to FDA, to enhance the communication and the consistency between CDER and CBER. And that's an area, as I said, where there's already cross-fertilization, but we need to regularize it, which is the term we're using, that reviewers in a similar disease state or have worked with similar trial designs, for example, or endpoints, are really communicating with each other to make sure they're being consistent, absolutely, but also really learning from each other. And FDA's institutional knowledge is continually growing in particular disease states. Just quickly, the third goal in this year's strategic agenda covers educational materials. FDA has 18, believe it or not, 18 rare disease programs, and that's a wealth of riches. But we're at a point with so much going on in rare disease that we need more of a roadmap for these various programs. If you all have a question about where do I go in FDA for such and such, that the hub is intended to be that guidepost. The third goal has been delayed a little bit. I think we'll probably talk about some of the challenges and opportunities that FDA has seen with the new administration, new secretary, new commissioner. But we're looking forward to that goal 3 being able to get to that pretty soon. So those are the goals, if that answers your question, Brad. Long answer.
So one follow-up is I think I recall seeing in the planning document that the intention was to do a revision of that in 2026.
Yeah.
Is that?
That's still the plan, that it was a 1-year document. So we will, we haven't started working on it yet, although I guess come next Tuesday. Oh, sorry. This is being shown later. Forgive me, everyone. But July 1 is just around the corner, which is halfway through the year. We haven't started working on it yet because we want to build on what we learned in 2025. But the plan is to do a new strategic agenda for 2026.
Amy, it sounds like there's a lot of opportunities for patient input. You mentioned the RISE, which I saw. That was published June 13th, and I think our Limb-Girdle community plans to submit some public comments there. What other roles can patients and advocacy groups play in shaping the Hub's priorities and initiatives? What can we do, and what input would you be looking for from us?
So meetings like this is really a strong way. I am out a lot talking to all members of the rare disease community. Before our conversation today, I was meeting with a company that focuses almost exclusively on therapies for rare disease. The Hub wants to hear not just from patient advocates, but definitely patient advocates, but the whole rare disease community on feedback on FDA and how our policies can be, make sure that they're being as efficient and as responsive and embracing of scientific innovation as possible. So the Hub is quite accessible. We have a website and an email address, and I'm also pretty accessible. So it's amy.rick@fda.hhs.gov. And you can reach out with your ideas, with your questions. And then as we move through 2025 and into 2026, I anticipate there'll be more formal opportunities as well, in addition to seeking proposals for RISE workshops, where we are seeking input from the rare disease community on various aspects of FDA's engagement with the rare disease community and our policies and their impact.
Thank you.
Can you share a little bit about what some of the innovations in trial design to address the challenges of small patient communities, such as the Limb-Girdle community?
So just to be clear, I am not a scientist, and this is a great point for me to emphasize that the Hub does not get involved in individual product or therapy development issues. That's such an important aspect of the Hub. It surprises people sometimes a little bit, I think. But the benefit is that the Hub can interact with your organizations as well as any of the companies that may have products in front of FDA. The Hub can still interact, meet with those companies, learn from them, get their opinions on policy and process issues, completely separate from a product review. So there's never a question about whether we should have had that conversation if something is being reviewed by FDA right now. But certainly, there's a lot of guidances that FDA has, to your question, Carol, on rare disease specifically. FDA has been, CDER and CBER, been very clear and very public about understanding the unique challenges of very small populations, so that the what's often referred to as the gold standard for 2 randomized controlled trials is in many disease states or subpopulations of rare disease states just not feasible in certain cases. And so working with those communities to make sure that natural history studies and registries and control options such as crossover trials or self-controls, various real-world data can be taken into account, non-clinical data taken into account, so that we get as much as is possible. The FDA and reviewing a particular therapy and working on trial design is really dealing with the whole picture as much as possible, understanding the reality of a particular disease. And I'd like to think this is my phrase, but in terms of the challenges, Carol, of a small population, just failure should not be an option. You keep working with what we have to make sure that we can pursue therapies for that smaller population.
Thank you.
So then just to go back a little bit, that's actually going to be one of your workshops that's going to be held later this year. Okay.
September 3rd, allow me to do a little plug. September 3rd, it is being facilitated by Duke Margolis. It's a hybrid workshop, so if you're in DC, you can come to the National Press Club for it, but it will be offered virtually. Registration is already open on the Duke Margolis website. I'm assuming it's on the website. I better check that. And it's on control options for in-trial design for small and diminishing populations. And by diminishing, what is meant is, for example, when you have a disease state that's already had a number of clinical trials, that may affect eligibility criteria for participation in future trials. Or if you have multiple trials going simultaneously, but participating in one may make the pool smaller of those who can participate in another trial. So different creative ways of dealing with the challenge of small and ever smaller populations. It looks to be an excellent program. We have our speakers are all locked in, and we have good representation from FDA, from industry, and from patient organizations. So I'm really excited about it.
Well, gosh, we wish we had longer to talk to you. This has been such a wonderful conversation, and thank you so much for joining us. And well, what is the best way for people to reach out to you?
Very accessible. Email is the best, and through your organizations or independently. And I love to hear from people. So, and thank you for having me. The work you all do is so important, and I thank you for that and encourage you to engage with the hub as much as helps you.
Okay.
Thank you, Amy. Thank you so much, and we appreciate your time. And it's just wonderful to have the ability to sit down and talk with you. So thank you very much.
Thank you.
Is this on? Yeah. Thank you for that great conversation, Kat, Brad, Carol, and of course, Amy from the FDA for taking the time to record that video. So I know they could have talked for a long time on a lot more topics. But next up, we have Annie Kennedy, who's the Chief of Policy, Advocacy, and Patient Engagement from Every Life Foundation. She is one of my advocacy heroes, I have to say. She's fearless, she's relentless, and a passionate leader for our entire rare disease community. So to have her here with our LGMD family is really special to me. And I'm excited to hear what she has to say and opportunities for laying out the upcoming LGMD advocacy lessons from the rare disease community.
Thank you so much. It's an honor to be here with all of you in general, but especially this weekend. I was texting a little bit with Kelly before I came here, and I think these are the moments when communities pull together and make sure that you send a signal, not just internally to yourselves, but to the world, that momentum will not slow down, that this is a community that does not have time to take our foot off the accelerator, but that when there is unmet need, this is the time when we need to make sure that we are keeping momentum strong. And so I'm going to talk a little bit about how we do that at the Every Life Foundation from a macro perspective, and then work with communities like yours so that you can really dig in from a micro perspective to be doing that work. So I'm really thrilled to be here with you today. So the Every Life Foundation, this is an image of us being on Capitol Hill. This was 2 years ago. Maybe it was this year. I'm not sure. I think the zebras were from this year. We are a policy, advocacy, and patient engagement organization, and there are opportunities, if you are not already familiar with us, for you to be engaged on all of those levels. As far as advocacy, we have a lot of really wonderful programs to engage individual advocates, and our goal around advocacy is simple: to make connections to your elected officials accessible to you, whether that's on the state or federal level. We have grants for individual organizations to make that possible. We have training materials. We host 3 opportunities throughout the year, one in Washington, one in district, which will actually be this summer from August 4th through 11th, and one for young people and teens specifically, and then we do state events throughout the year. And these are broad across the rare disease community. So the topics that we select are those that are selected by the community to prioritize to really raise our voices collectively. Policy, we're an evidence-based policy organization, and we focus on 3 distinct policy areas: diagnostics and newborn screening, public policy, so that's legislation, public health policy, regulatory policy, and access and value to approved therapies. And we do this through a coalition approach, working with patient advocacy organizations, biopharmaceutical partners, academic organizations, payers, and other relevant stakeholders in the policy space. So we have lots of resources available to you to help sort of break down what information you need to know as an individual living with a rare disease or somebody working within this ecosystem. So all of that's on our website, and all information at the end as to how to find all of that, as well as if, you know, we sort of function in this, what we like to call the alphabet soup in Washington. There are lots of acronyms that we use all of the time. We have legislative glossaries. We have primers around what types of legislative topics are happening each season, what you need to know, what's the difference between a reconciliation bill and the appropriations process. All of that's on our website. So if you're even hearing topics being talked about in Washington, you can go to our website and see if we've put out an information tool just to help you break down what's happening and why it matters specific to our rare disease community. So let's talk about who we are, why we're here in this space, why the work that everyone in this room is doing matters so much. And we're a part of an ecosystem. We're a part of a lot of ecosystems, but in rare disease, we're a part of a distinct ecosystem with lots of players and lots of partners. And I've been really struck over the last couple of days as each of the presenters has been speaking and has acknowledged all of the organizations and partners that have made each of the programs possible. And that without the family foundations, without the organizations, without those that have funded the animal models and the natural history studies, and even made strategic investments in those programs, none of the presenters who would have been up here this morning talking about the pipelines would have been able to be up here on this stage. So key to this ecosystem, central to this ecosystem, is the patient community. But on top of the complexity of this ecosystem is the urgency of rare disease. And that makes who we are in this ecosystem so important. So here are just some facts and stats about rare disease. And you may know some of this, but this is data that we've worked to really move from those back of the envelope estimates of who we are to have some real data. So policymakers have this data when they're making decisions about funding priorities, healthcare spend.
Rare diseases include more than 10,000 diseases, and that number actually goes up almost daily. We estimate that there are about 30 million Americans living with rare diseases. That's 10% of the US population. But we just had a conversation earlier about ICD codes, which are that hashtag that follows you through the healthcare system. We know we have under 900 ICD codes in rare disease, meaning we know that that's a gross underestimate, that if we could count people better living with rare diseases, that number would go up. So these are conservative estimates when we use these numbers. In 2020, we published a study of the national economic burden of living with a rare disease. How much does it cost to live with a rare disease? So we looked at 1 year of data, and we showed that it costs close to $1 trillion in 1 year for 379 rare diseases, close to $1 trillion. Now, that surpassed the cost of living with diabetes in the US, surpassed the cost of living with heart disease. And why that's so important is because the federal spend on rare diseases is budget dust. And so that's why data like that is really important to us. But what was also important with that data is we were able to dig down into what those cost shares were. And what we showed, and this will not surprise anyone in this room, is that only about 40% of those costs were what are considered direct costs, like what you see on your health care bills, what you spend at the doctor's office. 60% of those costs are costs being shouldered directly by families and society, the out-of-pocket costs associated with living with your diagnosis and your condition, which means we have a lot of work to do to make sure that when you receive a diagnosis, the lion's share of the cost of living with your diagnosis doesn't come out of your pocket. So those are the types of things that we are doing at the Every Life Foundation to help shift the policy conversation and working with our community to do that. We've done studies on what are the avoidable costs in the diagnostic odyssey, and then how do we do better to eliminate that diagnostic odyssey, and some of that data is there. We know that more than 50% of people living with rare diseases have pediatric onset rare diseases. We know that fewer than 5% of rare diseases have an approved diagnosis. And of those, they're not cures. So we have a lot of work to do. So those are the underpinnings of the urgency with which we work. We also believe that there's a moral imperative that we must work to accelerate therapeutic development and discovery for our rare disease community. And that's the urgency with which we work in our community. But we know that there's a challenge, that FDA has a public health mandate to ensure safety and efficacy, and we work within that regulatory rigor. So we sort of are at this impasse where we want safe and effective drugs, but we know that there are some different thresholds that we think about when we think about risk tolerance in rare disease. We also know that there's what's called the cure to care continuum. And so we've heard about this. Dr. Hester really talked about how much it costs to create a therapy. And so I just want you to look at this and look at sort of where that idea, that scientific idea starts. And again, we've had a lot of presentations in the last couple of days around the concepts and the ideas, and as they're moving through into clinical trials, the clinical trials is over there on the left, that phase 1, 2, 3, and where we get to FDA approval. And as communities, we often are very fixated on the FDA approval. We spend a lot of time thinking about approval. But what we have to remember is the goal is really to get that therapy into us. We need that therapy to get into our child, into ourselves. So there's a lot of evidence that we have to develop to make sure that there's going to actually be a reimbursement mechanism that's going to get paid for. And that's all that work on the right-hand side. But that data is being collected at the same time that we're doing all that work on the left-hand side. And oftentimes, what we are seeing play out right now is that you get caught sort of in this cycle on the left-hand side. You have really promising therapies that are in clinical trials, and you're sort of get stuck in this churn where not everything succeeds. And in rare disease, while that cure continuum exists for all disease spaces, in rare, it's even more complicated. And in ultra rare, It's intensely complicated. And so the onus on us as communities becomes even greater that we do some work. And we do some work to reduce that cycle. And so I'm going to talk about how we do that. And everyone in this room knows that time is a commodity. So here's what we do. As patient communities, we have created an environment where we are developing innovative approaches that are within regulatory statutes and boundaries. We are updating and oftentimes writing guidances with federal regulators that are reflecting learnings in real times of what's happening within clinical trials. And we're convening those as the patient communities because we can do that across trial pipelines. We are changing legislation and regulations. And I'm going to talk a little bit about how we're doing that. But there have been many laws that have been written and passed and led by our communities. And one of the things we've done is we, Every Life, helped convene the Congressional Rare Disease Caucus, members of Congress who have raised their hands to say, we care about rare disease. And we now work with that Congressional Caucus almost daily to ensure that they understand the priorities of the rare disease community. We convene caucus briefings throughout the year. When you guys come to the Hill, you meet with that caucus leadership to make sure that they are representing our priorities. That's incredibly important as we think about moving the needle and making sure that the incentives for therapeutic development are there. And I can't see the bottom of my slides, so I'm going to stand on my tippy toes. And then most importantly, making sure that the rare disease community voice is the center of all decision making. So this shift of the paradigm is what we call patient-focused drug development. So in a nutshell, creating rare disease therapeutic incentives, de-risking investment, so building those animal models, ensuring that there are natural history studies, creating a regulatory paradigm that ensures that there is benefit-risk data available, that there are patient preferences that are meaningful to the patient community, that investors know that the patient community's voice is central and that we are dead set on keeping our feet on the accelerator. And most importantly, we heard Amy just talking about this, that we want consistency, we want predictability, and we want transparency in decision makings. So this is just, I'm not going to go through the whole thing, and I'm hoping these slides will be available to everybody. But it's been a little bit of a wild year. It's quite a climate in Washington right now and around the US, and it's quite a dynamic environment. And I just put this together last night in the room, or yesterday in the room, and this is just a little timeline of what our community, and you guys have been very well represented in this with the leadership of your PAGs, and many of you in the room have participated in this, has achieved together. And I think we should all be really proud of this work, that the rare disease community's voice we had for the first time landmark hearings and White House forums just a year ago, so I actually went back a little bit further than a year to make sure people knew that. In January, we actually had the first, I don't even have it up here, cell and gene therapy forum at the White House. So we are on the map in a way that we've never been before. And actually just last week, there was what we believe will be the only public health hearing of the Energy and Commerce Committee, and newborn screening was prioritized at that hearing, and there was a lot of discussion about newborn screening and for rare disease in particular. So there have been a lot of wins for our community. Now, there are also a lot of threats for our community, and there are things that we can do about it. One of them being that when H.R. 1 passed just about 2 weeks ago, it contains threats to our Medicaid program. And we know that we have about a 50% Medicaid eligible patient community. And so there is much we can do to advocate to protect coverage for our community, but it's going to take everyone here who cares about Medicaid to be engaged in that. So this is a lot of information, and there's a lot of information coming at us every single day, all the time. So if you're like me and you feel like you're sipping out of a fire hose every time you open the news on your phone, and you're not really sure where to begin, you're interested in advocacy or you're interested in engaging, but you don't know how, I would think about it this way. So if you're concerned about your health coverage or the health coverage of someone you love, I would think about Medicaid advocacy. That would be a place to begin. If you're concerned about therapeutic development and momentum around therapeutic development, there are two key issues I would point to, and I would think about engaging around them. One is the reauthorization of something called the Rare Disease Pediatric Priority Review Voucher. And I have a couple slides in this deck, and I won't, for the sake of time, go through them all, but they're in here for when they're shared. And when I see you at Advocacy Day on the Hill in September, we'll go through them in more detail. But that is a critical incentive for therapeutic development in rare disease, and especially for a lot of the companies working in this space, that did not get reauthorized at the end of last year. And we will have a very critical window in September to get that work done between September and the end of the year. So now is the time for us to get that drumbeat going again. And we will be leading a lot of work around that, and we need this community to help us lean in on that. Biomedical and federal research funding. We are watching that funding disappear. There are proposals to cut it even further. We cannot afford to see that happen. The mighty voice of the patient community is making an impact on the Hill, but we need to keep that going. Again, we have opportunities to do that. If you're passionate about transitioning from pediatrics to adult, there are transition policy efforts underway. If you are passionate about diagnostics, we just heard a great discussion around why diagnosis and specific diagnosis matters. There is much work underway. If you're interested in serving as a patient representative on a federal advisory committee, a drug safety board, an advisory board with a company, there are training programs for that. We actually have a couple of them at Every Life. There are a number of organizations that do. One of them in particular is geared towards young adults. A couple of our federal agencies are looking specifically for young adults to serve on these, including the Department of Defense, their congressionally directed medical research program. And so we have training programs tailored for anybody, and then one just for young adults. Okay, I'm gonna skip through a couple of these slides, but I put them in there so they'd be made available. But this is a nice tutorial about the PRV program. And I'm just gonna show this. These are all the disease spaces that have had therapeutic approvals because of the PRV. Yeah, I think we can applaud this. We need the PRV. So if you're looking for an issue to engage in, we need the PRV. The Creating Hope Act must be passed. Medicaid. If you care about Medicaid, there are lots of ways to engage in Medicaid, both at the state and federal level, and I included on the slide where you can get involved. We wrote a guide in how to engage in rare disease therapeutic development. In this guide, there are resources for sponsors and resources for patient groups. And everything in this guide is linked to the original sources and the guidances. Find our guide. And if you would like to learn more, or you want to be in touch, please connect with me and our organization. We would love to be connected with you. Thank you.
Thank you so much, Annie, for your guidance and your leadership in the space, and just showing what we can do together as a community if we all step up and advocate. There's a lot of change that's needed. So Kat, who needs no introduction, is going to come up or speak for just a minute here to tell you how you can get involved right away and about our LGMD Day on the Hill.
Thank you, Annie. That was wonderful. Whether you live with Limb-Girdle or you love someone who does, or are simply passionate about making a change happen, I want to talk to you about something that really, truly will make a difference. And you can be a part of LGMD Day on the Hill, September 9th. Today, we actually have a sign-up table out in the lobby. As soon as you leave here, you can go to the speak table. There's a QR code, and you can sign up. The deadline to sign up to become a delegate is July 22nd. We don't want you to miss this opportunity. If you live in the United States, these issues matter to you. If you live globally and you're outside of the US and you still want to be a part of advocacy work, you can. In October, we're going to bring together all of the Limb-Girdle organizations outside of the US for a global advocacy meeting. And that's where we will be talking about how are advocacy issues in your country affecting you. So you don't have to have a background in advocacy or healthcare to become an advocate. You just need your voice, and all you need to do is tell your story. And LGMD Down the Hill is one day that you can participate in. But I want to direct you towards EverLife, because also I think the programs they have are phenomenal. Rare Across America allows you to be in your home and still an advocate. So you can go locally. You don't have to get on a plane. You don't have to travel anywhere. They will, am I correct? Yeah, they will put this all together for you so that you can be an advocate in your own home. We will do some online advocacy work through LGMD Down the Hill. If you can't be there, we'll help you to do those types of things. But I just think if you're going to get involved, I think EverLife is a great organization for advocacy, and Annie Kennedy is just a hero, and everybody respects her. Everybody knows that she's the real deal, and I think you guys can trust her that she's going to represent you. And then I also feel like you ought to know more about what MDA is doing in their advocacy work. I think they're doing a phenomenal job, and we're all pretty much a part of EverLife and MDA's advocacy work as well. And then we have our own special day, LGMD Down the Hill, and our own advocacy stuff that we're doing separately. But please get involved, go outside, sign up. We want to see you at Hill Day. Thank you.
Okay, there was a scheduled break, but in the interest of time, we're going to go ahead and move forward to our emergent treatments session. So if we could have session 9 come up to the podium to get started. Thank you.
All right, hi everybody, and welcome to session 9. This session is about emerging treatments. I actually was the chair of this session 2 years ago in DC, and it's one of my favorites because this gives you a sneak peek into what hopefully in a few years we'll be presenting during the clinical trials session. So this is really early work, but very exciting, and we have 4 excellent speakers. Our first speaker is Dr. Simone Spuler. She is a researcher and clinician. She's a professor of myology at Charity Hospital in Berlin, and she will talk about stem cells and gene editing.
So how do I proceed with the, yeah. This is the one? Okay, thank you, Jen. Thank you for the organizers for inviting me. I'm really honored to be able to speak here. So I will talk about primary human muscle stem cells as an advanced therapeutic medicinal product in the treatment of LGMDs. So we are working on clinical application in this untreatable group of diseases, and our approach towards gene repair in limb-girdle muscular dystrophies is outlined here. So we are working on a local approach in an autologous manner. That means that we isolate primary human muscle stem cells that are all inherent to our muscles. We isolate and we purify them. Then we correct in the stem cells, we correct the mutation that is causing the disease, and then taking the healthy, again, repaired myoblasts to re-inject these into patients. So muscle, as it's known now for 15 years, only can regenerate if muscle stem cells are present. Without muscle stem cells, only having present the myofibers, no muscle regeneration is possible because muscle fibers are not able to divide anymore. They are, as we call it, post-mitotic. So it's the green cell, it's a satellite cell that has the marker PAC7 that is able to actually regenerate muscle. And this is shown below. And so the activation signal for a satellite cell is some sort of an injury. You can have the injury by trauma, you can have the injury by very, very heavy exercise, or you have the injury by a disease that is causing the destruction of individual muscle fibers. So once the satellite cell gets activated, it starts to divide. And then what you see, and in stem cell research, this is called an asymmetric proliferation. You see cells that are able to fuse with existing muscle, and you're also having a small proportion of these cells that go back into the stem cell state. So they become quiescent, and they are ready to regenerate muscle in a later further injury. So here you apply something to muscle that over time will increase the percentage of healthy muscle towards diseased muscle. Okay, so people know this for a little while, but it's difficult to work with these satellite cells. Satellite cells are scarce, and they like to hide themselves, and it's difficult to isolate them. Once you have them in tissue culture, they divide for a while, but what they also do, they divide rapidly, and then they grow old, as we all do. So they go into senescence, and then they stop being regenerative. So the aim, if you want to use these cells for regenerative therapy, you need to keep these cells young, and you need to keep them in a regenerative state, because once they have fused or once they are senescent or old, they will not do any good for the cell or for the muscle anymore. And this is how the cells look. This is just to give you an impression. I think they are quite pretty. So the desmin shows that the cell is actually a myogenic cell. It's a muscle cell. And the Ki67 marker is useful to show that these cells are still able, it's the red one, that the cells are still able to proliferate, to divide, to actually regenerate muscle. And so this is how it looks when we look through the microscope. Okay, so now we focus our therapeutic efforts to LGMDs, and we have been working over the last years on the calpain-3 gene, on the alpha-sarcoglycan gene, and also on the dysferlin gene. And we also focus on so-called founder mutations. You all know, and you have heard during the last days, that many different mutations can cause these diseases. But in each of the genes, you do find mutations that are more frequent than others. And since there needs to be a rationale for using certain or working on certain mutations, we decided that it would make sense to work on mutations that are more frequent than others. And this is a list of mutations that are frequent in the population and that also can be repaired by new mechanisms that I will come to in a second. So it's about the calpain gene, it's about the alpha-sarcoglycan gene, dysferlin, and there's also a dystrophin gene mutation that we can correct quite efficiently now. Okay, now, since we have been able to repair some of these mutations, and here this is an example of why I'm saying we are working on frequent mutations. So we are here. I'm focusing on the calpain deficiency, LGMD-R1, and LGMD-R3, which is caused by alpha-sarcoglycan deficiency. So when we look at one single mutation, and this is a calpain-3. It's called 550 del A. The del stands for the word deletion, and the A for a single nucleotide, an adenine. So it's a single nucleotide missing in this entire calpain gene, which causes muscular dystrophy. I think this is just unbelievable by itself. And 40% of the LGMD-R1 patients, at least that we see in Germany, are carrying this single mutation. And people in the surrounding countries around Germany, there we see that the mutation is also frequent. Talking to Jen, I know that this is also quite frequent here in the US. In the alpha-sarcoglycan situation, we have two mutations, which are the 229 and the 739. So these are the spots in the gene, and these two mutations together make up of 60% of all patients that are suffering from alpha-sarcoglycan deficiency. So I think you can understand why we focus on these mutations. And so we are working towards two clinical trials, and the first one that is on LGMD-R1 is called the DELI 550, and of course you can imagine it's because it's a DEL A, so it's DELI 550, and the other one is called the DUAL-R3 trial. We are working with this new tool, which is called, the gene scissors when it comes to the lay press, but it's called the CRISPR-Cas tools, tools that have been developed about 10 years ago and that allow gene modification and gene editing in a way and an efficiency that has not been known before. So it's a completely new development, and it's very nice to be able to use these tools to repair and edit mutations. And in the last years, there has been a development. There is not only the CRISPR-Cas9 that is now probably a common term for you to use, but there has been further development. There is something that is called the base editor. So when we talk about the two trials, the DELI 550 and the Dual R3, we are also talking about two different gene editing tools. Both are related to the CRISPR. CRISPR-Cas9, the classical one, will be used to correct the 550 delay mutation, and this is given on a molecular level, as shown on the right. The Cas9 just cuts the DNA and repairs the DNA on exactly the right spot, inserting the missing A, and so this causes the sequence of the gene to become wild type again. In the Dual R3 trial on alpha-sarcoglycan, we are using a so-called base editor. It appears that the base editor might be not as dangerous to the DNA because it doesn't cut the DNA. So you have more forceps that is taking away one molecule of the double-strand DNA and then replaces it with another molecule. And so we do not cut the DNA, which potentially could be harmful. So here we have two different approaches. Now you can imagine that, dealing with DNA, talking about cutting DNA, taking with the forceps away certain molecules and replacing them with others, that there are safety issues that need to be addressed. And so we went to our regulatory agency. In Europe, it's the EMA, and in Germany, it's called the Paul-Ehrlich Institute, but they work closely together with the FDA, and there are not major differences between the one or the other regulatory agency. So they gave us a lot of homework to do. So here, but I'm sorry I missed to talk about this, but this is just the data, the original data that show that both of the mutations, the 550 delay for the calpain and the two mutations in the LGMD R3 that can be efficiently repaired on a percentage that is way above 60%, and usually we can repair 80% of the stem cells back to wild type. And the pictures that are shown here show that the protein is nicely expressed and also in a high and normal level compared to healthy controls. Okay, now I come back to the safety issue, because this is really something that concerns the regulatory agencies and, of course, also our lab. So this is the homework we had to do. It's probably not really comprehensible to you, but it just shows you in each of the squares there is a lot of work, and we worked on this for about 2.5 years to be as sure as one can be that we are not doing harm by our gene editing approaches. If you want to imagine what could happen, so if you go with a scissor into the genome, you may cut at the right point, and this is called the on target, and this is what is desired, but also there might be a mistake, and you do some manipulation on a spot in the genome which you really didn't intend to. And there, this is where the homework started, and you can do a lot of bioinformatics. You can target this question by bioinformatic tools, and there are wonderful programs which predict, where potential harm can be done. But you also have to go into the lab and really do pipetting, so wet lab experiments, and here the right method is called the GuideSeq. And so we combined both and looked for each of these mutations for all possible so-called off-targets. So the off-target analysis was completed, and we were quite happy because it took a lot of money, a lot of time, and but now we went back to our regulatory agency just 2 or 3 weeks ago, and they weren't happy yet. So we need to go back. It's probably another year of work, but they wanted a couple of more tests, and you can imagine that this technique is developing as quick as the CRISPR knowledge is developing. So it's not a surprise that what we heard about 3 years ago is not valid anymore, to 100%. So now they came up with new ideas, and of course we will follow that, but soon we will be ready. And so far we can say that it has not been that there has not been a risk that was implemented by this gene editing approaches. And some of the technical terms that can be addressed here for those of you who are a little bit more in the molecular aspects here, you have to anchor, you have to tell the molecules, the gene scissor, you have to tell them where to go in the gene. It's like a navigator in the car, you have to put in an address. And if you put a loose address, if you just say State Street, house number 100, and nobody knows where this State Street is supposed to be, then you will have a lot of different and wrong possibilities. But if you have a specific number and a specific state and city, then there will be only one aim. And this can be reached in the molecular sense with an PUM, with a certain address that is really well defined and not something that we call loose, where you can go anywhere and you will hit it and you will hit the right one, but you also will hit a lot of wrong addresses. And we made sure that with an NGG PUM we have something that is really specifically addressed. And this is how the data look then when we talk about safety and off-target. We want to make sure that repeated experiment really show exactly the same picture, that it's not a lot of variety that we see, and that we do not identify targets that are potentially harmful. Okay, now, this is a question that every patient and everybody else is asking immediately. So what does take so long? And why do you not, just start with the trial? So I talked about off-target, I talked about safety, I talked about the regulatory agencies, but just to make you understand what it takes, to run this trial, and, we are a research group, we have a small startup, it's called Myopax, and so there are not thousands of people, of course, working on that. So first of all, we need to convince people that it's really worthwhile to run this trial, and this is really something new and a new approach, and we need to secure finances. And now for the dual R3 and also for the DALI 550 trial, we were able in the first quarter of 2025 for each of the trials to secure as much money as we need to really start the trial. And so this is a little bit more than $1 million for each trial. This will not allow us to run it all the way through, but it does give us the possibility to really get started in a serious manner. So then, when we have the, without the money, you don't even need to bother about, dreaming about the future. So then we need to identify a facility that is able to produce these cells under clean room conditions. We call this GMP. It's good manufacturing practice. There is no lab in the world that knows exactly how to produce satellite cells and to do genetic editing under clean room conditions. So we have to teach them, and they have to prove to the FDA that they are able to do that. You call this validation runs, and the validation runs, they need to work, and they have to be consistent. You can't come up with a result on Monday that's different from the one on Wednesday, then you will never get this product to the patient. And then we need to go to the regulatory agencies, back to them, show them all the data we have on safety, on the validation of the manufacturing process, and only then the clinical trial can start. So here, when you look at the timeline, now I would say finances are as secured as they can be at time point zero, and in about 2.5 years, and I hope I'm not too optimistic here, we will start with a recruitment. And this is, and I know my colleagues already told me that, Simone, you are just too optimistic again. This may take even longer. Don't be, don't say anything that you cannot, don't promise anything that you cannot fulfill. But 2.5 years, I think, is realistic. We did learn a lot of how to accelerate this a bit, but we'll see. So just to give you an idea of, when can we really get started. And this is the group, and you see the sunshine in the horizon, a little bit stormy on top of us, but this is exactly how our work is going and proceeding, and we think that we will have good results that we hopefully do not harm, and all the agencies and everybody who supported our work so far is listed here on the right, and I thank you for attention.
Thank you so much, Dr. Spuler. Our next speaker is Mohan Viswanathan. He is a research scientist at MIT, and he's going to be talking about repurposing therapies.
Thank you. I'd like to thank everybody thanks everybody for showing up today. So where's our pointer? Oh, is it? Okay, sorry.
You could advance, but you can't.
Oh, yeah, no, I'm advancing, but. Am I not doing that? Oh, there we go. So today I'm going to tell you a little bit about a journey that I've been on for over a decade, and the culmination, or recent culmination, of a lot of hard work and effort on a number of people's part who I'll acknowledge at the end. So today I'm going to tell you about our drug discovery pipeline that we've been working on and developing, and a drug that we have identified that we think might be useful for therapeutic purposes for people with dysferlinopathy, also known as LGMD 2B and R2. But I'm going to call it dysferlinopathy for the rest of this talk, because I think it's really important for everybody to have a handle on what the genetics of their mutations are and the etiology of their disease. Okay, so just a quick overview of what happens when you have dysferlinopathy. You have a mutation, a loss of function in dysferlin, and this loss of function results in an inability to repair plasma membrane damage. And plasma membrane in muscle is called sarcolemma, so I can use that interchangeably, either plasma membrane or sarcolemmal damage. And so in this cartoon diagram that Liz McNally did in 2009, it's still holding pretty well up over time. You see dysferlin, and what dysferlin does is to repair membrane damage. So eccentric muscle contraction, things that put tensile forces on your muscles will rip the membrane. And when the membrane rips, it's a potential for death of their muscle cell. So when the membrane rips, calcium flows in. There's a low amount of calcium on the inside of the cell, higher on the outside. And that calcium coming in is a location marker for where the tear is. And what dysferlin does is it grabs these membranous vesicles, they're just below the skeletal muscle membrane, and fuses them, sealing the breach. And this is what happens very quickly in people without dysferlinopathy. So unfortunately, if you have loss of function mutations in dysferlin, you get LGMD 2B and dystrophic muscle phenotypes such as inflammation. You have incomplete muscle regeneration. You have massive fat replacement, muscle weakness, and eventually loss of ambulation for many patients. Okay, so we talked about a lot of different therapies in this past few days, and we're sort of on the work that we're doing is sort of on the cusp of a few of these. Very important to our work is personalized medicine. So, you know, how many people out there know they have a missense mutation in their gene? Just raise your hand if you know you have a missense mutation. And hopefully you all know what missense mutations are. If you don't, I'll tell you shortly. And the second class of sort of emerging therapies that we're interested in is this idea of chemical chaperones. So these are small chemicals that can be introduced in the body. And what the hope is they'll restore your mutant protein that's made in your cells if you have missense mutations back to where they belong, and hopefully to functionality. So we're trying to fool the body into allowing these proteins that normally it doesn't want to persist, and if they can, to function. Okay, so let's talk about chemical chaperones and personalized medicine. So when proteins are made in your body, they're translated from RNA into into a chain of amino acids that are folded. These proteins have to assume a three-dimensional structure often, or always, to be enzymatically or to be active or functionally active. So they fold properly and then they're functional. But if a protein misfolds, and there are a lot of reasons this happens. In fact, as you age, it's, the proteostasis network is what they try to describe protein folding in cells. That starts to break down as you get older. And so you get more protein misfolding. But these misfolded proteins can be bad for the cell, and so what it does is tied to destroy those misfolded proteins and degrade them or to include them into aggregates. And sometimes you see these in many aggregation-prone diseases. Okay, so let's talk about missense mutations. This is the personalized medicine aspects of it. So for those of you who know that you have missense mutations, that's great. Everybody should know what their mutation type is. So I'm using here demonstrating a mutation that is very important in my talk. And also thanks to Simone, who very generously created a mouse model with this particular mutation that's really helped us go forth with our research. So there's in humans and normal humans with human beings with normal copies of dysferlin, at position 1341, there's a lysine residue. And in dysferlinopathy patients, there's a mutant copy, and instead of the lysine, it's coded for by a proline. So the lysine residue makes a normal protein, it's folded, it goes and it gets trafficked, and it gets to the membrane surface. Okay, so, but in a dysferlinopathy patient, or mice that have a homolog of this mutation, the protein is unstable. It can form aggregates. It also gets rapidly degraded and never makes its way to the membrane surface. It's not there to do membrane repair. So our idea is, well, what if we fool the cell into not destroying this protein, get it to the membrane surface where it can be functional? Okay, so here's within that context of proteostasis in the cell, missense mutations can lead to unfolded and unstable proteins. And we think for dysferlinopathy, about 30 to 40% of the patients have missense mutations. And we know that for almost all dysferlinopathy patients, the protein is virtually absent from the cells. Okay, and that includes all the missense mutations. So a lot of them are being destroyed. Okay, so what is the hope for chemical chaperone therapies? So again, I told you, they're small molecules. They're thought to bind to the mutant protein, prevent their degradation, make sure they get to the correct organelle or the right surface. So there are a number of diseases that are currently being treated with chaperone protein, but I'm going to focus on one because I want to demonstrate how this idea of refolding a protein and getting it to the proper place and working is this proof of principle. And that's for cystic fibrosis. And this patients with cystic fibrosis, it affects their lungs, and it affects the cystic fibrosis transmembrane receptor. And there's a company called Vertex Pharmaceuticals that's been very successful in identifying and developing chemical chaperones for CFTR, or for CF patients. Okay, so here's a big slide that kind of does a synopsis of what Vertex has done. So CF is an autosomal recessive disease similar to dysferlinopathy and many LGMDs. And in the case of CFTR, it's an ion channel. It regulates salt and fluid in the lungs. And Vertex has several FDA-approved compounds, and they're all chemical chaperones. And to date, there's about 68,000 CF patients worldwide, and Vertex is making $9 to $11 billion in revenue on these chaperone molecules. So let's dip our toe into this water, shall we? So there are there's 6 different compounds I've listed up here. All of them have chaperone-like activity. The first ones that were discovered by Vertex were ivacaftor and deutericaftor. Caftor just stands for cystic fibrosis transmembrane receptor. So all of them seem to have that suffix at the end, and they have unusual names. But ivacaftor and deutericaftor were able to bind to CFTR and increase its ion flow. And then they came up with these other chemical chaperones that are able to bind to CFTR and not only So they bind to CFTR, but they make sure it gets to the membrane surface. This is very familiar, right? This is kind of what we want to do with dysferlin. So in addition to those individual drugs, they can now make combination drugs. So there's lumacaftor and ivacaftor that make a combi. And if you notice below each one, I've showed you how many different missense mutations each of these combination drugs can do. So this is sort of the idea that we have in developing a therapy for dysferlinopathy and perhaps other LGMDs as well. So in the drug discovery pipeline, you develop assays, you screen compounds, you find hits, you promote hits to leads, you do lead optimization, you take those compounds and you try to make them the best compounds you can in preclinical trials before you get them into patients. This is an oversimplification. Many people here know much more than I do about this. So this is a fun part of the story. So I'm a geneticist. I'm a model organism geneticist. And when I started working on dysferlin, I worked on a roundworm, a microscopic nematode that's found in the soil called C. elegans. Now, the Nobel Prize has been won several times for research in this organism. And we use it as a screening tool for drugs. Turns out that dysferlin is highly conserved evolutionarily, and it's found in C. elegans, but it's found in the sperm of C. elegans. So in humans, it's in skeletal muscles, and in C. elegans, it's in sperm. But it works the same way. It's involved in membrane fusion events. So here you see the sperm of C. elegans, and what happens is there's a calcium-dependent signal that causes a membrane fusion event. And when that membrane fusion occurs, the sperm develop and are fertilization competent. So we have these mutations in C. elegans in a dysferlin homolog, and at a particular temperature, the TS mutations that are missense mutations in C. elegans. And at a non-permissive temperature, they're sterile. So we did the screen and just looked for compounds that could restore fertility. And we could do this in 96-well format, and we screened 80,000 compounds. So in the absence of dysferlin, it's no progeny. If you have a hit compound, it restores fertility. And we found a number of compounds that could restore fertility in C. elegans. So this is one arm of our pathway. We have a number of novel chemical entities that are able to restore this homolog of dysferlin. But I'm here to tell you that we've tested some of these compounds in our human in vitro systems that I'm about to describe, and they're active. Okay, so this is the beginning of our pipeline. Here's our second screening platform. Basically what we did, and much of this is funded by the Jane Foundation, we modeled 113 different dysferlin patient mutations into cells, okay, that don't express dysferlin. And we are able to determine whether these mutations get to the membrane surface or not. We know that they're all pathogenic, or we believe that almost all of them are pathogenic when they gave us a list. And in this system, we were able to identify 64 mutations using a method of analysis called flow cytometry. So we could see whether dysferlin got to the membrane surface. And we found 64 different mutations where it never did. And we were able to turn this into a screening platform. So we're asking for compounds that, in the presence of the compound, can we get dysferlin to go to the membrane surface? Oops, Anyway, I can tell you that we found 25 different missense mutations. Okay, can we go back one? Sorry, is that possible? Okay, it's not. So we found 25 different patient mutations okay, I missed this point in the last slide, is that in developing these kind of assays, we needed a control. And we chose a chemical chaperone because of our knowledge of what happened in C. elegans already in the roundworm. We chose this chemical chaperone as a control. And it turned out that that control worked pretty well. And it worked on 25 different patient mutations. Not only did it get the mutations to the membrane surface, one of the strongest hits we got was to a mouse model that Simone created of a missense mutation in dysferlin. And using this mouse model, we were able to dose the animals with 4-PBA and examine their ability to repair muscle. And both in explanted muscles that we treat in Petri dishes, and from mouse that were given for PBA, we could see restoration of membrane repair in a number of these mutations. Okay, so what is sodium 4-PBA? What is this drug? Well, lo and behold, it's an FDA-approved compound, and it's used to treat urea cycle disorders. So it's been prescribed to patients for over 20 years. And what it does in urea cycle disorder patients is it acts as a sink for ammonia. So urea cycle disorder patients have mutations in one of 7 genes. There are 5 predominant ones that are involved in the urea cycle that you see here. Any mutation in one of those 5 will lead to urea cycle and a buildup of ammonia. Well, it turns out that 4-PBA is a drug that acts as a sink for ammonia. So those are the genes. I'm just going to skip that. So this is what 4-PBA does sort of chemically. The drug is called buphonal. That's what most patients take. The drug is broken down in the body, and ammonia in the form of glutamine. So ammonia gets converted to glutamine. It gets picked up by the breakdown product of the drug, and then it's excreted by the kidneys. So patients who take this drug take up to 20 grams of it a day. So they just eat it. They put it in their juice, they eat it with their cereal, they have it for breakfast, lunch, and dinner. But it's a life-saving drug. Typically, they test children for ammonia levels when they're born, so the determination of urea cycle disorder is made very early, and those children are put on the drugs and into adulthood. So we've developed these assays. We've got a hit for PBA, and it's FDA approved. And now we started doing preclinical trials. And so I'm going to show you a quick video of what the mouse that Simone created that she allowed us to import it into MIT for us to use as a model for our preclinical work. So as I said, this is one of the strongest alleles that 4-PBA worked on in our assays. And see on the left, you'll see the mouse crossing an inclined beam, and we measure crossing time. So this is a wild-type mouse, and this is a MEX38 mouse with an L1460P mutation, which is the homolog of what's mutated in humans. And as you see, as the mouse gets closer to the end, it has trouble, and it has footfalls, and it takes longer for the mouse to get in. So these are about 1-year-old mice with LGMD2B. Okay. So in wild-type mice, when you stain them for dysferlin, you take a cross-section of the muscle, you stain for dysferlin, you see this classical sarcolemmal staining pattern. Okay, so we can see that happens in wild-type animals. But in dysferlinopathy mice, what you see on the top of the screen, you see background staining. Okay, this background staining is just it's called the secondary antibody control. You can ignore it for now. But what you can see is that there's no dysferlin staining with these MEX38 mice that are treated with just water. But MEX38 mice that are given 4-PBA, you can see dysferlin restored to the membrane surface. Okay. When we look at membrane repair, what we do is we explant muscle and we shoot them with a laser beam to create a wound on the muscle, and we track a dye that's otherwise membrane impermeant. So if you don't have damage, it doesn't go in. When you create damage, it does. So this is what happens in MEX38 mice that are just given water. We laser wound, and you can see that the dye goes in and it doesn't get occluded. These are MEX38 mice that have been drinking 4-PBA for a year. You can see the damage. You see that photo bleaching, but it reseals instantly. So we took these mice at the end of the year. We did those kind of experiments with the histology and the membrane repair. But we just looked at just simple muscle weight, and we could see a significant increase in muscle weight in much of the affected muscles in the hind limbs of the mouse. So in the quadriceps, the EDL, the psoas, and the glutes, we see a pretty significant increase in the weight of these muscles. It's not back to wild-type levels, but we see muscle increase. So when we look at balance beam performance, we also see an improvement. So there are different beam widths. I'm sorry, that doesn't look so great on here, but there are different beam widths, and we can track how they perform on each beam width. And what we're able to show is there's a statistically significant improvement in their ability to cross these beams after a year on drugs. And I should say, we just started at a single dose. We really needed to know fast. We didn't do a lot of dose response experiments. This was a whole year assay at a single dose. So part of our next set of experiments is to work on dosing. So, we've done these preclinical studies, and we see efficacy in many levels. We think we can get them higher and better, and so we're working on those before we start talking about getting these into patients, because we'd like to establish some more knowledge about what's happening to the drug in the body of the mice, and if we can get the greatest improvement in the dystrophic phenotypes. And with that, I'd like to acknowledge the number of people who work on this in our lab: Eric Williams, Maddie McGee, Heidi Herbawi, and our amazing dissection person, Wontek Chung, who's amazing at doing muscle dissections for us, as well as our funding agencies, especially the Jane Foundation, who have been supporting my work since 2009 on this project. And with that, I will thank you all, the meeting organizers, and there's a QR code if you want to reach out and talk about your particular mutations.
Thank you so much. I bet you all didn't think you were going to learn about worm sperm today, but you did. Our next speaker is Dr. Jeffrey Chamberlain. He's a professor of neurology and medical genetics and the Macau Endowed Chair for Muscular Dystrophy Research at the University of Washington. And he'll be talking about novel gene therapy for LGMD2I/R9.
Thank you, Jen. I appreciate the invitation to be able to attend this meeting. So what I thought I would do today is I'm going to just give a general overview of what is gene therapy for those of you that may not be that familiar with it. I realize many of you probably are quite familiar with it, so I hope it's not too basic here. But the point here is to introduce the concepts of gene therapy, to outline some of the problem areas. And these are areas that we think are in great need of improvement so that we can advance the safety and the effectiveness of gene therapies for a variety of different disorders. So gene therapy, of course, refers to using genes themselves as a form of medicine to deliver them into the body or to manipulate the structure of a gene. There's three general types of gene therapy that we've been hearing about. The most common one that's applied is called gene replacement therapy, where basically the defective gene is not causing problems, so you just have to bring in a replacement copy of that gene. There's gene knockdown therapy, where you're actually trying to shut down a defective gene that's causing problems. And then gene editing, as we heard about in Simone Spieler's talk, where you're trying to modify or repair a mutant gene. So, of course, mutations in genes, generally the effect of these mutations is to alter the function of a protein that is coded by that gene. Normally, a gene will make various amounts of different proteins that do different jobs inside the cell. Some mutations, again, will make a defective protein that may or may not work. Sometimes it causes harm, and other mutations just don't make a protein at all, and these types of mutations can lead to diseases. We typically designate inherited or genetic diseases into two classes. They're dominant mutations or dominantly inherited diseases. Those are the ones where the mutation leads to production of a protein or sometimes an RNA that comes off the gene that is actively causing problems in the cell. It's causing toxicity, or it's interfering with the normal way that a cell is supposed to behave. And I've outlined some of the different types of limb-girdle muscular dystrophies that are inherited in a dominant pattern. Other versions of mutations are recessively inherited, and when we talk about a recessive mutation or recessive inheritance, that's a mutation that simply shuts down a gene so that gene doesn't do anything at all. And again, with the recessive mutations, we can try to fix those with gene replacement, and again, I've outlined some of the different diseases that are recessively inherited. And what I'm going to talk about today is mainly limb-girdle muscular dystrophy R9, which encodes the FKRP gene. So as those of you that are familiar with FKRP and LGMD-R9, you know there are two ongoing gene therapy trials. One over in Europe, started by Adamayo, which is using a type of AAV called AAV9 to deliver FKRP. My understanding is they've dosed 6 patients to date and have not run into any serious adverse events and are starting to see some improvement. And then here in the U.S., AskBio is conducting another trial. They're currently doing dose escalations, and I'm not aware of any results of that trial that have yet to be released, but hopefully that'll be coming soon. What my group is interested in also developing gene replacement therapy for FKRP disorders. We're not yet at the clinical stage, but what we're focusing on now is trying to develop next generation vectors to, again, try to preemptively avoid some of the serious problems that have been seen in occasional gene therapy trials. And by doing that, we're designing new vectors. We're trying to get better and more well-controlled production of this missing FKRP protein, and we're doing that by also tweaking the so-called on-off switches that are in those vectors that lead to the production of FKRP. And I'll go through that in a little more detail here. So again, FKRP is a recessively inherited disorder, so the mutations typically cause the protein not to work well, so we think we can treat it by replacing the mutant FKRP with a normal version of that. So we need to design and synthesize, again, a gene therapy drug. So there's 3 major components that go into developing a gene therapy type drug. One, you need a delivery system. I sometimes call those shuttle vectors. It's like a shuttle bus. It takes your gene from the laboratory into the muscles where it needs to do its action. Currently, you know, we hear a lot in the gene therapy field, you've probably heard a lot about these so-called AAV vectors. Why is everyone using AAV? Well, the reason with muscle diseases, 40% of the human body is muscle. And to take a new gene and get it into muscles all over the body requires a very efficient gene delivery shuttle that will target those muscles. Right now, the only way we know to get genes into all the muscles in the body in an efficient manner is with these AAV vectors. Now, there's lots of other ways that people are trying to develop to do that. None of them are really at the level of effectiveness to target muscles all over the body. But an important area of research is to come up with alternatives to AAV, because AAV has obviously caused some problems, particularly at the very high doses that is currently being applied in the clinic. Okay, so what do you put into these shuttle buses? You have to put in your new gene. In this case, with LGMD-R9, we're interested in putting in a new copy of an FKRP gene. But there's a lot of, it's easier said than done. You need to think about, do you want to put in the whole gene or just parts of the gene? Can you put in multiple copies of that gene? Do you use just the normal version of the gene, or can you enhance the structure of that gene to make it work even better than the normal one does? And you need to think about how much do you need in all the different types of muscles, particularly your limb muscles versus the heart muscles. Sometimes if you make too much of a protein in the heart relative to the amount in a limb muscle, that can cause problems. So you need to balance the amount of the protein you make in different types of muscles. And the way you do that is with these so-called on-off switches that are called promoters. And different promoters are turned on and they activate a gene in different cell types in the body. Some promoters work in all muscles, some only work in your limb muscles, some only work in the heart. Others only work in liver or kidney or things like that. So we've been spending many years developing new promoters that will work only in muscle, and we've got a whole set of them that we've been comparing that have different amounts of activity in different types of muscles throughout your body. And the way you put all that together is shown in this little cartoon at the bottom. This is a diagram of an AAV vector. The AAV is a naturally occurring human virus, adeno-associated virus. The way you make these AAV shuttles is you remove all the viral genes, except for a teeny piece at each end that doesn't make for any virus proteins, but it's important to produce these shuttles. So you just have a teeny little bit of the AAV, and you replace all the normal parts of the virus with your gene of interest, your artificial promoter, your FKRP gene in this case, and then you have to put in a little signal at the end that we sometimes call a stop sign or a poly-A site, which tells the cellular machinery that it's reached the end of the gene. So again, how do you deliver these? Why do we use AAV vectors? Well, this is an example of an experiment that we did in my lab about 20 years ago. At that time, we had no idea how to get genes into the muscles all over the body. And a great postdoc in my lab, Paul Grigorovich, who's now down in Australia, realized that extremely high doses of infusion of AAV vectors could transfer new genes to all the muscles of the body. And that's an example shown here. This is just one muscle from a mouse that we infused with a high dose of an AAV vector and showed for the first time that you could target new genes body-wide. And that's now formed the basis for essentially all gene therapy trials going on worldwide for muscle diseases. This has worked well for a lot of disorders, but it can cause problems. It's difficult to regulate exactly how much you get in there, and it takes extremely high doses of the AAV to cause it to leak out of the blood vessels and enter the muscle cells. And it's these high doses that are now starting to cause problems in some gene therapy trials. So we need ways around that. And one of the best way that I think a lot of people have thought of is to come up with new types of AAV vectors. All the naturally occurring AAVs, of which there's close to 100, have been tested, and they all need these extremely high doses. But a number of laboratories have come up with synthetic versions of AAV where they've modified the surface of the AAV, and there are some now that are getting in the muscle at doses about 10 times lower than all the ones that are currently in the clinic. And this is just an example of that. We've screened a number of these different AAVs that have come from a variety of different labs, particularly from Dirk Grimm's lab in Germany and Sharif Tabit-Bordbar's lab, who's at Kate Therapeutics. And I don't know if you can see in this graph here, we've shown what happens if you just inject a saline solution or AAV9, which is the most commonly used AAV. In this case, you see very little of the protein being produced, but these new so-called myotropic vectors make varying degrees in different muscle types. And AAV Myo1 and AAV Myo4A, at least in our hands, seem to be working best, and we've been switching over to those. I will say that one of these now has entered clinical trials by Solid Biosciences. They're the only company that has taken a myotropic vector and put it into a clinical trial, and their results were announced a few months ago. It's really astounding. They're getting much, much higher levels of gene transfer with this new system. So hopefully that's going to catch on and be transferred over to a lot of other disorders. The other thing I mentioned is we need these promoters or these on-off switches to work at the level we want them to. We want to be able to make a predicted amount of protein in the right muscle types. And for some diseases, like Duchenne muscular dystrophy, you really want to make your protein in all the muscles in the body. In other disorders, like with calpain-3 and with FKRP deficiencies, you really don't want to make much in the heart. So we've been working to design a lot of different promoters. This is a result of an actual 40-year collaboration with my colleague Steve Hauschka at the University of Washington. Steve has designed hundreds and hundreds of different promoters, and many of those are now being used in human clinical trials throughout the world. The newest one we call CK8, and that's currently being used again by Solid Biosciences. The problem with most of the ones that we've developed in our own laboratory is that they're very active in the heart as well as other muscles. So we've been collaborating with Melissa Spencer's lab at UCLA, together with her postdoc Ruby Goldstein de Salazar, who was here and had a poster still up over there, to try to find promoter elements, variants of the ones we've already have that will work very well in the limb muscles but be off in the heart. And we think we've got one now through Ruby's work here. And basically the idea here is that this is a new promoter element that makes very high levels of protein in all the limb muscles, including fast and slow limb muscles, but it's very, very low in the heart. And to my knowledge, this is the only promoter that works like that, and we're starting to move this into our FKRP vectors. The way we test those is fairly standard, the way a lot of people do. We put together these FKRP AAV vectors with different promoters, inject them into the tail vein of a mouse, which is the most easily accessible blood vessel in mice. And in this case, we typically look at older animals because we're interested in the ability to correct a disorder in somebody that already has the disease. Typically, if you go into a newborn mouse, you can prevent a disease from coming on. You get beautiful results, but but that doesn't necessarily translate in the real world to clinical results. So we typically try to age our mice out to 6 months to a year, sometimes 2 years of age, before applying the gene therapy to ask how does it work in a situation where you've already got this disease. And here's an example from this study. It's shown in the bottom, in the middle. Oh, and by the way, this is work done by a brilliant scientist in my lab, Dr. Hisham Tasfayat, where using a normal version of the FKRP gene, he can get very high levels of this protein being produced, but with a modified, enhanced version of it, we can often increase the amount of protein that's being made. Oops. Well, I skipped over, unfortunately, my last slide. Oh, here we go. Yeah, and this is just measuring the strength of the muscles. This is a mouse model that has FKRP deficiency. It was kindly provided to us by J.P. Laurent. And again, in the uninjected mice, we see very low levels of force, which is the amount of strength that the different muscles can develop. But in delivering two of these newer FKRP AAV vectors with the myotropic serotype, we're able to approach normal levels of strength even in these 1-year-old mice. So again, the way we've been optimizing, and we're continuing to optimize these vectors, is to find and identify the best and the safest promoter. We're trying to optimize the dose using newer types of AAV that can come in at least 10-fold lower doses than are currently being used in the clinic, and we're tweaking the design of the actual FKRP gene itself to maximize its activity. And we hope to be able to finish screening the different ones we're working on and start moving that into clinical trials in the future. So I just want to stop there, thank all the folks in my lab that did the work, and particularly I want to acknowledge the support from the LGMD 2I Fund, the Muscular Dystrophy Association, and Kinea Bio. Thank you.
Thank you, Dr. Chamberlain. Really exciting stuff. The final speaker for this session is Dr. Scott Wolf. He's professor at the UMass Chan Medical School, and he will be talking about prime editing.
Thank you all for hanging around for my talk, and thanks to the organizers for giving me a chance to speak today. So I'm going to give you an overview of some of the work we're doing to apply genome editing systems to LGMD R9 or 2I. You guys have heard from ML Biosolutions and AskBio today about FKRP, and Jeff talked about it as well, where it's an important enzyme for decorating alpha-dystroglycan, which is on the surface of cells, with sugar chains that interact with laminins to stabilize the interaction of muscle with the extracellular matrix. And so FKRP plays a critical role as an enzyme in this process. Patients with LGMD R9 have insufficient enzymatic activity for FKRP, and this leads to the sugar chains not being fully extended and subsequently progressive muscle damage over time that leads to the limb-girdle muscular dystrophy. So it's an autosomal recessive disorder, and as you heard also earlier today, that one of the most common missense mutations is a leucine 276 to isoleucine mutation, where over 90% of the patients in the population have this particular mutation. And so we're interested in using genome editing systems to precisely correct this mutation. And so there's a new type of genome editing system that's called a prime editor. And you can think about this as a word processor for the genome. So if your genome is a book and the chromosomes are chapters and genes are individual sentences on pages, the prime editor can go into a specific sentence on a specific page and find a misspelled word and go ahead and correct that, and so restore the information that's present in that sentence. And you can think about it restoring gene function. And so what is a prime editor molecularly? As I mentioned, we want to create a prime editor that will restore the correct sequence at L276I. With regards to what is a prime editor molecularly, it's a protein DNA complex. So the protein complex contains two enzymatic activities. In light blue, diagrammed is a Cas9 nickase that can break one strand of the DNA site-specifically at its target site. And then there's a polymerase called reverse transcriptase that can write things into the genome. Now, this is bound to an RNA called a prime editing guide RNA that contains a sequence at the 5' end of it that Watson-Crick base pairs with the genome and helps it define the proper address, as Simone was mentioning. And then at the 3' end has templates, a primer binding site, and regions that can write, that the reverse transcriptase can write into the genome to install a desired precise edit. And so prime editors can make insertions or deletions, or correct assertions or deletions, or change specific bases. And so once the next strand of DNA anneals to the genome, or to the template in the prime editor guide RNA, it can be extended by the reverse transcriptase to precisely write in a desired sequence. And then DNA repair enzymes can come in and incorporate that into the genome, and you have your desired edit to correct the target site. And one of the nice things about prime editors is they tend to have very low off-target rates because they're not making double-strand breaks in the genome, like Cas9 nuclease. So to correct L276I, there are two sequence elements that are recognized by the prime editor. One is a protospacer-associated motif, or PAM, that's recognized by the protein. And then there's Watson-Crick base pairing of the guide RNA with the protospacer, and this covers about 23 bases, so it gives a large degree of specificity, and that's how you have very precise editing without getting genotoxicity. Now, it makes a nick at the site in the genome, in this case where the magenta caret is shown, and then the reverse transcriptase can write in the correct sequence. In this case, it's in blue lowercase letters. We're writing in a change from A to C to restore the wild type leucine codon. And then we make a couple of other synonymous mutations, to the neighboring codon to increase the precision and rate of editing, but don't actually change the functional sequence that's read out when it's translated. And so for testing our prime editors to see if they're going to work, we collaborate with the Charlie Emerson's laboratory. So he's developed methods for taking patient cells. They can be fibroblasts that are taken from the arm. These can be reprogrammed into induced pluripotent cells. And then those pluripotent cells can be differentiated into myoblasts, which are sort of like muscle stem cells, and myotubes in vitro. And we can use these from patients to test the ability of the prime editor to restore the sequence. In this case, we have a patient that's donated cells that's homozygous for the FKRP L276 mutation. And so we can test our prime editor on these. And so we've evaluated the prime editor on, in two different types of cells, the imyoblasts that I mentioned to you previously, as well as a transformed cell line that's somewhat easier to edit, where we've installed the point mutation as well. And so our initial efforts to do prime editing gave us some precise correction, imyoblasts being the most relevant cells that we've addressed so far, but you can see the editing rates are really low. They're less than 10%. So then we went into optimization of the prime editor system, optimizing the PEG RNA as well as the protein. And in this just one example of where we've looked at various links with regards to the homology arm in the PEG RNA to define a length that was most effective. And you can see that 20 nucleotides was the most effective with regards to increasing the rate of correction of the L276I mutation. So I won't belabor all the steps that we went into with regards to optimizing the prime editing, but in the red bar for the imyoblasts, you can see we've increased the precise correction rate from less than 10% to about 50%. And so we've made great progress on this. And now the next steps are to move into patient myotubes in vitro to show that in essentially mimics of muscle cells that we can precisely correct this particular mutation. And then, as Simone mentioned, we need to do off-target analysis, which is to look at genotoxicity of these reagents in cells to make sure that they're not going to do damage at unwanted sites in the genome. And then we'll work on in vivo delivery of prime editing into muscle xenografts, of patient muscle xenografts to look for correction using a nanoparticle delivery system that I'll tell you a little bit more about in the context of some work we've been doing on LGMD R7, which is 2G, which is another gene that is defective in limb-girdle muscular dystrophy. It's called TCAP. And so in this case, we've been working on an in vivo in a mouse model of a TCAP that has an 8 base pair duplication in it. This mimics a common mutation in a subset of patients with this particular disorder. And we're interested in this case in delivering Cas9 nuclease, which makes a double-strand break, to target this duplication of the 8 base pair element and to see if we can remove that duplication or change the register of this duplication, because an 8 base pair duplication causes the gene to be out of frame, and so no protein is produced. And so we've been using the delivery system, a nanoparticle delivery system that's called lipid nanoparticles. And they're sort of like spheres of fat that you can put cargo inside. And they can fuse to cells, much like if you think about how if you have 2 soap bubbles that come together, they'll fuse into a larger sort of bubble, and one of the insides of both those bubbles come together. And so we've been applying this in the context of delivering these editing reagents either as protein RNA complexes or as mRNA with a guide RNA, using multiple doses in weekly occurrence through local injection into the hind limb of these animals, and then assaying for editing efficiency at 8 weeks. And what, unfortunately, the bars are not showing up very well, but the red bars are delivery of protein RNA complexes. The blue bars are delivery of mRNA, guide RNA complexes. And in one case, we've been able to achieve over 30% editing at the target site, and more than 50% of the edited alleles have restored reading frame. And these are muscle sections of TCAP null animals, except for the upper left-hand section, where we're staining with an antibody that's specific for the protein produced by TCAP, which is telethonin. So it turns the muscle yellow if the protein is expressed. And then the upper right-hand corner of the images, where the image is green, there's no TCAP being expressed. And then the sections below show treatments with various different Cas9 nucleases delivered by these lipid nanoparticles. And the one with the magenta rectangle around it is showing our most efficient system, where we get about 45% of the muscle fibers have restoration of TCAP expression. So overall, this looks promising, and we'd like to use these types of lipid nanoparticle systems to be able to test our prime editors for limb-girdle and muscular dystrophy 2I as well. And so what I've shown you is that we can use prime editing to efficiently correct FKRP L276I mutation. And this is sort of a first step towards moving this towards a therapeutic. But excitingly, once prime editing is developed to be efficient in skeletal muscle for one particular mutation, in principle, all you have to do is change the guide RNA, and then you can make personalized genome editors that can be applied to any particular mutation that is associated with genes that cause muscular dystrophy. And then we're working with lipid nanoparticles to do the delivery right now, locally in mice, to be able to study the efficacy of these prime editing reagents. But one of the technological advances that we still need to make is to move from local delivery, which is how we're delivering these reagents through lipid nanoparticles, to systemic delivery. We want to have a system where we can redose and essentially tune up the precise correction rate in skeletal muscle of patients to achieve a functional cure for these different muscular dystrophies. And then finally, I need to thank the many people who were associated with this work, Anya and Sukanya from my lab, who've worked on FKRP and TCAP respectively. I've had a great collaboration with Charlie Emerson for many years, and Dongcheng and Caitlin in his lab have worked on the FKRP and TCAP projects. Daniel Siegwart is a very talented scientist working at University of Texas Southwestern on lipid nanoparticles, who's given us these reagents, and Yu Hui and his lab has been instrumental in these studies. And then I collaborate with Keeler Klunk lab, and Greg Cox's lab has made the TCAP mouse that we've been using. He's been a great collaborator at Jackson UMaine. And then I have to thank the funding sources that have allowed these projects to move forward: the Cure LGMD2I Foundation, the LGMD2I Fund, the Muscular Dystrophy Association, and then the NIH just for general support of the lab. And then thank you guys for listening. I'd be happy to talk with you afterwards if you have any questions about genome editing. Thank you.
Thank you so much to all of our speakers. They're on time, and now we're going to have some closing remarks, so please stick around.
I'd like to take this opportunity to thank everyone who participated in this weekend's conference. I hope that you're all finding that it was an amazing experience. We never could have put on a conference like this without the support of our wonderful sponsors. An event like this takes a lot of planning, and there are a lot of costs, and there's a lot of organization that's involved to put on a conference of this quality. And this is a very unique conference because it is a patient-led conference. Everyone who is in our planning team either has a form of LGMD or is a parent of a child with LGMD or a caregiver. We do not use any professionals to help us put on this conference. It is truly unique in being a patient-led conference. We are extremely grateful to the Speak Foundation. The Speak Foundation is the center of this conference. They have been very generous over the years in helping to provide a very cost-effective conference that families can afford to attend. We know that to continue moving forward, we're going to be needing more assistance from our wonderful LGMD advocacy organizations, as well as the community.
So on my part, I'd like to say, first of all, thank you all for being here. As one person put it to me not long ago, in this current environment, and we heard, about some of the issues with gene therapy development, earlier in the conference. There's clearly a lot of challenges for our community, but there's a lot of opportunities for our community as well. And having all of you together at this conference demonstrates the strength of our community and the commitment of the patients and family members and supporters for making things happen, for finding treatments for our diseases. And we're going to have to do a lot of advocacy, not only for, in the political realm, but also drug developers. One of the things they want to know in which rare disease to work on is what is the strength of the advocacy community, how many patients are diagnosed with the disease, what is the knowledge of natural history, how ready is the community for clinical trials. I think we've made huge progress in all of those areas, and due to many of you participating in all of these endeavors. So thank you very much.
I'm not sure I can actually add anything more than what they said, but
truly drug developers and our community and researchers and clinicians and patient advocacy orgs, all of us together, we're an ecosystem, and we do rely upon each other because the community needs to be strong. And when I say that, the community of patient advocacy orgs coming together to establish this worldwide limb-girdle community, it's so critical. And we collaborate. The strength of limb-girdle muscular dystrophy is that we collaborate. We don't compete, and we're unified. And it's all of the organizations that work together to put this conference on. And when you see a community in rare disease world, it is extremely unusual to see this many organizations and this many subtypes that collaborate and work together in unison, really like a fine oiled machine. We all get along, we support each other, and we're not competitive. We really do work together, and it is really a beautiful community that we're a part of. And so when we talk about having these conferences in the future, we do need help. We need volunteers. We need financial support. We want to continue to provide this high level of conference for our families and our patients, and we're so glad that you came. So, call to action. If you want to be a part of what we're doing when we start our conference leadership team meetings, we're looking for event planners, people who are really highly organized, willing to be boots on the ground. If that's you, we would love for you to volunteer. we love that because we need that help as a patient-led conference. So wonderful time that we all had here. I appreciate every single one of you. Thank you for all that you have done this weekend. And most of all, I want to thank our speakers because they could have done a lot of other things over the weekend. They all took their time. They came and they served our community. And would you please just give a warm applause to them? And thank you lastly for our sponsors who made this happen, and that's ML Bio, Sarepta, and AskBio, who are our platinum sponsors, and our organizational sponsors as well, who have just been so generous. And Brad, did you want to say something else before we close?
I was just going to say that one of the things I particularly enjoyed these last 2 days was seeing all of the connections made between the attendees. You know, I know having a rare disease can be a very lonely and isolating experience. You know, if this is your first time meeting other, fellow patients, I hope you feel that you're part of a community and, that you don't have to deal with this alone.
That's right. So thank you all. Have a safe trip home.